signalni put koji najčešće izmene u ćelijama kancera. Zašto spominjamo i jak stat? Zato što dolazi do interpleja, crossovera ova 3 signalna puta, što jeste, u tome i treba tražiti uzroke rezistencije. Tako da jedni potencijalni kandidati uzroka rezistencije na target terapiju su znači neki drugi BRAF genetički mehanizmi kao što su amplifikacije, neke druge BRAF mutacije, znači treba gledati u to, MEK alteracije, znači nishodno mutacije koje se dešave od BRAF-a, pa koga blokiramo MEK i BRAF inhibitorom, nije važno jer se ćelija i dalje deli i postoji taj bypass, znači signal ERK fosforiliše akt i signal ćelija se nastoji da preživi, ćelija funkcioniše preko drugog signalnog puta. Znači već je dosta poznato o mehanizmima rezistencije. Šta kažu vodiči? Nisu se mnogo menjali za karcinom, za melanom u odnosu na pre par godina. Znači BRAF V600 je najčešća mutacija. Mi testiramo V600 kada dobijete rezultat, ne kažemo da je, jer postoji cross-reaktivnost sa DEK, sve su senzitivne na BRAF MEK inhibitore. Ono što hoću ovde da podcrtam da postoje podataka da i non-V600 mutacije koje se nalaze blizu kodona 600 takođe mogu biti osetljive na MEK inhibitore, a takođe i neke fuzije. Što znači upitna ostavlja da li je naša metoda dovoljna, pa verovatno nije, ali treba razmišljati o tim mutacijama koje su malo van tog regiona. NRAS mutacije rečeno korelišu sa slabim preživljavanjem i takođe mogu odgovoriti na MEK inhibitore i C-KIT mutacije kod akralnog i mukazalnog takođe se dešavaju na određenim hotspot mestima, znači lako ih je detektovati i mogu ukazati na senzitivnost na KIT inhibitore. Šta kaže ESMO vodič o upotrebi NGS-a kod solidnih tumora? 2020. godine, verovatno ste upoznati, pojavila se ova ESCAT skala, skala kliničke actionability, kliničke aktivnosti genetičkih alteracija za ko postoji lek, znači od tiera 1 do tier X. Tier 1 su naravno biomarkeri koji su uveliko u kliničkoj praksi, tier 2 koji su ispitivanjima i na osnovu toga su i klasifikovane genetičke varijante kao i tumori, solidni tumori kod kojih je na osnovu broja ovih varijanti neophodan NGS. Šta je novo u odnosu na 2020. godinu, a što naravno važi i za melanom, da postoji sve više takozvanih tumor agnostik biomarkera koje treba detektovati kod svih solidnih tumora. BRAF je od pre 2 godine tumor agnostik i za bilo koje oboljenje gde se detektuje postoji odobrena terapija BRAF MEK inhibitora. Tu su NTRK koji su retki, ali MSI, RET fuzije, TMB kao tumor mutational burden, MSI TMB kao prediktor odgovora na imunoterapiju, kao i alteracije u receptoru za fibroblastni faktor rasta. Sama preporuka ESMA za melanom nije direktna, znači pošto je to BRAF i NRAS se mogu lako uraditi real-time PCR-om kao što radimo, znači, ali ako bi radili NGS u kući, na primjer za karcinom pluća, što jeste neki sledeći korak, on bi naravno uključivao i sve gene koji se nalaze kod melanoma. Ovo je američko iskustvo, vrlo objavljena referenca, vrlo nedavno, gde vidite kako raste upotreba, odnosno primjena NGS-a za različite oboljenja. Očekivano za karcinom pluća plava linija je najviša, naravno zbog tog velikog broja alteracije koje ne možete detektovati single gene metodom 1 po 1, ali evo i za melanom je taj skok od 1,5 do 17,4%, verovatno zahvaljujući tim naporima da se otkriju mehanizmi rezistencije, kao i novim genima i tumor agnostik biomarkerima. Šta se traži od biomarkera? Takođe iskustvo lekara zavisno od stadijuma bolesti. U stadijumu 4 melanoma u svetu preovladava ipak NGS, znači metoda koja je sveobuhvatna, koja nam omogućava testiranje 100 i više gena u odnosu, ali kao što vidite, ova crna figurica, to je ipak i da taj single gene, kao što mi radimo, da rade dosta i bogate zemlje. Ono što je takođe karakteristično je da se najveći broj testiranja nudi za stadijume 3A do 4, gde je takođe i upotreba cirkulišuće tumorske DNK, naravno realno zbog njene mogućnosti da prati rezistenciju u realnom vremenu i da kaže odgovore o mehanizmu rezistencije i genetičkim alteracijama. Sama tečna biopsija o kojoj se mnogo priča, već u upotrebi, radimo i mi od 2016. za karcinom pluća, ono što treba reći da se njena količina u toku bolesti menja. Pa kao što vidite na ovom desnom grafu, u ranim stadijuma bolesti njena koncentracija je manja. Kada je ona manja, teže je izolovati i samim tim ti rezultati su manje pouzdani, pošto nismo sigurni da li smo izolovali ukupnu slobodnu DNK ili tumorsku DNK. U kasnim stadijuma bolesti nje ima dosta, zato je i upotreba njena već u vodičima za karcinom pluća kolorektalni, a u ranim fazama se tek pišu preporuke. Znači, direktna upotrebljivost tečne biopsije je uzrokovana njenom količinom kao i osetljivošću metode koja se koristi, o tome treba voditi računa i jeste to metoda izbora, jeste uzbudljivo, ali kada dobijete rezultat, kada se ne detektuje nijedna mutacija, to je upitno da li mi imamo u stvari rezultat slobodne ćelijske DNK. Kod melanoma postoje različiti pristupi, uglavnom imamo dva izvora tumorske DNK, jedno su ta cirkulišuća slobodna DNK i drugo su tumorske ćelije. Što se tiče klinike, upotrebi je cirkulišuća tumorska DNK, to je ono što mi radimo, lakše izolovati i tu naravno što se toga tiče treba koristiti vrlo osetljive metode, kao što je NGS, mi koristimo trenutno za pluća digitalni PCR, koji jeste vrlo osetljiv, ali opet je single gene analiza i naravno treba voditi račune o stadijumu bolesti. Znači, što je raniji stadijum bolesti, vidite ovde manje koncentracija DNK, metoda mora biti osetljivija u smislu da detektuje jedan molekul u 1000 wild type tipova. Takođe, ovde je konkretno metoda izbora za praćenje odgovora na terapiju. Ovde su prikazani pacijenti koji su primali BRAF/MEK inhibitore i vidite na ovom prvom grafu posle 6 meseci bez progresije bolesti kako ta cirkulišuća DNK, kako se daje terapija, ona pada. I znači u momentu imate taj molekularni odgovor koji nekad prethodi radiološkom odgovoru, pa jeste tu ta snaga cirkulišuće tumorske DNK i može se pratiti, odnosno i znati pre radiološke progresije kada će pacijent imati pogoršanje bolesti. I na desnom grafu vidite da responderi u odnosu na neresponderi imaju vrlo zanemarljive količine cirkulišuće DNK, odnosno takozvani DNK clearance. Ovo je iskorišćeno u puno radova, postoje i naučni projekti, o tome će se pričati i na danu melanoma, koji prate upravo koncentraciju DNK digitalnim PCR-om pri praćenju odgovora na bolest. Konkretno naše iskustva, mi nismo quite modern yet, kako kaže naslov, mi dalje koristimo BRAF mutacioni test, detektujemo samo tu mutaciju na poziciji V600E, odnosno njih 4 koje cross-reaktivnost na TMS, jednostavna metoda, target metoda, vrlo pouzdana, vrlo osetljiva, znate da rezultati budu jednom nedeljno, do sada je testirano skoro 2000 pacijenata, od 2013. Procenat je u skladu sa literaturnim podacima i ono što je dobro za ovu metodu, mi stvarno nemamo rezultata koji nisu validni. Ovde je kratko prikazan graf kako raste broj pacijenata, naravno od letos, pošto je ušli su BRAF/MEK inhibitori u adjuvantni setting, taj broj pacijenata je porastao za 50%. Što se tiče nekog našeg plana, mi se trudimo, bit će jedan projekat krati za cirkulišuću DNK gde ćemo probati digitalnim PCR-om da validiramo metodu i nadamo se da će to možda biti neka metoda izbora za budućnost kao i metoda za neke research projekte. To hvala ispred laboratorije za molekularnu genetiku.
Thank you for a very quick and informative talk. You can join us in the panel. Now our next speaker is our dear guest, Piotr Rutkowski from Poland. He is leader of many trials in his country and a very citated person, so we value his presence here. And of course, the dobre jutro.
Dobre jutro. So good morning. Thank you, the organizing committee, especially Professor Markowicz and Professor Nada Santacz for invitation for this wonderful Congress. With short delay, we're starting the presentation. I will focus on the role of surgery and perioperative treatment in melanoma because although we thought that everything is set up for surgery, but now it's really, the role is changing, and I hope that it will be interesting for you. So, okay. Here you see my potential conflict of interest, and I would like to focus that I'm generally the surgical oncologists, which are, I don't know, is it work or not, which are working in multidisciplinary team treating melanoma and skin cancer patients for more than 25 years. So I saw all these changes. However, as we know, still sentinel biopsy, it's basic and essential part of staging for clinical melanoma from PT1B to PT4 in all patients, and about 20% of patients is sentinel lymph node positive. And still for last more than 10 years, it is recommended for all melanomas more than 1 millimeter. However, we usually consider it for PT1B also patients. When we look at the NCCN guidelines, it's also the same, that the patients should be considered for sentinel biopsies since PT1B stage, and for PT1A, usually we have only white excision. The same is for PT2A and higher stages. What is more important that now, usually after positive sentinel lymph node, we are going only to the observation and adjuvant therapy. I will focus on that later. So you may see here, I don't know, is it working, this pointer? No.
You can try this one.
Okay, but I'm not sure is it working on the screen, so not. This one? Okay, doesn't matter. So looking at the stage 3A, usually we have observation only without additional nodal surgery. Okay, thank you, but I'm not sure that it's seen on the screen. You know, this is, yes, so it's, okay. And for stage 2B or higher, usually now, so stage 2BC, and we are going directly also without sentinel lymph node involvement for adjuvant therapy. This is new thing which should consider. I know that in Serbia still it's not reimbursed, this part of adjuvant therapy. However, I will show what is the impact on the patients. And also in terms of the in-transit metastatic disease, when we have the relapse after some time from primary tumor, and this is single in-transit metastatic disease, we can consider also sentinel lymph node biopsy. What is also important that in some location we should use SPECT-CT, so fusion imaging for sentinel biopsy imaging. So it is standard procedure for head and neck and trunk location because it's much better visualized sentinel lymph node, not using the planar scintigraphy. It has been confirmed in several papers, so our group look at that, especially in location like head and neck, as I mentioned, and the trunk. What we also know about the role of sentinel biopsy? The old MSLT1 trial showed that we haven't any impact on overall survival. However, it is the basic staging procedures which can differentiate between the better prognostic patient with sentinel lymph node negative group and worse prognostic group with sentinel lymph node positive. And the final results also showed that it was no impact on overall survival of this procedure. This is staging procedure. For years, we also looked, can we omit The next step, so because for many years, completion lymph node dissections, when the sentinel lymph node was positive, we perform lymph node dissection. But now it is not true. First, we try to look at the prognostic value of the size of the metastatic tumor. This is a joint paper of Dutch group together with our group. And we discovered that with small deposits in sentinel lymph node, it is absolutely no impact on overall survival, this disease. But the next step was compare completion lymph node dissection or observation in sentinel lymph node positive melanoma. And now we know that for melanoma-specific survival, it's zero impact of completion lymph node dissection. It means that this is obsolete, this is harmful for patient. We do not need to perform completion lymph node dissection for our patient when the sentinel lymph node is positive. The same was shown by another study. This was German group study, DCOG SLT. When you see on the left upper side, the impact on melanoma-specific survival, overall survival, was zero. And the final analysis also confirmed this for overall survival. Meta-analysis also did not show that it's any benefit in survival or recurrence rate if the patient undergo completion lymph node dissection when observation, and another meta-analysis. The change in disease stage is less than 6% of the patients when we perform completion lymph node dissection. So as I mentioned, now it should be abolished and we do not perform it for last 7 years. Can we replace sentinel biopsy by any technique? PET not. PET, it's not useful in this staging. When we have a relatively thin melanoma and we consider sentinel biopsy, so PET has zero impact because we cannot find deposit on the level of 1-2 millimeter in the sentinel biopsy. When we look at the current guidelines, ESMO guidelines completely eliminated completion lymph node dissection, and with positive sentinel biopsy, we go directly to adjuvant therapy, except the situation when we have a very small deposit, so the observation and with ultrasound follow-up should be performed. This is our paper showing the changes in the behavior of our surgeons and our attitude for the patients who are, maybe I will take this microphone and I will show you. So you see the active surveillance was here. This was adjuvant therapy. This was cell-ND plus adjuvant, and this was cell-ND alone. And you see how it changed to 2021. So this is completion lymph node dissection in 2021. Now it's almost zero in Poland. So it was based on the 7 major centers in Poland. And what is more important, when you see there is no impact at all, completion lymph node dissection and CLN or CLND and no CLND on overall survival. So in real world, we can confirm the data from the study. What has the impact? Adjuvant therapy. Adjuvant therapy has real impact, especially at early observation. Targeted therapy has impact on relapse-free survival. Why sentinel biopsy is also important? Because it improves local regional control of the disease. So we have staging procedure and better local regional control with sentinel biopsy. Can we replace, as I mentioned, sentinel biopsy? Probably yes, in the future. Now we are starting some evaluation of the primary tumor with gene expression profile tests, which can have a very strong prognostic value, and maybe we can eliminate sentinel biopsy in some cases and go directly to adjuvant therapy. So is any role of completion lymph node section after positive sentinel node? No, except increasing lymphedema and decreasing the quality of life of our patients. So we shouldn't perform it now for any subgroup. Still need surgery in the era of risk scores? Yes, because for sentinel biopsy we have still a better regional control. We can discuss the benefits of adjuvant therapy, and in the future it can be replaced by biomarkers. However, we do not perform lymph node dissection after positive sentinel biopsy. So we still perform therapeutic lymph node dissection, but probably in the future we also abandon this. I will show you some examples, and of course we do not perform elective lymph node dissection as well. So now the second part about the perioperative treatment. The standard of care is adjuvant therapy, so postoperative systemic treatment for 1 year, but probably we are going in the direction of neoadjuvant therapy. We are deeply involved in the recent trials for that approach because early eradication of micrometastatic disease in more immunosensitive microenvironment can lead to more cure of the disease. We can also probably limit the extent of surgery or improve surgical outcomes with R0 resection. We can have a better information of biomarkers. But we need, of course, the collaboration from the beginning. So before surgery, before the decision about surgery, we should discuss with our medical oncologists how to best approach for this patient. So we are talking about the systemic treatment for potentially curable disease in stage 3 or stage 2B/C disease. Because when you look at the stage 3 melanoma, for stage 3C and stage 3D, we have very poor prognosis patients. And this is why we need something more beyond surgery. Also, when we look on stage 2B and especially 2C, the prognosis is worse for stage 2C than stage 3A and 3B. So the patient with single positive sentinel lymph node has much better prognosis than the thick melanomas without sentinel lymph node involvement. On average, for stage 3, we have about 60% relapse rate. For stage 2BC, about 40% relapse rate. So adjuvant therapy is a standard of care now. We're using in stage 3, this is reimbursed in Serbia. In stage 4, only nivolumab, and this is a rare situation when we have single metastatic disease. Usually, in my opinion, we're starting from systemic treatment and thereafter we consider surgery. But sometimes it's happened that surgery first and adjuvant therapy. And the new stage 2BC with Pembro or Nivo. Now it's reimbursed in Poland. I hope that it will be reimbursed in Serbia soon. So the current environment in perioperative treatment, of course, went from the development in stage 4 disease and introduction of this postoperative treatment dramatically decreased risk of relapse and improved this metastasis-free survival. And next strategy is first adopting the predictive biomarkers and also neoadjuvant therapy, which is not formally approved but reimbursed in some countries. So we have several clinical scenarios now, as you may see here. Very important is to know the BRAF status for stage 3 disease. And generally with this adjuvant therapy, we can decrease risk of relapse and about 20% distance metastasis-free survival can be improved about 12 to 15%. So you see that all curves with all drugs used in adjuvant situation, Nivo, Pembro, Dabrafenib, Trametinib, are very similar. And all has category 1 in treatment of in postoperative setting. And you see also that after positive sentinel lymph node, we have active ultrasound or CT imaging and go directly to systemic therapy. CLND is not preferred now. We have long-term data now, 5 to 7 years, and all showing the same situation. However, the impact of adjuvant therapy is much higher in more advanced disease. So when we have stage 3C or stage 3D, generally we have much better impact of systemic therapy. For stage 3A, we always discuss with the patient, is it worth to use adjuvant therapy or not? You see, this is for targeted therapy, the same situation. The number needed to treat for patients treated with adjuvant therapy is about 6 now. And here you see our study from our real-world evidence that overall survival is the same for targeted therapy and immunotherapy in adjuvant setting. However, the curves for relapse-free survival are a little bit different. It's here. And you see that they cross after 2 years, like in the clinical trials, because targeted therapy works when it's given, and thereafter we have some relapses. Immunotherapy needs some time, but the final curves are very, very similar. The same is no impact of completion immunodissection on adjuvant therapy. What is also important that generally we should always be aware of the number needed to treat and the number needed to harm in terms of perioperative treatment. For earlier stages, we have 2 trials showing also the improvement of distance metastasis-free survival, especially for stage 2C. This is why I said that it's worth to use this postoperative treatment in this setting. This previous one was for pembrolizumab. This one is for nivolumab, but the curves are very, very similar. And what is the future? The future probably can be personalized vaccine with mRNA. This is very interesting approach. When we remove the tumor, we performing NGS, we produce mRNA based on the individual pattern of neoantigens and giving to the patient together with anti-PD-1. And you see these results are from phase 2 trial. However, it's much better than adjuvant therapy used now, so anti-PD-1 alone, especially in terms of distance metastasis-free survival. It's almost ideal because it's almost 90% of disease control with this approach. So for adjuvant therapy, we have 3 approved systemic therapies from stage 2 to stage 4. And very important is correct evaluation of risk of relapse. And the last few slides are about the preoperative treatment. It also can change our approach for melanoma. So short course of neoadjuvant immunotherapy is beneficial for the patients. Now we have 2 trials confirming there. We use sometimes in the current practice when we have borderline resectable disease, and we also apply to our Minister of Health for reimbursement of this procedure. And what is important, that pathological response is an early surrogate for the response and for further prognosis. You see how changed this perioperative treatment for melanoma. I remember this time when we had only adjuvant interferon, who was not very active, which was not very active for our patients. Adjuvant CTLA-4 never approved in Europe. Adjuvant anti-PD-1, I showed the data, and now 2 trials with neoadjuvant, but you see hazard ratio compared to adjuvant therapy 0.3. This is amazing in the current times with this trial, which is called NADINA trial. And first trial which showed that neoadjuvant therapy can work was very clever trial, because instead of using all cycles of pembrolizumab postoperatively, 3 cycles were given before surgery, and you see that this blue curve with neoadjuvant adjuvant group was much better than adjuvant only. But the current standard is based now on NADINA trial. 2 courses of ipi-nivo, but in lower dose of ipi, showed the improvement of almost 30% in event-free survival as compared to the standard of care, which is adjuvant therapy. And the same is for distance metastasis-free survival. So for macrometastatic disease, palpable nodes, in transit mets probably will give the immunotherapy before and evaluate pathological response, which about 50% are responding very well to this immunotherapy. The future is using probably only the index node resection. So like in the breast cancer, make an index node marked, give immunotherapy, thereafter you remove only this index lymph node. If it's pathological complete remission, no further treatment is required, with very good long-term data. About 60% of patients has this response to the therapy, and you see that omission of therapeutic lymph node dissection in the future, this is not a standard yet, in patients with major pathological response probably will lead to the limiting of the extent of surgery or personalized approach, because if you have no response, of course, we'll remove surgical nodes and give postoperative treatment. So the changes in this approach are huge, and in the newest version of SCC guidelines, neoadjuvant therapy is option. We also introduced this in Polish guidelines this year. And you see this is one of our papers on neoadjuvant approach, and it is much more effective and much easier to perform surgery. And if we have major pathological response, the results are really good. What is also important, that preoperative treatment does not decrease the quality of surgery. No significant difference in surgical time, complications. This is from a Dutch group of patients, and from our study published recently in European Journal of Surgical Oncology, you see also that the surgical complications are really on the level which we expected without any perioperative treatment. So personalized of this neoadjuvant immunotherapy, this is future, but it happens really now. What is also important, that for this patient who has a major response, probably we do not need very detailed follow-up. We can reduce the number of CTs postoperatively, because if the patient has long-term disease control without any relapse, so doing a CT in this group of patients, it's nonsense. So to summarize, what is the current standard and perspectives for adjuvant therapy, which is standard of care, micrometastatic disease, stage 2 BC, it will be the standard of care. Maybe this personalized vaccine will replace this, the current approach. For neoadjuvant therapy, it should be the standard of care in clinical palpable nodal nodes. It is about 20 to 25% of the disease, and maybe in the future reduce surgery in the nearest future. But of course, the key to success is collaboration, as I mentioned, and we hope to improve the survival in this group of patients. So thank you very much for your attention, and I would like to thank my team from Department of Soft Tissue Bone Sarcoma and Melanoma. Thank you very much.
Dobro jutro, dobar dan. Ja ću vam posle ovog današnjeg izuzetno detaljnog predavanja profesora Rutkovskog u najkraćim mogućim crtama prikazati ključne momente za adjuvantnu terapiju melanoma kože.
Imamo predavanje, Vasilij. Evo.
Yes. Šta je ono što čini rizičnu grupu melanoma koja podleže eventualnom tretmanu u adjuvantnom settingu? Znači, govorimo o stadijumu 2B, 2C i stadijumima 3. Ono što je ključno, saradnja patologa i izuzetno precizna dijagnoza, koju, hvala Bogu, imamo prilike da se susrećemo sa nalazima naših patologa, a ono što je u našoj situaciji donekle problem, koji mislim da tokom vremena rešavamo, je dužina čekanja patohistološkog nalaza. Ali vremenom će se i to rešiti. Ovo je ono što je ključni moment za odluku o adjuvantnom tretmanu. Znači, u kolikom procentu i kod kog stadijuma očekujemo ili se javlja rekurentna bolest. Za stadijum 2B to je 32%, ali za stadijum 2C je čak 46%. Vidite razliku da je čak i u toj situaciji stadijum 2C sa mnogo većim rizikom i mnogo opasniji i teži za, kažem, odluku o tom terapijskom modalitetu, a u odnosu na stadijum 3A imamo odnos rekurentne bolesti od 44-45 za stadijum 3B i čak da 74% pacijenata kod stadijuma 3C. Šta je sledeći ključan moment? To je vreme javljanja rekurentne bolesti. Naravno, opet uviđate da je stadijum 2C sa lošijom prognozom, odnosno kraćim vremenom do pojave rekurentne bolesti u odnosu na stadijum 3A. Naravno, on se smanjuje sa porastom stadijuma i otprilike godinu dana za stadijum 3b, ali samo 5 meseci za stadijum 3c. Ono što je ključno u ciljevima primene adjuvantne terapije kod melanoma je naravno zaštita, odnosno prevencija pojave rekurentne ili metastatske bolesti. Naravno da tu uvek moramo da skrenemo pažnju i o toksičnim efektima koji mogu biti opasni po bolesnika ili trajni u odnosu na životni vek bolesnika i eventualnu potrebu za kasnijom primenom terapije u metastatskom settingu. Naravno, uvek, odnosno već duži niz godina govorimo o kvalitetu života koji je neophodno očuvati u svakom momentu tretmana bolesnika, a naročito se to odnosi na adjuvantnu terapiju kod melanoma. Poznato nam je svima, jer smo u situaciji da dajemo i imuno i kombo target terapiju od januara 2017. godine. Svi smo se suočili sa različitim nuspojavama i toksičnim efektima kod naših bolesnika tokom ovih 7, pa da kažemo i skoro 8 godina, i onda možemo samo da kažem da pojačamo intenzitet onoga što se zove praćenje kontrole i predviđanje toksičnih efekata koji se mogu javiti kod pojedinih bolesnika, ali naravno kod što manje njih. Ovo je jedno podsjećanje na istorijske momente u smislu javljanja adjuvantne terapije, odnosno kada se koja registraciona studija javila i kada je postojala mogućnost, kada je došlo do mogućnosti tretmana imunoterapijom ili kombo target terapijom. Ono što je bitno je da je malte ne svake godine dolazilo do registracije novih lekova i novih protokola u adjuvantnom settingu, ali naročita eksplozija svega toga kreće od 2015. godine. Ono što je bitno je da se pomeraju i stadijumi bolesti u kojima se primenjuje. Ono što je sve to što sam vam sada rekla je naravno registrovano u ovim NCCN vodičima u kojima se strogo definiše šta je to što je sa dokazom kategorije 1 u primjeni stadijuma 2b ili 2c i ono što su protokoli sa prioritetom primjene kod stadijuma 3a, b, c ili d. Naravno, sve ono što je navedeno u NCCN vodičima, ponovljeno je u ESMO vodičima, bez obzira na relativnu, da kažem, zastarelost njihovu, jer nisu updateovani od 22. godine, međutim, krajem ove godine ili najkasnije početkom sledeće godine očekujemo i update ESMO vodiča u smislu adjuvantne terapije. Ono što ne smemo zaboraviti, a što je dr. Janković iznela jako bitan moment, da mi za sad imamo samo BRAF kao ključni moment za odluku o terapijskom pristupu, i da nikad ne smemo zaboraviti, bez obzira o kom stadijumu sada govorimo, na potrebu za BRAF testiranjem i retestiranjem. Ono što je ključno kod melanoma je ta ogromna varijabilnost u promeni mutagenog statusa i to je jedan od momenata koji smo naravno tokom mogućnosti lečenja u Srbiji u odnosu na primjenu različitih terapijskih mogućnosti prilagođavali i menjali. Ono što je naša realnost je da od maja meseca imamo mogućnost za lečenje 3. stadijuma melanoma, imunoterapijom pembrolizumabom i nivolumabom i kombo target terapijom dabrafenibom i trametinibom, ali nažalost ne i za 2. stadijum. Za sada toliko. U odnosu na metastatsku bolest, primaris dr. Matković, ali ono što mislim da će za vas sve biti najkorisnije i najznačajnije, to je priskaz slučaja koji sledi. Hvala vam.
Dobro, drage kolege, poštovane kolege, dobro jutro, dobar dan, ne znam ni ja šta da kažem, meni je jako žao što smo ovo malo kasnili, ovo kao malo uvoda dok ne puste moje slajdove. U stvari, cela ova sesija je, moram da kažem, zamišljena da u nastavku sada malo pričamo više o tom nacionalnom vodiču za melanom za koga očekujemo da vrlo skoro izađe, u stvari da prikažemo šta je to nešto novo, šta ćemo moći da pročitamo u tom novom nacionalnom vodiču. I ono što bih ja na početku rekla jeste da smo jako ponosni, ja verujem svi ovde koji sede, a i vi u publici, a i oni koji nažalost danas nisu sa nama, da u kontinuitetu pratimo sve ono novo što se dešava vezano za prevenciju, dijagnozu i tretman melanoma. Setite se našeg nacionalnog vodiča iz 2014. godine, pa 19. i evo sada krajem, a možda početkom iduće godine, jer očekujemo neke update-ove svetskih i evropskih vodiča, imat ćemo i novi nacionalni vodič. Ja bih trebala da kažem samo vrlo kratko nešto šta je to novo u sistemskom lečenju metastatskog melanoma i za sada ono poslednje što imamo vezano za ESMO, za znači preporuke Evropskog udruženja medikalnih onkologa je iz 20. godine, ta konsenzus konferencija, prethodni neki guidelinesi su iz 19. i koliko vidim svi najavljuju da će krajem ove godine izaći najnoviji, updateovani podaci, pa tako ćemo i mi sačekati sa našim vodičem da bi sve to što je najsvežije uneli u njega. I naravno NCCN vodiči koji se updateuju otprilike na nedeljnom nivou. Tako da su oni onako nešto ažurniji. Ono što je novo u odnosu na prethodni vodič za sistemsko lečenje jeste šta je to preferirajući režim, a šta su ostali preporučeni režimi u lečenju metastatske bolesti. Znači, ranije je bilo da i imunoterapija, bilo mono, bilo kombinovana i target terapija je preferirajući režim od pre nekog vremena, znači preferirajuća je imunoterapija, bilo mono ili kombinovana, a u ostale terapijske režime spada target terapija, naravno kod BRAF mutiranog melanoma. U ove naredne linije terapije, druge, treće i tako dalje, neću sad ulaziti jer zaista nemamo vremena. Po meni, ono što je znači i dalje ostalo kao neko ključne tačke, jeste izbor prve linije terapije kod BRAF mutiranog melanoma. Videli smo da je adjuvantna terapija postala danas standard u lečenju i onda nam se otvorio problem i pitanje na koje ćemo pokušati, nadam se i u narednom ovom panelu da odgovorimo, kako izabrati prvu liniju terapije sistemske bolesti ako je pacijent primao adjuvantnu terapiju. I naravno morala sam zadnje da stavim ono što nama u realnoj kliničkoj praksi nedostaje, a što je u svim terapijskim vodičima, to je mogućnost retretmana. To je praktično mogućnost neke treće, četvrte linije, što je rezervisano, jasno vam je kad znate o kakvoj se bolesti radi za jedan mali broj pacijenata. Ovdje bi trebalo da budu, ja ne znam kako vidite ovde gore, ali to je čitav niz različitih faktora koji utiču na izbor prve linije. Slabo se vidi, tako da ćemo ih preskočiti. Znači i target i imunoterapija, kao što sam već rekla, je racionalan izbor prve linije sistemskog lečenja BRAF mutiranog melanoma, ali generalno preferirajuća opcija je primjena imunoterapije. Prediktivnih biomarkera nemamo da znamo kome ćemo šta dati, još uvek, ali ono što znamo i što primenjujemo u svakodnevnoj kliničkoj praksi je činjenica da target terapija daje brz terapijski odgovor unutar već par nedelja, unutar već nedelju dana, da čini kontrolu bolesti kod gotovo 90% pacijenata, međutim da razvija se rezistencija unutar nekih 6, 8 ili nešto više meseci. To je vrlo značajno kad biramo terapiju kod BRAF mutiranog melanoma u prvoj liniji. Znači, pacijenti kojima je potrebno da imaju brz terapijski odgovor, koji imaju balki bolest, koji imaju povišene vrednosti LDH, visceralne metastaze, recimo u jetri opsežne, pre će biti da kandidati za primjenu target terapije nego imunoterapije. To je poruka u stvari svih ovih terapijskih vodiča. Da li izabrati monoterapiju kad biramo imunoterapiju ili kombinovanu koju nažalost mi još uvek nemamo, ali dajemo je pod određenim uslovima, svakako je izbor na kombinovanoj terapiji, jer ona daje mnogo bolji i response rate i dužinu trajanja terapijskog odgovora, daje mogućnost da izlečenje pacijenata, odnosno produženje ukupnog preživljavanja. I na kraju ovo pitanje, a o tome ćemo možda i kasnije u panelu diskutovati, treća stvar, kako u uslovima postojanja adjuvantne terapije izabrati prvu liniju sistemske kad pacijent relapsira. Ovo su jako lepi ADO vodiči, ali eto, da skratimo, o njima ćemo pričati kasnije. Hvala vam lepo.
Dobro, u nastavku naše melanoma sesije koja je malo kasnije počela, proći ćemo kroz slučaj koji smo osmislili kako bismo dotakli sve neke tačke spoticanja u donošenju naših kliničkih odluka. Da krenemo kroz slajdove.
Pa evo. Pa evo, taj naš prikaz slučaja je znači jedna mlada žena koja ima 24 godine, koja je zaposlena u banci. Naravno, sa svoje 24 godine nema apsolutno nikakve komorbiditete, negativnu porodičnu istoriju za malignitet. Ona je lepa žena, ima plave oči, ima plavu kosu i jako voli da vodi računa o svom spoljnom izgledu, naravno, što je u tim godinama i normalno, pretpostavljam. I smatra da, znači, taj neki tamni ten doprinosi njenom lepšem izgledu i regularno, znači od svoje 18. godine ide u solarijum, stalno, a tokom letnjih meseci ona ide na more, tamo boravi 3 do 4 nedelje i intenzivno se izlaže sunčevom, intenzivno se sunča, odnosno izlaže se sunčevom zračenju i naravno više puta je imala i dešavale su sve različite opekotine koje je dosta dugo posle toga trebalo vremena da zaleči. Pa je moje pitanje, recimo, Željko, da li ti misliš da je ovo zaista jedno pravilno ponašanje, da li je ovo pravilan životni stil ovako jedne mlade osobe?
To je, nažalost, stil koji praktikuje dosta mladih osoba. Ja ću samo navesti podatak da je solarijum kriv kod 79% ženskih osoba mlađih od 29 godina. To su podaci iz literature. Nažalost, slična situacija u našoj zemlji. Ono što smo mi uspeli da se izborimo, a to je da je donet zakonski akt da je solarijum zabranjen u Srbiji za mlađe od 29 godina, mlađe od 18 godina, a da sve starije osobe moraju da potpišu informisani pristanak prilikom sprovođenja tretmana u solarijumu. Drugo je pitanje koliko se to sprovodi i sigurno smo svesni da, pogotovo kada su mature u pitanju, da mlađi stanovnici Srbije idu bez kontrole i roditelja ili, nažalost, pod znanjem roditelja, ali bojim se da inspekcijski deo Ministarstva zdravlja ne sprovodi ovo kako bi trebalo.
Ja bih samo podsjetila mog dragog kolegu Ivana na daleku kancerološku nedelju kada smo pričali o melanomima kod mladih osoba, možda će se setiti u starom Sava centru, pa smo izvlačili podatke naših pacijenata od onih recimo nekih 18 do 29 godina i jedan od naših zaključaka je bio tada i to Željko, spominjem i tebi da sunce nije naš neprijatelj, je li tako? Da u stvari je sunce izvor života, ali smo krivi mi i naše neodgovorno ponašanje, ja bih rekla.
Ne, svakako samo da rešimo dilemu kad nam dođu pacijenti koji kažu sunce se promenilo, znate. Zapravo mi smo se promenili, naše ponašanje, evo samo da se setimo neka, da kažem, srednja ili starija generacija, neka samo pomisli da li su se njihove bake kupale u kupaćem kostimu. Nisu. Razlika je 60 godina između rođenja jedne i druge osobe. Da li je neko, recimo, kosio pre 60 godina bez majice? Nije. Danas to radi. To su samo razlike. I još jedna mala digresija, samo 70. godina u Beogradu je bilo pitanje da li idete na more. Sada je pitanje gde idete na more. To je već druga razlika. Tako da, i još koliko puta idete. Tako da, sunce se nije promenilo za 50 ili 100 godina, to je treptaj oka za život sunca, nego zapravo smo se mi promenili u našem ponašanju.
Hvala Željko na komentarima. Idemo dalje kroz slučaj. Naša pacijentkinja je u sklopu rutinskog sistematskog pregleda koje je organizovala njena kompanija otišla na dermatološki pregled gde su naravno verifikovane brojne solarne promene po koži i dosta melanocitnih nevusa, s tim što je jedan od nevusa bio atipičan na zadnjoj strani ruke. Vidite i sliku. Pacijentkinja je upućena na hitnu eksciziju suspektne lezije i u histopatološkom nalazu verifikovan je melanom, nodularni tip, preslo 4,1 sa prisutnim ulceracijama, marginama koje su bile 9 po dubini i 13 po periferiji i nije bilo satelitskih lezija. Moje sledeće pitanje je za doktora Jevrića kao hirurga sa Instituta za onkologiju i radiologiju Srbije. Pored ovog kliničkog pregleda, šta bismo sledeće još uradili pacijentu kada ima ovakav nalaz i kada je završena hiruška ekscizija?
Hvala, Nado. Obzirom da se radi o debelom melanomu koji ima ulceraciju, mi bi svakako tražili da se uradi neki skener inicijalno, skener abdomena, grudnog koša abdomena i male karlice i ciljani ultrazvuk regionalnih limfnih nodusa. To je za neko inicijalno stažiranje i svakako taj pacijent bi morao da ide na konzilijum, odnosno multidisciplinarni tim o odluci za, praktično prvoj odluci za početak onkološkog lečenja.
Da, to je
neki algoritam koji se kod nas sprovodi i koga se striktno držimo na konzilijumu.
Tako je, kod nas nijedan pacijent ne može dalje da dobije lečenje bez konzilijuma.
Da.
Naravno. I tačni odgovori su tu B, C i D. I sad taj inicijalni, šta je inicijalno urađeno, fizikalni pregled, klinički pregled, da li postoje uvećane limfni čvorovi, da li imamo neke satelitske ili intransit lezije, ultrazvuk regionalnih, znači nodalnih basena, CT pregled. Moje pitanje je, ko bi uradio u ovoj fazi bolesti magnetendokranijuma od vas? Pa ne baš, Jevriću.
Ja ne.
Ja bih samo iskomentarisao, znači, pošto sad znamo konačni patohistološki nalaz melanom debeo 4,1 mm, znači debeli melanom, da mi dobijemo izveštaj da je atipična promena, mislim, malo sa nalazom atipične promene, ja mislim da tu dominantnu ulogu u odluci i izboru dalje dijagnostike ima najčešće hirurg ili plastični hirurg kod koji pacijenti dođu. I ako ima dovoljno iskustva da zaista pomisli da je debeli melanom, tada ima razloga da se uradi neka veća dijagnostika.
Yes, let's hear what Piotr would do in Poland.
Of course, everything was done properly until now, and we usually also doing CT scan and always discuss MRI brain because the risk of metastasis in general in this patient is about 40%. And we order BRAF testing at this stage because nevertheless the patient will be for adjuvant therapy. And of course, if the CT MRI is free of disease, so we perform sentinel biopsy and go for further adjuvant therapy.
Dobro, uradit ćemo naravno laboratoriju. Sad, ja bih pitala Rado, da li je ovo pravo vreme da radimo BRAF testiranje ili da čekamo kasnije?
Ne čekamo.
Ne čekamo? Dobro.
BRAF mutice je znači rani događaj u onkogenezi i verujem da sve biomarkere treba raditi što je moguće ranije zbog poznavanja molekularnog profila na početku, naročito u svetlu sad postojećih tretmana u tim stadijumima bolesti i zbog kombinacija. Znači, apsolutno da.
Hvala.
Let's comment, sorry, sad ćemo na srpskom. Ja bih pitala Milicu Rajović da prokomentariše kakve su ekscizione margine dovoljne prema vodičima sada i kada ćemo raditi sentinel biopsiju.
Pa evo mi od našeg onog prvog vodiča iz 2014. smo preporučivali ekscizione margine 2 do 3 mm, a reekcizione su ostale do dana današnjeg kao i tada što su bile za in situ melanom 5 mm, za melanom deblji od 1 mm, od 2 mm, od 1 mm, pardon, margina od 1 cm, a za melanome deblje od 2 mm po Breslovu, 2 cm su bile margine i ti su se sekundarni defekti najčešće zatvarali ili direktnom suturom ili autotransplantatom kože, izbjegavali su se lokalni režnjevi. Što se tiče biopsije limfnog čvora stražara, ona je apsolutno bila preporučivana za sve melanome koji su deblji od 0,8 mm, ili za melanome koji su tanji od 0,8, a imaju ulceraciju ili neki drugi faktor rizika, u odnosu takođe na konzilijarnu odluku kada se radi recimo o pacijentima mlađe životne dobi, pacijentima koji imaju eventualno više od jednog melanoma, onda se preporučuje sentinel i za Breslov tanji od 0,8 mm. Svakako za Breslov od 0,8 do 1 mm koji ima ulceraciju i za Breslov deblji od 1 mm. To je patohistološki stadijum 1b. Uloga biopsije, limfnog čvora biopsije, limfnog čvora stražara za stadijum 2b i 2c je apsolutno indikovana zbog toga što dobijamo staging bolesti, znači sa pozitivnim ili negativnim limfnim čvorom stražarom znamo da li su ti pacijenti i dalje u 2b ili 2c stadijumu ili prelaze u 3. klinički stadijum koji apsolutno znači metastatsku bolest u regionalnim limfnim čvorovima. Imamo bolju kontrolu bolesti.
Hvala, Milice. Now we have a question for Piotr. Is there a place for dissection? Yes.
I hope that I answered during my presentation. There is no. But as you must remember that this trial, MSLT2, was done even before the era of adjuvant therapy, and it was zero impact of melanoma specific survival. So now it's even less discussion about this. So, of course, the patient should go for, if it's positive, should go directly to adjuvant systemic therapy.
Na kraju smo, kad smo sve ovo odradili, zaključili da nakon ove, u stvari, široke, ekscizije, u stvari, ožiljka i provere limfnih čvorova stražara, to je bila leva aksila, i gde su detektovana 2 sentinel limfna čvora, ali su bila negativna u pogledu melanoma, stažirali bolest na osnovu ICCA-10M 8. klasifikacije, PT4B, N0, M0, znači stadijum 2C. I sad je moje pitanje, u stvari, šta bi dalje radili sa ovom pacijentkinjom? Da li bi je samo uputili dalje na regularne kontrole, jer završeno je hiruško lečenje? Da li bi je vratili hirurgu onkologu da kompletira disekciju nodalnog bazena, da slučaj da nešto što kažu nije propušteno, da li bi je uputili radijacionom onkologu ili bi je uputili možda konzilijumu, multidisciplinarnom tumorskom bordu, da razmotri primenu adjuvantne terapije. Ja ću vam odmah dati odgovor da je to pod D tačan, ali ih bi molila Tanju, našu dragu koleginicu Tanju Radevica VMA, da nam kaže a zašto je upućujemo na konzilijum i zašto uopšte pričamo o adjuvantnoj terapiji.
Pa zato što su ovo pacijenti zapravo kod kojih je prema podacima iz velikih registara i baze...
Mikrofon, Tanja.
Da. Ovo je pokazano da je njihovo 5-godišnje preživljavanje, odnosno melanoma specific survival, zapravo u 2B stadijumu 87% i 82% u 2C i praktično je izjednačeno sa 3B stadijumom, odnosno pacijentima koji imaju metastaze u limfnom čvoru. I ovo su upravo pacijenti koji pripadaju toj visokorizičnoj grupi, zapravo imaju visok rizik od relapsa i lošije preživljavanje. Ako pogledamo stope relapsa kod pacijenata u drugom B stadijumu, stopa relapsa je 32%, a kod drugog C zapravo je 46%, što je, ako uporedimo sa trećim B stadijumom, kod kojih je stopa relapsa 44,5, zapravo lošije nego u trećem stadijumu. I upravo iz ovog razloga su sprovedene dve velike registracione studije, to je Keynote 716 studija, koja je komparirala pembrolizumab sa placebom i nakon 36 meseci 76% pacijenata je bilo bez relapsa u odnosu na preko 63 u placebo grupi, odnosno smanjen je rizik od relapsa za 38%. Ali isto u ovoj studiji je pokazano da je smanjen je rizik za pojavu udaljenih metastaza za 41%. Takođe, u drugoj studiji, to je Checkmate 76K, je kompariran nivolumab sa placebom i nakon 24 meseca je pokazano da su bez relapsa, da je bilo 76% pacijenata koji su primali nivolumab u odnosu na 61 u placebo grupi i da je kod njih takođe za 47% smanjen rizik od relapsa. Upravo iz ovog razloga, na osnovu rezultata ovih studija su nivolumab i pembrolizumab sa najvećim nivoom preporuke uvršteni u svetske vodiče, znači za NCCN, nakon odobrenja od strane Američke agencije za hranu i lekove i Evropske agencije za lekove i nalaze se u trenutnim vodičima.
Dobro, idemo dalje. Naša pacijentkinja je završila sa adjuvantnom imunoterapijom i razvila je nekoliko neželjenih efekata. To su bili osip, svrab i hipotiroidizam koji je naravno kontrolisan uz supstituciju. Moje pitanje bi se odnosilo na Eminu da prokomentariše značaj endokrinoloških efekata neželjenih terapije koju dajemo, koliko je to važno, pogotovo kod mlađe žene, ovo je jedna mlada žena.
Pa svi znamo da prilikom imunoterapije česta su ta neželjena imunološka dejstva u smislu endokrinopatija najčešće i najčešće nam je zastupljena hipotireoza. Naročito kod mladih žena i u adjuvantnom settingu treba voditi računa i naročito ako je u reproduktivnom periodu, ali sve ono što znamo o hipotireoidizmu da ne zahteva, da u supstitucijonu terapiju ne zahteva prekid imunoterapije ukoliko je aktuelna, ali šta još moramo da znamo? Moramo da znamo da svi ovi endokrini poremećaji, neurološka, imunološka neželjena dejstva mogu da nastanu i odloženo posle prekida terapije, znači mogu da budu akutna, ali mogu da budu i da se jave mnogo kasnije, mogu da budu rekurentna, da se jave, znači najmanje u jednom istom organu 2 puta, mogu da budu odložena dejstva i nakon 3 meseca od prekida terapije mogu da budu hronična, da persistiraju i posle 3 meseca od prekida imunoterapije, što znači šta nam je tu bitno. Pogotovo sad kad dajemo u adjuvantnom settingu imunoterapiju, treba produženo praćenje svih tih pacijenata, baš zbog tih neželjenih imunoloških događaja. Tako da baš je prošle godine neki zanimljiv rad objavljen gde su pacijenti praćeni najmanje 18 meseci od prekida adjuvantne imunoterapije. To su pacijenti sa stadijumom 3 resektovanog, znači melanoma, i gde se videlo, znači da akutnu toksičnost je razvilo oko 71% pacijenata, gde vidimo da, znači, ovde da je najzastupljeniji tiroiditis, odnosno hipotireoza, oko 15%, dok se odložena hipotireoza javila u oko, znači, 2,2% pacijenata, a iz obe grupe, znači, u hronicitet hipotireoza prešlo je 85% pacijenata, što znači nemali broj. Tako da, pored toga, česta su i druga neželjena dejstva u smislu dermatitisa, pruritusa, u smislu artralgija, artritisa, kolitis, dijareja, ali sve to je imalo nisku stopu hroniciteta. I šta je najbitnije? Najbitnije je da je sve to nije zahtevalo i da mora da se daje terapija, ne zahteva prekid, znači uz supstitucijonu terapiju, sve to može da se drži pod kontrolom i praćenje dugotrajno. Eto.
Srećom, taj supstitucija L-tiroksinom je jako moćna i, da kažem, i u slučajima bez da je to komplikacija. Međutim, imamo interesantno pitanje za mene. Da li mi svim tim pacijentima eventualno možemo da proverimo nivo tiroglobulinskih i antimikrozomalnih antitela? Možda oni već imaju neku težnju ka oštećenju, odnosno ka autoimunskom tiroiditisu, pa da ovo samo doprinese. Mislim, ne možemo za sve okrivljavati ni imunoterapiju, tako da, eto, možda pitanje za razmišljanje. Jer kad bi generalno gledali, svaka četvrta osoba ima početni autoimunski tiroiditis.
Evo što se tiče nas, Ivane, mi imamo, pa pretpostavljam i vi, imamo čitav panel laboratorijskih analiza. Naravno, pacijenti ulaze i sa hipotireozom, nisu svi zdravi i imaju komorbiditete, ali bez obzira imali, nemali, čitav panel laboratorijskih analiza se i radi na početku i onda shodno preporukama se prati tokom terapija, ovo što si malo prespomenuo, posebno od kada je imunoterapija došla u karcinom dojke gde se kombinuje sa hemioterapijom, taj panel inicijalnih laboratorijskih analiza je još više proširen. Međutim, svi znate jako dobro koliko karcinom menja život naših pacijenata i u suštini fertilitet je jedan veoma značajan moment samog preživljavanja tih pacijenata. Ja se bavim i urologijom, pa to znam kad se radi o karcinomima testisa i svi mi znamo šta se radi i šta se dešava kad pacijenti primaju hemioterapiju. Međutim, jedno potpuno novo područje koje se danas otvara je pitanje fertiliteta i primene imunoterapije. Profesore Petkoviću, da li bi nam vi nešto rekli o tome? Vi ste i hematolog dodatno, tako da imate sigurno i sa krioprezervacijama, savetima pacijentima dosta iskustva.
Pa ovo je polje koje je trenutno ovako dosta aktualno u onkologiji, pogotovo što govorimo o adjuvantnoj terapiji. Kada govorimo o adjuvantnoj terapiji, znači pred sobom imamo, uslovno rečeno, zdrave ljude kojima treba da dajemo nekakvu terapiju u smislu zaštite od povratka bolesti, pri čemu mi nemamo prediktivne biomarkere ni za metastatsku, a kamoli za adjuvantnu, da bismo znali ko zaista ima benefit od ove terapije. U tom smislu treba jasno praviti, da kažem, ako je to moguće, ravnotežu između toga, šta raditi kada je u pitanju fertilitet. Ne postoje trenutno nikakve prospektivne studije koje su dale neki konkretan zaključak, iako je u najavi jedna prospektivna studija italijanske grupe koja bi pratila, recimo, anti-Millerov hormon kod primene imunoterapije, a kada govorimo konkretno ovde o melanomu, dakle, ni imuno, ni target terapija, ne postoje randomizovane studije koje su razmatrale ovu problematiku. Ono što je preporuka jeste, što svuda u tim vodičima piše, da treba diskutovati sa pacijentom o eventualnoj kontracepciji tokom lečenja, tokom primjene adjuvantne terapije, ali, kažem, ne postoje jasne preporuke.
Znači, hvala vam, moramo se snalaziti, otprilike i procenjivati, ali zaista za imunoterapiju još uvek ne znamo šta bi radili, kao što znamo za hemiju. Pratit ćemo, pa vidjet ćemo šta će biti. I pacijentkinja je završila godinu dana adjuvantne imunoterapije za stadijum 2C. S obzirom na sve te stope i procente relapsa bolesti, jako je bitno pacijenta sa melanomom u svakoj fazi njegove bolesti regularno pratiti. Zar ne, Željko?
To je svakako sa čime se mi susrećemo sa mogućnostima da naši pacijenti urade određene analize, to je sad druga vrsta priče, ali ono što bi mi svakako trebali, a to je ono što je Suzana, što si spomenula malo pre, to je multidisciplinarni pristup svemu tome. Znači, nisu nam u svim centrima dostupni ni dermatolozi, ni plastični hirurzi, ni onkološki hirurzi, ali jednostavno je neophodno da imamo. Znači, zbog čega? Zato što poznato je da pacijenti koji imaju već melanom imaju veću šansu da naprave drugi primarni melanom i naravno da imaju drugi nemelanomski karcinom kože. Znamo da su veoma česte metastaze, odnosno recidivi u regionalnom limfnom basenu. Takođe, čuli smo nekoliko puta danas koliki je rizik od udaljenih metastaza kod pacijenata u stadijumu 2C i naravno kao biomarkeri LDH i S100 svako mogu da nam pomognu u daljem praćenju pacijenata. U našem vodiču sadašnjem, koji je aktuelan, i u budućem, koji će biti uskoro, postoje jasne preporuke o tome kako i koliko često treba pratiti pacijenta.
Hvala, Željko.
Dobro, taman je Željko uveo u ovo našeg pacijenta dalje šta se dešava. Nakon 8 meseci, naravno nakon kompletiranja adjuvantne imunoterapije, pacijentkinji se pojavljaju limfodenopatije u regionalnom, to jest u levoj aksili. Fine needle biopsija potvrdila da se radi o metastazi melanoma, na CT-u isključena udaljena diseminacija bolesti, pacijentkinja je u odličnom opštem stanju bez ikakvih simptoma, znači radi se o resektabilnom nodalnom relapsu. Tako da, moje pitanje ide profesorki Borislavi, slajdovi su nestali, ali s obzirom da imamo NCCN preporuke šta bi trebalo raditi u ovoj situaciji, koja je realnost u Srbiji, šta mi možemo da uradimo i zašto?
Pa ono što bi bio osnovni koncept, preporuka NCCN vodiča je primjena neoadjuvantne terapije. Međutim, nije to velik broj zemalja koje imaju mogućnosti primjene neoadjuvantne terapije. Znači, nismo mi usamljeni, mnogo je više zemalja koje nemaju te mogućnosti nego koje imaju i naravno ukoliko nismo u mogućnosti, kao što mi u Srbiji nismo, onda naravno opet dolazimo do ključnog momenta, odnosno hirurgije u radikalnom smislu hiruškog tretmana. Ono što je bitno je da kad bi došli u situaciju, a sigurno ćemo jednog dana doći u tu situaciju da imamo pristup neoadjuvantnoj terapiji, je opet onaj multidisciplinarni tim koji treba da daje preporuku, ali naravno uvek se pozivamo i na to da treba ostaviti mogućnost izboru bolesnika za koji vid lečenja bi se opredelio. Ukoliko mu se sve predoči kakve su rezultati i očekivanja od svakog vida od ovih ponuđenih mogućnosti.
Hvala. We have seen in Piotr's presentation that what you would do.
This is a really current dilemma, but usually first we discuss also with the patient and in our multidisciplinary team, because we cannot use the second adjuvant, let's say. Here, of course, it would be possible because the patient is BRAF positive, so we could use dabrafenib trametinib post-surgery. However, it is not reimbursed in Poland, but generally this is the option. So usually we consider, it depends also on the age of the patient, all other factors. If the patient is eligible for ipi-nivo, usually we give 2 cycles of ipi-nivo in this situation and operate afterwards. If the patient is not very fit for ipi-nivo, which is generally preferable approach for metastatic disease for us, so usually we go to the surgery and observation because it's only local-regional disease. Sometimes we use rescue radiotherapy, but very rarely. Radiotherapy is now it's used an exceptional situation.
Dobro, pacijentkinja nije primila neoadjuvantnu terapiju jer nije dostupna, pa mislim učinjena je disekcija limfnog bazena i potvrđeno, ekstirpirano 18, metastaze potvrđene u 3 limfna čvora. Retestirana je ponovo, dobijena ponovo pozitivna mutacija, PT4B, N2B, M0, sad je znači resektabilni stadijum 3C. Moje pitanje je, Rado, pa jer smo trebali ponovo da retestiramo ili nam je bio dovoljan samo onaj prvi test BRAF statusa?
Potrebno je retestirati, naročito kod melanoma, jer je pokazano da čak u 20% ne postoji usaglašenost između molekularnog profila primarnog tumora i metastaze. A takođe i BRAF mutacija može biti jedan mehanizam rezistencije. U stvari generalna preporuka od uvek testiramo najnoviji uzorak, znači to je već drugo oboljenje, tako da fakt.
Samo što je ovde pitanje, ona je BRAF inicijalno bila pozitivna, tako da nam to za terapiju u suštini, je li tako? Da je bila negativna inicijalno, onda bi nam to verovatno bio veći značaj.
Ali da, ne postoji usaglašenost visoka kod melanoma.
Dobro. Stadijum 3C. I šta ćemo dalje sa pacijentkinjom, da li ćemo samo da je kontrolišemo, da li ćemo sa radijacionim onkologom da razmišljamo o lokalnoj radioterapiji, što je po preporukama, ili ćemo ponovo Borislava da je uputimo na konziliju?
first immunotherapy especially could be ineffective. But this is our preference for BRAF positive stage 3 disease, especially in younger patients, because they have in this long-term side effects, and usually the long-term results are better. Moreover, it does not produce the resistance to the combined immunotherapy if we have metastatic disease. So usually we propose to the patients dabrafenib, trametinib in stage 3 disease.
Šta ti misliš, Borislava? Da li bi bila situacija drugačija da smo dali target terapiju u drugom krugu adjuvantne terapije?
To bi bilo preporučljivo kada bi bili u situaciji da imamo mogućnost lečenja kombinovanom imunoterapijom, odnosno primjenom ipilimumaba. Obzirom da mi nemamo tu mogućnost, onda i taj moment da bolesnik odlučuje i da mu se daje akcenat na odluci bolesnika može da kažem, promeni tok, jer po svim ovim preporukama i rezultatima koje smo ovde izneli, relativno je mali procenat razlike koji dovodi do takvih odluka. Ali mislim da je u našoj situaciji ključna nemogućnost davanja ipilimumaba u metastatskoj bolesti.
Hvala ti.
Marko, samo da li misliš da ima potrebe?
Ne, svakako.
Definitivno, uvidom u sve dokazali smo da postoji bolest.
Znači, svi se slažemo da ne bi bioptirali za ovako kratko vreme.
Next. Now we need expert opinion from Piotr. What should we do next?
This is a very difficult situation because the relapse after adjuvant therapy is very fast. And so probably we'll start targeted therapy because Ipi/Nivo has low. Of course, it has some chance, but very low. Usually when we have longer term relapse after adjuvant therapy, we use Ipi/Nivo as a first-line therapy without any doubts. But here is very fast progression of the disease and multifocal, so probably we'll use encorafenib, binimetinib usually we use in the first line in this situation.
Da li nam, recimo, da li nam ovi vodiči EADO guidelines iz 24. godine, Milice, mogu malo pomoći da se odlučimo? Evo, čuli smo encorafenib, binimetinib, target terapija, ali kad bi pratili ove algoritme, došli bi do toga istog, zar ne?
Da, mi došli bi do istog, znači ovaj sa desne strane je u stvari naša pacijentkinja koja je prvo bila u 2. C, pa je bila u 3. C, pa je sad u 4. stadijumu bolesti, nakon 2 adjuvantne imuno-onkološke terapije od po godinu dana i nakon verifikacije da postoje udaljene metastaze. Mi smo u suštini njoj dali u startu, jer imala relaps bolesti manje od 6 meseci nakon terapije, dobila je anti-PD1 antitelo. Za nju bi u suštini sledeća opcija terapijska bila BRAF i MEK inhibitori, obzirom na to da je BRAF pozitivna, ili sledeća opcijska varijanta bi bila IPI plus nivo. Za relaps koji je nastao posle 6 meseci bi dobila BRAF i MEK inhibitor za BRAF mutirane i u sledećoj opciji bi dobila IPI plus nivo. To je naš pacijent. Odnosno terapijska opcija je mogla da bude i drugačija, da ona u adjuvantnom settingu dobije BRAF i MEK inhibitor i onda bi već ta terapija bila drugačija. Na osnovu ovih vodiča mi smo postupili, da kažem, ispravno vezano za naš case report.
Da, hvala. Pacijentkinja je i dobila target terapiju, ali je dobila dabrafenib, trametinib, jer to je kod nas dostupno. I sad smo imali evaluaciju nakon 4, nakon 8, nakon 12 ciklusa terapije i kao što vidite, odgovorila je sasvim dobro, od parcijalnog odgovora i dalje regresije do kompletnog odgovora plućnih metastaza, kompletnog odgovora subkutanih depozita, ali ta retroperitonealna masa je se sporo smanjivala, nakon 12 meseci 15%, nakon 18 meseci je, samo promenite, 20% regredirala. Tada smo posle 20 meseci terapije uradili ovaj naš PCT, koji je pokazao zaista odsustvo bolesti, ali u retroperitoneumu i dalje postojanje te neke mase sa jednim vrlo niskim vezivanjem, odnosno metabolizmom glukoze. I sad je ono moje krucijalno pitanje za naše drage hirurge ovde prisutne, da li ima mesta hirurgiji u metastatskoj bolesti? Doktore Jevriću, jeste mi prvi na redu tu? Da.
Naravno da ima, treba biti oprezan i diskutovati o svakom pacijentu ponaosob. Nekad se radi iz palijativnih razloga ako ima pacijent simptome krvarenja ili obstrukciju. U ovom slučaju on ima dobar odgovor, ima jednu masu koja je zaostala nakon terapije. Svakako bi on bio kandidat za neko hiruško lečenje na našem konzilijumu.
Svi hiruzi se slažu.
Svi hiruzi se slažu. Šta kaže Piotr?
If the patient had only oligometastatic disease, so the surgery is fine. But the patients had really multifocal disease when started the treatment so no surgery, not at this stage. But if you will have only one focus, which we will start to regrow, yes, the local treatment can be interesting option. We use surgery or stereotactic radiotherapy in this situation, especially in this location where the surgeon can be much more morbid than radiotherapy. And this is a good idea to do something locally, but if we have a focal progression only, not to use surgery at the beginning multifocal disease.
Da, pacijentkinja jeste operisana. U patohistološkom nalazu naravno bilo je benigno. My comment for Piotr now. She did get surgery, everything was clear. What would you do now? This is really important to comment.
Okay, but it can happen because imaging does not evaluate well the pathological response, what I also mentioned. But so it's a good sign, okay, for the patient, for the further treatment, and definitely the patient should be treated lifelong until the progression with targeted therapy, because stopping targeted therapy in metastatic disease means the progression of the disease nevertheless.
I na kraju samo evo da kažemo, Ivane, šta mi možemo, a u stvari šta bi trebalo. Znači imamo fantastične, ja mislim, onkološke hirurge, bilo opšte, bilo plastičare, odlično sarađujemo, imamo odlične radijacione onkologe, uključujući upravo i taj X nož i gamma nož, stereotaksičnu radioterapiju. Međutim, mi malo ovako medikalni onkolozi, nama stalno nešto fali, ja bih rekla. Znači, dostupna nam je adjuvantna terapija za stadijum 3, za stadijum 4 imamo imunoterapiju. Ono što nam nije dostupno zvanično je anti-CTLA4 ipilimumab, ali ga imamo pod određenim okolnostima, i ono što nam znači nije dostupno je neadjuvantna terapija i adjuvantna terapija stadijuma 2B i C i retretman.
I wonder how the political decisions are reliable, because here it's nonsense to use anti-PD-1 and anti-CTLA4 separately, because now we know that combination of ipi/nivo is first much more effective for the patient, and second is cost effective. So the decision to finance only one and second, it's very not clever at all, because you are losing patients and you are losing money. And this should be really persuaded, because the combination of ipi/nivo means that usually you are giving 3 cycles median because of the toxicity, and you stop the treatment and you have 50 to 60% disease control rate, and about 40 to 50% are long-term survivors. That's all. And usually you can stop the treatment after some time. This never happened for such situation. For nivo, okay, you have the disease control at the level of 30%, but especially after adjuvant therapy, you haven't a good option. Because if you have progression after adjuvant therapy, so ipi/nivo is much better option now. So this is why I think that this should be clearly shown, that now you have several analyses that the combination of ipi/nivo is much better in terms. We have long-term 10 years overall survival data. This is first. Melanoma-specific survival is improved 10%. And moreover, this is much more cost-effective because the median time of the treatment is shorter than for anti-PD-1. So,
Piotr, thank you very much for this, what we say, final touch on our story. That was something that I was starting to ask Željko, and we are all on the same, I should say, front in this battle. And generally, we are expecting in a few weeks, 2 weeks, this melanoma days, and then we'll get together and what I think we all share the idea that we get all the information, all medical evidence, and then start again to push, because it is not either illogical, but thank you. We probably needed someone to tell us. So we all know that, and I thank you. And if there is no other question from the audience, I apologize to not to the MSD, but to colleagues that were waiting for another symposium. We had little technical problems, and we started about 8:30, so we are not much out of time, and okay, we'll continue, and I wish you all the best.
Nastavljamo odmah dalje sa simpozijom. Kafe pauze nema. Izvolite sesti. Ja ne znam da li da ja sedem ili da ja da ispričam uvod pa da sedem. Ajde ću. Gde nam je panelist? Broj 3. Mi ćemo završiti do 11. Da. Samo što travel time. Gde nam je treći panelist? Marijana. Da. Poštovane koleginice i kolege, nastavljamo sa simpozijom kompanije MSD, koji će govoriti o, naravno, imunoterapiji, koji će govoriti o nauci, ali koji će govoriti o tome kako tu nauku treba primeniti i kako ta nauka treba da bude dostupna svima i inovativne terapije treba da budu dostupne svima. Sa mnom je uvaženi panel, doktorka Marijana Milović, koja upravo svečano ulazi u salu i penje se na binu, doktorka Suzana Matković, obe sa IRS-a i doktor Zoran Andrić sa KBC Bežanijska Kosa i naravno četvrta stolica su svi oni pacijenti koji čekaju inovativnu terapiju, koju smo dobili u posljednjih 6 meseci, ali naravno jako mnogo još je indikacije i bolesti koje nemaju adekvatnu terapiju i za koju dalje treba naravno da se borimo. O čemu ćemo pričati danas? Prva stvar, kao deo Evrope, nadam se jednom i Evropske unije, pričat ćemo o ključnim porukama iz Evropskog plana za borbu protiv raka. Šta su to Evropljani izdvojili, šta je to bitno i šta je to najbitnije za sve. Naravno, ulogu imunoterapije vrlo dobro znate, imamo veliko iskustvo sad sa različitim indikacijama, dotaći ćemo i naše iskustva, do sada naučene lekcije, ali i ono gde želimo da budemo, nadamo se, u bliskoj budućnosti i na kraju ćemo imati diskusiju. Zašto je sve ovo bitno? Zašto je bitna onkologija uopšte? Zato što 2020. godine ste imali 20 miliona slučajeva raka i skoro 10 miliona umrlih od raka. Za 20 godina ćemo imati 32 miliona umrla od raka i 16,9 miliona umrlih i to nije moglo da prođe nezapaženo u svakoj ozbiljnoj zemlji, u Americi i u Evropi. I onda je Evropska unija napravila takozvani Evropski plan borbe protiv raka, koja govori u pravcu dve stvari. Jedna stvar je da se poboljšaju ishodi od karcinoma, odnosno smanji smrtnost, poveća dijagnostiku u ranijim stadijima, poboljša nauka i inovativne terapije, ali ono što je Ursula von der Leyen takođe istakla je da svaki deo Evrope treba da ima istu dostupnost inovativnih terapija, istu dostupnost dijagnostike i svuda da budu vrlo slični ishodi. Imamo jako puno koraka do tog trenutka, ali koji su osnovni delovi tog kancer plana? Pre svega prevencija, kako primarna, promena stila života, ishrane i naravno veći obuhvat HPV vakcinacijom, jer to je zaista nešto što može da spreči karcinom u potpunosti, rana detekcija, ono što mi zovemo screening, da poboljša se screeningu tamo gde nije razvijen i naravno dostupnost kako dijagnostike i terapije i što veći broj izlečenih koji će posle toga biti praćeni na sve ono što može da se desi nakon izlečenja raka. S jedne strane to postižemo naukom, ali s druge strane smanjenjem nejednakosti u dostupnosti dijagnostike i terapije. I jedan od tih 10 ključnih inicijativa je ono o čemu ćemo sada govoriti, a to je dostupnost inovacija. Nauka stalno napreduje, za 70 dana se duplira znanje iz onkologije i da bi to znanje primenili i na ishode, to svuda mora da bude dostupno. Šta je urađeno u poslednje vreme, u poslednjih 30 godina u najrazvijenijim evropskim zemljama, to su naravno nordijske zemlje, isto ovakvu sliku imamo i u Sjedinim Američkim Državama. Poboljšavaju se ishodi lečenja, odnosno veća stopa izlečenja raka. Naravno, oni su na vreme sredili svoje screening programe, svoje mere primarne prevencije i to je najviše uticalo da od 90. godina do recimo 2010. ili 15. godine doprinese ovakvom napretku. Od 2015. na ovamo svaki napredak u najrazvijenijim zemljama sveta je zbog inovacija, odnosno inovativnih terapija koje doprinose boljim ishodima. 152 nova leka su registrovana u periodu od 2004. do 2022. Od 2022. na ovamo još čitav niz. I do pre par godina zemlje nisu imale adekvatan način da procene koji je lek, uslovno rečeno, korisniji od onog drugog. I onda ESMO razvio takozvanu ESMO benefit skalu koja je izuzetno bitna i koje implementiraju maltene skoro sve zemlje Evropske unije. Ono što sada ESMO razvija je taj ESMO reimbursement model koji osim ESMO skale uključuje i ekonomske parametre koji su izuzetno bitni i mi se nadamo da će i taj reimbursement model uskoro videti svetlost dana i da će opet sve evropske zemlje ga usvojiti kao neki standard. Gde smo bili do pre par godina, ovo je dostupnost lekova u onkologiji u različitim zemljama, mi smo i uvek smo maltene bili pri dnu, ono što se desilo je 17 novih lekova od te analize na ovamo, popeli smo se par mesta, ali ponovo imamo gap u onome šta nam je potrebno i šta bi bio optimalno lečenje za naše pacijente. Zašto je opet to važno? Svakih 10 godina se desi neka revolucija u inovativnoj sistemskoj terapiji, odnosno u sistemskoj terapiji raka i tako je 70. i 80. godina došla inovacija koji su bili citostatici, doksorubicin, cisplatin, izlečili smo limfome, izlečili smo karcinom testisa. Pa je onda negde od početka 2000-ih pojavila se target terapija, svi znamo šta su radili Glivek, Herceptin i naravno čitav niz lekova nakon toga i negde pre 10 ili možda i već pa i 15 godina je počela ta revolucija imunoterapije. Danas imamo i antibody drug konjugate, ali imunoterapija je u stvari i dalje negde na početku svog razvoja i nije doživjela svoj maksimum. Dokaz da imunoterapija ima ekstremnu važnost u onkologiji je i broj registracije pembrolizumaba, odnosno Keytrude u Evropi. 31 indikacija je sada u Evropskoj uniji i ja sam stvarno želeo da svaku indikaciju ponaosob čitam i zašto je ta indikacija, ali mi nisu dali iz MSD-a, ne znam zašto. Ali ovo su one indikacije koje su u Evropi. Kakva je situacija u Srbiji? Mi smo u Srbiji pre godinu dana imali 23 registrovane indikacije i nažalost samo 2 dostupne, to su metastatski melanom i nesitnoćelijski karcinom pluća sa visokom PDL1 ekspresijom. Danas je situacija nešto bolja, ali dalje vidite jako velik broj zaključanih ormarića. Imamo 6 dostupnih terapija, uz prve 2 imamo i karcinom pluća sa nižom ekspresijom, adjuvantni melanom u 3. stadijonu i triple negativni karcinom dojke, kako metastatski, tako i rani. I to otprilike se vidi isto na ovom slajdu, to su one indikacije koje mi koristimo u svakodnevnoj praksi, sad i već imamo veliko iskustvo, ali ono šta se proširio se broj ormarića. Sa 23 smo otišli na 27 i sad imamo 6 dostupnih indikacija od 27. Tu smo negde jedni od najlošijih u regionu, samo Bosna i Hercegovina ima nešto manje dostupnih indikacija pembrolizumabu u odnosu na nas, ali evo radimo na tom i sada razgovaramo o tome šta su nama prioriteti i šta treba da nam bude dostupno u narednom periodu. I krećem sa svojim panelistima. Doktorka Matković, prvo pitanje je koliko je živo pacijenata koji su učestvovali u kliničkim studijama sa pembrolizumabom sa metastatskim melanomom. Sećamo se do pre 10 godina da je otprilike prosečno preživljavanje sa DTI-CM bilo oko 6 meseci. Koliko je sada živo nakon 10 godina?
Ja ću početi sa onom već ovako malo, rekla bih, istršenom rečenicom da je primjena imunoterapije dramatično, revolucionarno, kako god hoćete, izmenila paradigmu lečenja metastatskog melanoma, a to najbolje znamo mi, evo Laza je spomenuo, koji se time i bavimo. O 10-godišnjem preživljavanju, koliko je živo, nismo ni razgovarali. Znači, a koliko je danas u ovim studijama živo, ovo je upravo ta studija pembrolizumab versus ipilimumab, 10-godišnji follow-up. Znači, to je nešto što smo mislili da može da bude i nedostižno, ali evo, tu smo. To su upravo rezultati 10-godišnjeg praćenja, samo ako pogledate ovaj desni forest plot, vidjet ćete kakva je prednost primene pembrolizumaba kod ovih pacijenata, onih koji u stvari imaju lošu prognostički gledajući bolest sa povećanim LDH, sa balki bolešću, sa metastazama u mozgu. I evo vam odgovor, evo Lazo, odgovor na tvoje pitanje, 34% pacijenata sa metastatskim melanomom je živo nakon 10 godina.
Da, to nam govori o prilog nečega što se zove koncept izlečenja metastatskog raka. I ja mislim da je imunoterapija, kada se sve ovo vidi, nešto što menja koncept od nečega što smo zvali neizlečiva bolest, danas zaista možemo da izlečimo metastatski rak. Ali ono što je takođe važno da uz hirurgiju u nekim indikacijama koje su agresivne i koje imaju tendenciju da se bolest vraća, imamo dobru perioperativnu terapiju. Koje su to 2 indikacije jako važne? Jednu imamo, a drugu očekujemo, gde je pembrolizumab produžio ukupno preživljavanje kad se daje u neoadjuvantnoj, odnosno adjuvantnoj fazi.
Pa, kao prvo, imamo divne vesti sa posljednjeg ESMO 2024. godine, Keynote 522 studija koja je pozitivna i u smislu ukupnog preživljavanja. Mi svi znamo koliko je teško u ranom settingu dokazati benefit u ukupnom preživljavanju, ali definitivno Keynote 522 je apsolutno pokazala da dodatak pembrolizumabu u neodjuvantnom settingu uz hemioterapiju, a potom adjuvantno nastavljeno nakon hirurgije, donosi prednost u ukupnom preživljavanju. Praktično ta delta je 5% i relativna redukcija rizika za smrtni ishod praktično 34%. Definitivno danas imamo više opcija i čak i kada ispred sebe imamo i brka pozitivnog pacijenta, nije nam lako da odlučimo, jer mi sad imamo i ukupno preživljavanje sa pembrolizumabom i ukupno preživljavanje tada, naravno, Olimpija studiji, tako da definitivno ovde pembrolizumab u ranom settingu karcinoma dojke je nešto što su zaista divni rezultati i obradovalo naše pacijentkinje.
To je tvoje. Ali imamo i drugu studiju, Keynote 564, praćenje 57,2 meseca kod karcinoma bubrežnih ćelija, adjuvantna terapija. Ovo što je u većini, retko se u stvari dešava u kliničkim studijama da se potvrdi prednost, statistički značaj na ukupnom preživljavanju primenom adjuvantne terapije, a to je u ovoj studiji postignuto, to su rezultati ovogodišnji i to je u stvari prva potvrda produžetka ukupnog preživljavanja primenom adjuvantne terapije pembrolizumabom kod karcinoma bubrežnih ćelija. To je jedina u stvari potvrda, jedina klinička studija koja je to potvrdila.
Hvala lepo. Mi već dovoljno dugo imamo Keytrudu u lečenju karcinoma pluća, nesitno-ćelijskog karcinoma sa visokom PDL1 ekspresijom, dovoljno dugo da imamo naše rezultate. Doktor Andriću, kakvi su naši rezultati i zašto je uopšte bitna ova terapija karcinoma pluća?
Pa znamo da je Keynote 024 etablirala Keytrudu među prvim indikacijama i znamo da je... Ja mislim da sam promenio. I znamo da je na osnovu Keynote 024 i u Srbiji lek na pozitivnoj listi kao prva indikacija i kao što se vidi ovdje na 5-godišnjem nivou, razlika je dupla u preživljavanju između bolesnika koji primaju Keytrudu ili versus hemoterapija, tako da je to nesporno. Mi danas u našoj svakodnevnoj praksi, iako znamo da je Keynote 024 imala terapiju 35 ciklusa maksimalno, mi danas imamo pacijenata koji neće da odustaju, ne možemo i da iskinemo sa terapije i to se samo dodatno dodava na fond i na kraju u stvari umanjuje ukupnu svotu novca koja bi se mogla možda rasporediti na druge indikacije. Tako da imamo danas u Srbiji pacijenata koji su primili i po 120 ciklusa terapije. I pored nuz efekata, pored svega, oni dalje ne odustaju.
Ali su živi.
Pa možda bi bili živi da su prekinuli. To je ta začkoljica, zato što mi treba da možda prekinemo nakon 35 ciklusa, pa da čekamo progresiju. I da je opet reintroduciramo tu istu imunoterapiju.
Hvala, Zorane. Videli smo gde smo bili, šta radimo, kakvi su i naši rezultati i tako dalje, ali ono što je u onih 27, od kojih je 21 nedostupno, nekoliko ima izuzetno važnih za nas. Jedno je cervikalni karcinom, karcinom bubrega, karcinome glave i vrata i još jedna indikacija u karcinomu pluća. Tako da molim Marijanu da nam ispriča koji su rezultati Keytrudu lečenju cervikalnog karcinoma i zašto je to bitno da nam bude jedna od sledećih dostupnih terapijskih opcija. Ne znam da li želiš ovde za stage ili ovako dobro.
Mislim, lakše mi je, a i naočare su bolje. Šta je to ključno za persistentni metastatski i rekurentni karcinom grlića? Ono što je, nažalost, tužno i neslavni podaci za našu zemlju, prema stopi incidencije i mortaliteta, Srbija je na 3. mestu na svetu u 2020. godini i prema podacima Svetske zdravstvene organizacije. U Srbiji tokom 2021. godine imamo registrovano 1085 novoobolelih i negde skoro polovina umrlih žena. Ono gde želim apsolutno sve nas da podsjetim i da apsolutno moramo da povećamo awareness i svesnost da je vakcina došla, praktično sve domove zdravlja, vakcina protiv glavnog uzročnika ovog karcinoma, 9-valentna, koja treba da se primeni i dostupna je za sve devojčice i dečake u uzrastu 9 do 19 godina o trošku RFZO. Takođe, screening za karcinom grlića materice nije apsolutno razvijen u našoj zemlji i sve moramo da učinimo prvenstveno da podignemo svest o ovoj bolesti i da ako možemo ovu bolest grlića materice prepoznamo u prekanceroznim fazama. Ali, nažalost, u Srbiji za sada situacija nije dobra. Jako mnogo imamo persistentnih, rekurentnih i metastatskih karcinoma grlića, tako da je za nas posebno važna studija Keynote 826, koja je imala zadatak da dokaže da li Keytruda, dodata dabletu hemijoterapije sa ili bez bevacizumaba, donosi dodatnu prednost u odnosu na placebo i hemioterapiju i bevacizumab. Ukupno je bilo 617 pacijentkinja randomizovanih u odnosu 1:1, a uključeni su bili pacijenti sa persistentnim, metastatskim i rekurentnim karcinomom grlića materice. Primarni ciljevi dualni su bili i ukupno preživljavanje i PFS, a sekundarni objektivni odgovor i trajanje navedenog odgovora. Ovde ćemo danas izdvojiti uglavnom pacijenta o kojima pre svega danas pričamo i gde je glavna indikacija i EME, a naravno i kod nas u ALIMS-u, a uskoro nadam se i u RFZO-u, to su pacijentke sa CPS skorom 1 i većim. Vidimo da su osnovne karakteristike pacijenata išlo u pravcu da je bilo više bele rase, da je histologija bila dominantno skvamocelularnog karcinoma, ali ono što želim da poentiram da je 63% pacijentkinja, praktično 2/3 primilo bevacizumab, 1/3 nije primila, a negde u nekoj studiji sličnog karaktera sa atezo praktično sve pacijentke su primale bevacizumab. I vidimo nakon 39 meseci praćenja da imamo sjajnu divergenciju Kaplan-Majerove krive i jasan pokazatelj porasta medijana ukupnog preživljavanja za više od godinu dana i redukcija rizika za smrtni ishod 40%. Statistički i klinički izuzetno značajno za naše pacijentkinje. Takođe, promptni odgovori i objektivni response rate 68,5%, daleko frekventniji u odnosu na granu bez pembrolizumaba, gde je 50,9%, takođe 10% više kompletnih remisija, čak 26% kompletnih remisija u metastatskom karcinomu grlića. A i trajanje tih odgovora je bilo negde za 9 meseci duže, 19 meseci u odnosu na 10 bez pembrolizumaba. A kada govorimo naravno o profilu toksičnosti, najčešća toksičnost je bila anemija, ali da vas podsjetim, anemija je pre svega rezultat kako davanja hemioterapije, tako i rezultat same konstitucije bolesti, jer svi znamo da opsežni karcinom grlića je jako često praćen sam po sebi anemijom hronične bolesti. Ali kada govorimo o imunološki posredovanim reakcijama, one su zaista bile retke i bile su uglavnom niskog gradusa. I ono što bih zaključila da zapravo Keynote 826 je impresivna studija koja je kod pacijentkinja sa persistentnim, rekurentnim i metastatskim karcinomom grlića sa CPS skorom 1 i većim pokazala jasan, statistički signifikantan i klinički izuzetno značajan benefit u pogledu ukupnog preživljavanja i PFS-a, relativna redukcija rizika za smrtni ishod i progresiju 40%, sjajni objektivni odgovori 68%, mnogo kompletnih remisija, a što se tiče safety profila, apsolutno prepoznatljiv, bezbedonosni profil, sigurnosnih nekih novih signala nije bilo, lako za rukovanje jer već imamo dugo iskustvo sa imunoterapijom, samo treba da na vreme primetimo neželjeni efekat i da na vreme krenemo da zapravo hendlujemo sa redukcijom doze. I ono gde sam htela da nama kliničarima pojasnim koliko je zapravo važno dati dodatno bevacizumab. Pa kako vreme odmiče i kako medijana follow-upa je sve duža i duža, vidimo da se ovi hazard ratio približavaju. Tako da ukoliko su pacijenti primili i pembro i bev, vidimo da je hazard ratio 0,61, a ne mnogo bitno različito i ako nisu primili bev 0,67. Da benefit postoji, ali on je umeren. Tako da vidjet ćemo, nadam se da će fond obezbediti i kod CPS 1 i većih i pembro i bev, ali ukoliko to ne bude slučaj ili imamo fistule, nemojte mnogo da se sekirate ako bev ne možete dati. Međutim, ono što jeste važno, NCCN vrlo brzo reaguje na ovako sjajne rezultate i više nego jasno kategorija 1 i najviši nivo dokaza da PDL-1 pozitivnu populaciju metastatskog karcinoma grlića, apsolutno tablet hemioterapije sa ili bez beva i obavezno pembro. A šta je u Srbiji situacija? Pa do pre samo 2 godine mogli smo davati samo cisplatinu. Užasno smo bili frustrirani. Negde od prošle godine smo malo manje frustrirani, možemo dati i off-label taxol zajedno sa platinom. Ali ono što zaista želimo, to je da damo kompletnu terapiju za naše pacijentkinje. Tipični pacijent za karcinomom grlića izgleda da je otprilike mlađa žena, znači radno aktivna i u punoj životnoj snazi. Uglavnom, jedna od tih pacijentkinja se javila sa jačim menstrualnim krvarenjem, abnormalnim vaginalnim iscetkom, neobjašnjivim bolom u donjem delu leđa. Papa je bio abnormalna kolposkopija sa biopsijom, otkrila adenokarcinom grlića materice. Magnet rezonancije otkrio prisustvo mase na grliću materice, ali i invaziju i epitela mokraćne bešike. Na petu vidimo hipermetaboličnu leziju na grliću, ali nažalost i u kalici i lezije na jetri. Ovo je bio 4B stadijum. PDL-1 skor je pokazao da je CPS 5, znači pozitivan, i dijagnoza je bila FIGO stadijum 4B, adenokarcinom grlića materice. Šta smo mogli? Mogli smo da damo tablet, paklitaksel i cisplatin. A šta je trebalo da damo? Trebalo je naravno da damo i pembrolizumab, po mogućstvu naravno i bevacizumab. I ovih pacijentkinja ovog tipa ima oko najmanje 200 u ovom trenutku kojima je zaista neizmerno potrebna ova terapija. A zašto? Sa onom cisplatinom mogli smo negde da dosegnemo medijanu ukupnog preživljavanja 12-13 meseci. Sa dodatkom beva još od 14. godine, već 10 godina znamo da bi ta medijana overall survival bila čak 17,5 meseci. Ali nismo imali ni bev. A sada sa Keynote 826 možemo da omogućimo da našim pacijentima da one žive čak skoro 30 meseci. Medijana ukupno preživljavanja 28,6 kod CPS 1 i veći. I naravno, naša osnovna uloga je da idemo ka fondu sa ovim rezultatima. Ali da, i naši ciljevi i globalni ciljevi Svetske zdravstvene organizacije za eliminaciju raka grlića, prvo i najvažnije, da se vakcinacija uradi apsolutno u kompletu, najmanje 90% devojčica i dečaka. I naravno, skrining je obavezan kako negde oko 35. potom i oko 45. godine. On ne sme da bude oportun, on mora biti obavezan, jer zaista dugo traje proces karcinogeneze kod grlića i zaista je lako prepoznati i CIN1, i CIN2, i CIN3. Imamo vremena, ali ne možete ići kod ginekologa na 3 godine. Morate videti ginekologa svake godine. I naravno, s obzirom da nažalost i dalje imamo mnogo persistentnih, rekurentnih i metastatskih, tretman za sve naše pacijentkinje je hitno potreban. Divno je što je MSD omogućio da ćemo uskoro moći i da testiramo i da za neki veliki broj pacijenata dobijemo pembrolizumab, ali ono što zaista moramo da obezbedimo već i da uskoro ta neka bliska budućnost, da fond prepozna neizmeran značaj i potrebu za sve naše, uglavnom mlade pacijentkinje i da zaista mogu da žive duže i kvalitetnije.
Hvala Marijane. Ja zaista mislim da je ovo jedan od prioriteta fonda u narednom periodu. UMOS forum je bio vezan za HPV malignitete. Karcinom pluća imamo neke indikacije. Ja mislim da svaki pacijent sa karcinom pluća u jednom momentu treba da dobije imunoterapiju, da je to jako bitno. I šta je sad ključno za bolje ishode kod ovih pacijenata sa karcinom pluća? Šta nam je još potrebno da bi bili još bolji?
Pa, uspeli smo u karcinomu pluća da otključamo 2 indikacije, to je na osnovu pomenute studije Keynote 024 i na osnovu studije Keynote 189 za bolesnike koje su od PDL-1 pozitivne od 1 do 49. Međutim, za skvamoznu indikaciju, studija koja je to objasnila sve i uspešno indikovala lek pembrolizumab u skvamoznoj etiologiji, u Srbiji, nažalost, nije na pozitivnoj listi. Znači, u Srbiji su na pozitivnoj listi non-skvamoz, non-small cell kancer, znači adenokarcinomi i non-skvamoz ostala patologija, dok je skvamozni uskraćen. Znamo da je u Evropi i Americi to registrovano, znači u prvoj liniji, studija Keynote 407, znači hemoterapija plus Keytruda za sve nivoe PDL pozitivnosti, znači primarni cilj ukupno preživljavanje PFS, 4 ciklusa nakon toga terapija održavanja, dozvoljen crossover, što je mnogo bitno, znači u bolesnici koji su primili placebo, nakon progresije bolesti, bio im je dozvoljen crossover, to je primanje pembrolizumaba. I pored toga svega što je dozvoljen crossover, koji je bio čak u nivou preko 50%, razlika u PFS-u je impresivna, znači 38% bolesnika imalo benefit od dodatka pembrolizumaba u ovom settingu, znači u ukupnoj populaciji, znači i oni od 0 pa do 100 su imali određeni benefit, što je stvarno impresivno. Takođe, ukupno preživljavanje, razlika 6 meseci i dalje, i tu, u tom delu, znači ukupno preživljavanje, preko 30% bolesnika ima benefit od dodatka pembrolizumaba i, kao što vidite ovde, crossover, preko 50%, znači bolesnika je primala pembrolizumab u onoj grani koja je primala placebo nakon progresije bolesti. Nuz efekti, slični s obzirom na hemoterapijske protokole, razlika u imunnim odgovorima, takozvani imunomodulativnim, tim odgovorima koji su povezani sa imunoterapijom. Međutim, u gradu 3 i 5, samo 13% bolesnika je imalo značajniji nuz efekat. Sad tu dalje ne produbljujemo, što se tiče same imunoterapije, već ste rekli ovde da su endokrinopatije glavni problem. Čak i dijabetes u nekim slučajima. Znači, šta je preferirajući protokol za skvamozni karcinom pluća od 1 do 49%, prva linija, svakako je tu pembrolizumab na prvom mjestu u kombinaciji kod non-skvamozne etilogije sa pemetrexedom, a kod skvamozne paklitaksel ili nab-paklitaksel. Evropski vodič isto to, ali znači u tom prvoj liniji, znači kod bilo koje ekspresije od 0 pa do 100 je indikovan pembrolizumab u prvoj liniji. Tako da je to jedna indikacija koja nije trenutno na fondu i trebalo bi da se prioritizuje, po mom mišljenju, jer je nesitoćelijski karcinom pluća i generalni karcinom pluća je na prvom mjestu kod muškaraca po učestalosti, kod žena na drugom, sa tendencom čak da prestigne, ukoliko ne ukinemo pušenje, i karcinom dojke koji je na prvom mjestu. Srećom, u Srbiji je pokrenuta studija koja nudi tim bolesnicima od 0 do 100 mogućnost da prime pembrolizumab. Dakle, nadamo se da će ona zameni period do postavljanja pembrolizumaba na pozitivnu listu. Tipični pacijent, znamo ko su ti tipični pacijenti, stariji muškarci, pušači, tegobe karakteristične za karcinom pluća, da ne produbljimo. Znači, češće u Srbiji uznapredovala bolest i evo ovde što se tiče combined positive score kod njega 10, tako da on je kandidat za trenutno u Srbiji kombinaciju hemoterapije i paklitaksel, karboplatin ili gemzar karboplatin, zavisno od preferencija. Svakako dodatak pembrolizumaba bi njemu omogućio duže preživljavanje, što je najvažnija stvar. Znači, ovo je prva indikacija na pozitivnoj listi, ovo je druga, znači magnituda clinical benefit score 5, znači najveći nivo benefita, takođe i u kombinaciji sa neskvamozne etilogije kod bolesnika koji imaju 1 do 49%, i takođe na pozitivnoj listi fonda, ova naša indikacija, u skladu sa studijom 407, treba da se izborimo, da se nekako ubaci na tu listu i da ti bolesnici koji imaju isti tumor pluća, samo što je ovaj neskvamozni, ovaj skvamozni, sad ovi mogu, ovi ne mogu. Što ja mislim, treba pitati ovoga zaštitnika ljudskih prava. Dobro. Zahvaljujem.
Hvala lepo. Ono što sledeće planiramo da bude najverovatnije UMOS forumi i što je, ovo nije taj koji menja, nema veze, menja ovaj drugi, nije važno, je karcinom bubrega. Karcinom bubrega nakon mnogo studija, ne menja ni ovaj, nakon mnogo studija, bravo. Stala je tehnika. Sad je promenilo do... Sledeće nam je doktorka Matković. Dakle, ono što sam hteo da kažem, a mučili su na slajdovi, je to da je sledeći umosforum najverovatnije vezan za karcinom bubrega. Jer jako dugo vremena, prvo nemamo optimalnu terapiju u metastatskoj fazi, a drugo, konačno se pojavila studija u adjuvantnoj fazi, posle mnogo pokušaja da produžava kako vreme do povratka bolesti, tako do ukupnog preživljavanja. Koja je to studija i kakvi su rezultati i u karcinomu bubrega, a posle u karcinomu glave i vrata, koji je takođe važna indikacija za imunoterapiju.
Jeste, tačno tako, samo bih molila taj menjač. Da li mogu da kažem možda da svaki pacijent, ali ne baš svaki, ali sa karcinomom bubrežnih ćelija treba da primi imunoterapiju. Tako si rekao za karcinom pluća, znači svaki pacijent sa metastatskom bolešću, svetloćelijskim karcinomom bubrežnih ćelija treba da bude lečen imunoterapijom. To je upravo ovo što smo rekli, koja se do duše daje u kombinaciji sa inhibitorima tirozin kinaze, ali svaki pacijent sa visoko rizičnim karcinomom bubrežnih ćelija nakon operativnog lečenja bi trebao da primi adjuvantnu terapiju, upravo na osnovu rezultata studije za koji ću vam reći neke osnovne karakteristike. Samo da vas na početku podsjetim da određen broj pacijenata ima visok rizik za razvoj, za ponovnu pojavu bolesti nakon nefrektomije i ovo je upravo podaci analize jedne ankete koja je rađena, obuhvatila 105 lekara u 5 zemalja Evropske unije, Francuska, Nemačka, Italija, Španija i Velika Britanija, koji leče preko 3800 pacijenata sa RCC-om mesečno, na osnovu kojega se došlo do zaključka da gotovo polovina, 48% pacijenata nakon primarnog lečenja razvije relaps bolesti, a od toga 60% ima metastatsku bolest. Znači, potreba za lečenjem i u ranim fazama, a i u metastatskoj bolesti je vrlo jasna. Ovo su NCCN preporuke i ESMO preporuke za 24. godinu, gde se jasno i u jednim i u drugim vidi pozicionirana, u stvari preporuka za primenu pembrolizumaba kod visoko rizične bolesti nakon nefrektomije, znači i jedni i drugi vodiči su u potpunosti usaglašeni, pri čemu, ako se ne varam, za adjuvantno lečenje, kako se već to označava kod nas u ESMU, to je najviši nivo dokaza. Studija 564 KINOT, znači uključivala je pacijente nakon radikalne nefrektomije koji su imali visok rizik, koji je definisan na jedan određen način, to ćemo videti malo detaljnije na kraju, znači intermedijarni visok rizik, ali ono što je bilo vrlo zanimljivo i vrlo su zanimljivi podaci, iako tih pacijenata nije bilo previše, to je metastatska bolest koja je podvrgnuta hiruškom lečenju, koja se nalazi u NET stadijumu bolesti, znači M1 NET stadijum bolesti, koji su randomizovani da prime adjuvantni pembrolizumab u odnosu na placebo, pri čemu je vrlo jasno da je pembrolizumab davan tokom godinu dana, kao i u svakom adjuvantnom settingu, i naravno primarni cilj je bio preživljavanje bez ponovne pojave bolesti, a ukupno preživljavanje, koga stalno spominjemo, koje nam je ovde u stvari krucijalna stvar, je bio jedan od sekundarnih ciljeva. To su bili dominantno muškarci, kao što se i očekuje shodno epidemiološkim podacima, neke srednje životne dobi 60 godina, ovo po meni performans 0 i 1, ja stalno to nešto pričam, meni je to ne isto, ali vrlo slično, znači bili su dobrog opšteg stanja. N0 bolesti imalo 94% pacijenata, sarkomatoidnu komponentu 11% pacijenata, a ona celu priču čini prognostički lošijem i čini da se radi o bolesti višeg rizika, i kao što se vidi 92% pacijenata je imalo radikalnu nefrektomiju. Ovo su prvi rezultati Znači, dati od strane istraživača u celokupnoj populaciji, znači preživljavanje bez ponovne pojave bolesti, medijana follow-upa 20, nešto više od 24 meseca, jasno se vidi ta razlika, znači 24 meseca preživljava preko 77% pacijenata koji su primali Pembro u odnosu na 68, ako dobro vidim, onih koji su primali placebo. Međutim, ako idemo dalje follow-up, 30,1 mesec, već se ove krive malo razdvajaju, 75,2% živi 30 meseci koji su primali Pembro u odnosu na one koji nisu. Hazard ratio je 0,63, znači 38% redukcija rizika od ponovne pojave bolesti. Ovo je također follow-up 30,1 mesec, gde su posebno pokazane krive preživljavanja bez ponovne pojave bolesti za intermedijarni i high risk, ali ono što sam malo prespomenula, pogledajte kako su se krive baš onako dramatično razdvojile za M1 net. Nemamo ni mi u realnoj praksi tih pacijenata previše, ali ovih visokorizičnih svakako da imamo. Evo pogledajte, kod njih hazard ratio je 60, znači 40% se smanjuje rizik da se bolest ponovo javi i to je definitivno vrlo respektabilan procenat. 57 meseci follow-upa, poslednji izveštaj aprila ove godine, dati su rezultati, ja mislim ako se ne varam, na ASKU ove godine, je li tako? Na ASKU. Na? ASKO-GU, da. Nije na ESMU, nego na ASKU početkom godine. Podaci za ukupno preživljavanje pri primjeni adjuvantnog pembrolizumaba i kao što vidite, znači to je prva u stvari studija koja je pokazala da primjena adjuvantnog pembrolizumaba kod visokorizičnih pacijenata nakon operacije RCC-a produžava njihovo ukupno preživljavanje i celoj priči, celoj studiji, preporuci i primjeni te terapije daje dodatnu težinu. Još jedan u ukupnoj populaciji slajd, odnosno kriva ukupnog preživljavanja sa skoro 38% smanjenja rizika od smrtnog ishoda. Pacijenti, kad pogledate 5 godina kasnije u odnosu na početak ove studije, znači pembrolizumab u adjuvantnom lečenju svetloćelijskog RCC-a, pacijenti lečeni pembrolizumabom posle nefrektomije su imali manji rizik od smrtnog ishoda za 38%, tokom praćenja od nešto više od 57 meseci, a za 28% je smanjen rizik od ponovne pojave bolesti, upravo sa tim najdužim follow-upom. Pa evo, pošto su svi prikazali tipičnog pacijenta, kako izgleda taj tipični pacijent sa svetloćelijskim karcinomom bubrežnih ćelija, muškarac je svakako, jer dominantno 2/3 obolelih su muškarci. Ja bih rekla u ovako dobrim godinama, 62 godine, još uvek dobro držeći, sposoban i da radi. Lazar malo odmahuje glavom, ali jeste. Nema značajnije komorbiditete, ima neku malu hipertenziju koju svi što imaju u tim godinama, ništa specijalno. Osetio je bol u donjem delu leđa i povremeno mu se javljala hematurija. I nakon prolaska kroz sve te dijagnostičke procedure, potvrđeno je da ima veliku tumorsku masu u levom bubregu, koja po skeneru zauzima i okolni prostor, ali nije potvrđeno širenje u regionalne limfne čvorove i nisu potvrđene udaljene metastaze. Učinjena je biopsija, potvrđeno je da je RCC svetloćelijskog tipa i nakon toga je operisan, što je radikalna nefrektomija urađena i histološki potvrđeno da je to PT3 tumor. To jeste tumor, znači visokorizični koji zahteva primjenu imunoterapije po svim preporukama, međutim ono što mi danas u Srbiji možemo da ponudimo jeste samo regularno praćenje pacijenta. Samo molila bih vas da obratite pažnju na deo desni slajda gde su navedeni, znači nije samo PT3 rizičan, PT2 sa sarkomatoidnom komponentom, PT3, bilo koji gradus bez zahvaćenih limfnih čvorova, PT4, bilo koji gradus N0, M0 i naravno imamo bilo koji stadijum PT, bilo koji gradus ukoliko postoji zahvaćenost limfnih čvorova. I to je u suštini kad pogledate još jedna vruća stolica, kako smo je nazvali, koja čeka da dobije svoju indikaciju. U suštini za karcinom, za CC nema otvorenih vrata, ali smo ih malo odškrinuli, pošto, kao i Marijana što je spomenula, dobit ćemo donaciju za 100 pacijenata u Srbiji, što će značiti prevashodno našim pacijentima, ali iskreno rečeno značit će i nama, da u ovoj kategoriji pacijenata steknemo iskustvo sa primenom imunoterapije. I Lazar je još spomenuo, šta je ključno za bolje ishode u lečenju rekurentnog ili metastatskog karcinoma glave i vrata. Ja, pošto se bavim urologijom i tako pričam, šta nam fali, šta imamo i tako dalje, uvek spominjemo da je karcinom mokraćne bešike, neko naše siroče, ali ja uvek kažem da uz to siroče i karcinom glave i vrata jeste siroče, jer zaista za svo ovo vreme dok su druge lokalizacije na našu sreću i sreću pacijenata dobijali nove lekove, karcinom glave i vrata rekurentni ili metastatski ima samo mogućnost primene Erbituksa u jednoj maloj fazi bolesti, dalje održavanja, dalje imunoterapije zvanično nema i to bi bio jedan, ja bih rekla, još od prioriteta u svakom slučaju. Ovo vam je samo prikaz Evrope, ovo što je zeleno pokazuje gde je sve dostupna primjena pembrolizumaba za pacijente, ono malo crveno smo mi i Bosna, koliko vidim, tako da sve ta slika deluje poprilično onako, bar što se nas tiče, tužno. Neki broj novoregistrovanih u našoj zemlji se kreće nešto preko 1800, više od 900 pacijenata umre tokom 20. godine, pa kakav bi to bio neki tipičan pacijent koga mi srećemo? Znači, ponovo je muškarac, 55 godina otprilike star, dugogodišnji pušač i dosta često takvi pacijenti u nekoj svojoj anamnezi navode i da konzumiraju alkohol, javlja se sa bolom u grlu, otežano guta, promukao je, pojavljuju se otoci, odnosno uvećani limfni čvorovi na vratu. Nakon dijagnostičkih procedura i biopsije potvrđeno je da se radi o skvamoznom karcinomu glave i vrata, a PET-CT koji je urađen pokazuje znači promene u orofaringsu, metastatske limfne čvorove na vratu, udaljene metastatske lezije u plućima. Učinjeno je PDL-1 testiranje i on je pozitivan, znači definitivno ispunjava sve kriterijume za primanu pembrolizumaba, ali šta mi možemo danas zvanično? Možemo samo dati hemioterapiju. Međutim, ako se ne varam, mi smo dobili donaciju za 50 pacijenata u Srbiji, tako da je ovo još jedna prilika da se ja onima koji su nam dali donaciju zahvalim, jer to je zaista doprinelo da ipak makar tih 50 pacijenata lečimo onako kako nam pokazuju preporuke i kako treba.
Hvala najlepše. Imamo tamo 2 minuta za zaključak, a pre zaključka zaista ono što i Suzana i Marijana su pomenule, a to je da smo dobili donacije od kompanije MSD za cervikalni karcinom i za adjuvantnu terapiju bubrega i zaista se puno zahvaljujemo i kao jednoj odgovornoj kompaniji da i mi dobijemo priliku da naučimo da koristimo u tim indikacijama ovaj lek, a i naravno pacijenti. Gde je ključ? Ja bih se možda osvrnuo na panel koji smo ovde imali pre 2 dana, gde smo zaista neke ključeve pronašli i zaista negde smo poslali poruku koja se već negde čula sa nekim stvarima, ne bih zvanično još ništa o tome, ali nešto se dešava. Ali ključ u nekoliko stvari. Prvo je ključ u skriningu, pričali smo o skriningu, ako otkrijemo rak na vreme, bolju ćemo imati stopu izlečenja. Tu je ključ i u nama i u udruženjima pacijenata, najviše je tu ključ kod države. Ključ je naravno u dostupnosti lekova, u nauci, u edukaciji, stalnoj edukaciji, ovakvi skupovi doprinose edukaciji i to nam je izuzetno važno, ali ono što je možda najvažnije što se tiče dostupnosti lekova i nauke, nije dovoljno imati samo studiju, nije dovoljno imati samo Kaplan-Mojerove krive, jer ako taj lek ne dođe do pacijenta, onda nam je sve džabe. Eto, toliko od nas, ja mislim da se slažete s ovim. Hvala lepo na pažnji, hvala još jednom kompaniji MSD na svemu što radi za nas. Hvala.
Test.
Irena i Rada. Ne, idemo deo po deo. Zovem vas ja. Samo vi sedite ovdje. Dobar dan, dobro jutro, drage kolege i koleginice. Danas ćemo pričati o karcinomu endometrijuma i vidjet ćemo zaista u ovoj bolesti ima mnogo novina i mi sami, medikalni onkolozi i patolozi, a i naravno hirurzi i radioterapeuti, negde pokušavamo da se snalazimo sa ovim novim preporukama i novinama i želimo i vama da prenesemo gde se nalazimo danas, a gde razmišljamo da ćemo već sutra biti. Pa kao prvo volili bi da čujemo novine u karcinomu endometrijuma iz ugla patologa i zamolit ću doktorku Svetlanu Milenković da nam sa svog aspekta ispriča šta je to novo i na šta treba da obratimo pažnju.
Samo ću malo podići. Evo ovako. I ovde je pomeraš, jel? Aha.
Možeš tu, možeš i tu.
Dobro.
Ili tu.
Ovako, levo, desno.
Desno.
Ok. Znači, poštovane koleginice i kolege, jedna ogromna i široka tema za vrlo kratko vreme, pa ajte da budemo koncizni. Znači, iskreno ništa nije doživjelo toliku transformaciju kao što je FIGO klasifikacija endometrijalnih karcinoma, pri čemu prvi put za sve ove godine koliko mi radimo patologiju, histologija ulazi kao sastavni deo stadijuma, što nas razlikuje do dosadašnjih hiruških, odnosno anatomskih. Kao osnova se uzima naravno histologija i ono što treba da ponesete možda odavde jeste da ta nova klasifikacija ima i svoj histološki deo koji je malo modifikovan, ali svoj molekularni koji je tek što bi rekli science fiction za većinu ljudi, pogotovo u patologiji. Napravljena je nova histološka klasifikacija podtipova karcinoma endometrijuma, od kojih su samo neki, oni koji pripadaju low risk tumorima, većina ovih ovde nabrojanih pripada kategoriji high risk tumora, odnosno high grade tumora, pri čemu obrate pažnju na karcinosarkom. To je nekadašnji mešoviti Miller, koji se danas smatra high grade karcinomom, tako da molim auditorijum kad pošalje zahtev patologu za reviziju, ne traži da se izjasni koliki je procenat sarkomske, a koliki je epitelne komponente, to apsolutno nema više nikakvog značaja. Uvode se i dve nova podtipa, gastrointestinalni mucinozni, kao izuzetno loš prognostički, i uvodi se mezonefrični, o kome govorimo tek u poslednjih par godina. Naravno, ovo su sve karakteristike jednog malignog tumora sa posebnim aspektom koji ćemo pogledati u nizu slajdova dalje, gradus tumora i limfovaskularna invazija. Da biste sve to uopšte razmatrali, pričali, definisali, morate budete sigurni da se radi o tumoru koji je ginekološkog porekla. Tu sad ulazimo u upliv imunohistohemije, koja sad postaje apsolutni standard, znači prosto ne možemo funkcionisati bez nje i smatra se da svi tumori koji su PAX8 pozitivni su u suštini u najvećem broju slučajeva primarno ginekološki. Međutim, kako ćemo mi jasno da definišemo primarni tumor, jer PAX8 da pozitivnost i grlića i endometrijuma i jajnika. I sad idemo dalje, tražimo druge surogat markere i koreliramo sa klinikom. Naprimer, P16 se nekad smatrao ekstremno dobrim markerom koji će da vam pokaže da se nešto radi jasno karcinomu grlića, da bi se posle pokazao da je on i tekako dobar marker za, recimo, seroznu diferencijaciju endometrioidni, koji vas uvodi u problem jer ste pogrešno definisali primarno poreklo. Nešto slično se dešava i sa jajnikom, što mislim da pravi takođe ogroman problem. Prvo i hiruzima kako pristupiti, a zatim i hemioterapeutima šta lečiti. Pa je, recimo, probano. VT1 je pozitivan marker mnogo češće kod jajnika u seroznom nego endometrijumu, za razliku, na primjer, od novog sa kojim mi apsolutno nemamo iskustvo, SOK17 koji je češće u endometrijumu nego u jajniku. I sve smo to uradili da bismo došli do promene koji trpi endometrioidni karcinom, koji je ujedno i najčešći, koji je do sada imao 3 gradusa, pri čemu su kriterijumi u suštini bili prisustvo solidnih polja. Da li mi grešimo pri određivanju gradusa koji definiše celu ovu dalju priču? Naravno da grešimo, pogotovo kad imamo kiretažni materijal, jer ko vam garantuje da smo u tom kiretažnom materijalu dobili apsolutno adekvatan odnos između žlezdane i skvamozne komponente, odnosno solidne, i da li smo skvamoznu komponentu pogrešno protumačili kao solidnu, a ona je u stvari morula. I da bismo se izvukli iz cele priče, uvodimo binarnu klasifikaciju koja je danas prihvaćena, verujte, i postoji jedan veliki deo Srbije koji još uvek ne radi na ovakav način, a to je da imamo samo 2 tipa, od kojih jedan low grade, i to su gradusi 1 i 2, i high grade koji je u suštini gradus 3. Pošto se naravno ni to nije pokazalo kao dovoljno dobro, uveli smo i poslednju varijantu klasifikacije kao molekularnu klasifikaciju, pri čemu preduslov za ovakvu klasifikaciju jeste da ste jasno definisali, znači histološki, odnosno imunohistohemijski, kom tipu tumora je reč. Svi ovi tumori na ovoj slici izgledaju vrlo slično. Oni imaju potpuno različito poreklo i različit tip diferencijacije, time i gradus i prognostičke parametre. Ista slika, vama sve odeluje šareno, isto verujte i meni i većini mojih kolega, dok se iza toga ne bi u suštini uradila imunohistohemija. Na kraju dođe smo do molekularnih testiranja. Svi znamo polemutaciju, ja je moram pročitati, to je domen egzonukleaze DNK polimeraze epsilon, koje se u suštini naziva skraćeno pole, kao tako je znamo, i kojima se pridružuju još jedan panel markera, od kojih je jedan P53, a drugo je MSI, odnosno MMR deficijencija. Pri tome imate pole kao ultramutiranu varijantu i imate pole divljeg tipa, koji predstavlja drugi tip tumora, koji ide sa gubitkom ekspresije u okviru nekog od, znate da postoje 4, u okviru MSI-a, i nezavisno od toga kakav je bio P53, to jest da li je bio abnormalni ili wild type. I na kraju, poslednji korak u dijagnostičkom algoritmu, koji kaže da treba da odredite P53, koji je suštinski na kraju ispadne najvažniji kada ga primenite u imunohistohemijskom smislu za procenu ponašanja jednog endometrijalnog karcinoma. Dala sam vam originalan tekst iz jednog rada koji se odnosi na ginekološku patologiju, koji kaže da je imunohistohemijski P53 potpuno validan dijagnostički algoritam, je konvencionalan, široko primenjen, nije skup i vrlo ga je lako interpretirati pod uslovom da imate ginekopatologa. Samo toliko. Stavite ga u 2 kategorije, od kojih je jedan P53 wild type, a drugi je P53 abnormal type. Sad se postavlja pitanje da li bismo mi to radili samo imunohistohemijski ili bismo mi to radili preko NGS-a. Ovo je jedna od, možda da kažemo, retkih varijanti određivanja gde se imunohistohemijsko validiranje P53 u vrlo visokoj senzitivnosti i specifičnosti podudara sa genetikom. I smatra se da genetika čak i nije potrebna za većinu slučajeva da je dovoljno da uradimo imunohistohemija. Ali tu sad ide ono ne leži vraže. Sada smo podelili P53 abnormal type u 3, odnosno 4 različita obrazca. Što može prosto kad mora komplikovano. I to bi bila abnormalna prekomerna ekspresija, gde imate P53 jedarni, pozitivan u 80 do 100% ćelija, pri čemu je to intenzivna pozitivnost, jaka jedarna, nema ekspresije, takozvani null mutanti. Postoji citoplazmatska koja je u suštini aberantna ekspresija, jer P53 je nuklearno antitelo, i poslednji 4. pojam koji se skoro uvodi, to je takozvana subnuklearna abnormalna P53 ekspresija. I evo, sad i oni pokušavaju da definišu šta je to subklonalna abnormalna P53 kao nagla regionalna abnormalna P53 ekspresija u manje od 80% tumorskog volumena. Zašto je uvode? Zato što se pokazalo da postoje slučajevi za koji nikada ne biste u morfološkom smislu rekli da pripadaju kategoriji loši prognostički, a te žene, sećate se, par puta smo i pričali, na konzilima dobiju metastaze čak i na perikardu. Možda su to, na primjer, neke od tih žena. Ovo su 4 modela abnormalnog P53. Znači, označava se kao P53 abnormal, ona skraćenica, jel? Ovo bi bio wild type, on se nalazi sve između ovih, jel? I najveći broj tumora u suštini pripadaju ovoj kategoriji. Ja se neću zadržavati kod testiranja za MSI, odnosno MRD, jer on ima različite značaje, a neću zato što smatram da će biti mete interesovanja u nekim narednim sastancima, u prvom redu kako je najavljeno od strane AstraZeneca, pa ćemo o tome pričati drugi put. Kako izgleda na kraju molekularna klasifikacija endometrijalnih karcinoma? Imamo 4 grupe, to su pole ultramutirani sa najboljim prognostičkim karakteristikama, to je MMR deficijentni, P53 mutirani i endometrijalni karcinom kojima nedostaje bilo koja od ovih promena koji se smatraju karcinomima nespecifičnog molekularnog profila. Oni su prognostički različiti. Najbolji je pole ultramutirani, najlošiji je P53 abnormalni, dok se ova dva navode kao intermedijarni. Pogledajte kako izgleda šema tih klasifikacija, pri čemu se kaže da svi karcinomi endometrijuma, bez obzira na histološki tip diferencijacije, mogu da se klasifikuju molekularno. I evo ih preduslovi. Znači, da biste uopšte o ovom govorili, prođete celu sekvencijalnu etapu od histologije preko imunohistohemije na kraju do molekularnog testiranja. Evo ih oni slučajevi što sam rekla da su bili intrigantni, zbog čega na kraju uvode tu 4. subklonalnu ekspresiju. Ovo su 2 tumora sa leve strane koje su pogrešene od strane patologa kao low grade tumori. I oni u suštini i jesu low grade tumori, ali su pokazali P53 abnormal type. Pošto nisu bili sigurni, jer ne postoji, da kažemo, korelacija između jednog i drugog, urađeno je NGS, znači sekvencioniranje, i ono je potvrdilo da je T53 bilo abnormalno, što znači da se ovi karcinomi, bez obzira što deluju prognostički dobri po tipu diferencijacije, moraju u sklopu nove klasifikacije svrstati u onu drugu kategoriju. Pri tome, molekularna klasifikacija, zapamtite, se odnosi samo na prva 2 stadijuma. Znači, stadijum FIGO 1 i 2 podležu promeni. Stadijum 3 i 4 zadržavaju svoje karakteristike, odnosno određivanje stadijuma se vrši samo po hiruškim, odnosno anatomskim strukturama, a u stadijumu 1 i 2 ulaze molekularna i imunohistohemijska. I evo sada, ovo je kada se primjeri molekularna, ono za koju mi uglavnom znamo je imunohistohemijska, odnosno histološka, po prognostičkim tipovima, a ovo bi bila molekularna, u kojoj kaže da FIGO 1A, takozvani M-pole mutirani, je ograničen na korpus uterusa sa ili bez cervikalne ekstenzije, nezavisno od toga kakav je LVI. Prvi put se količina, odnosno broj vaskularnih prostora, da li je mali ili je značajan, uvodi kao kategorija koja takođe uvršuje neku bolest u određeni stadijum. Granica je 5. Znači, 5 limfovaskularnih prostora je nešto što se smatra malim, a sve preko 5 limfovaskularnih prostora je nešto što je značajno. I naravno, ovaj 2C2 se odnosi kada postoji P53 abnormalni. Znači, za vas zapamtite pole ultramutirani, izuzetno dobro prognostički, pole abnormalni ne. Da se tu ne zaustavljamo, nego idemo dalje, to u nekom narednom, šta se radi, imate serozni, pa nam još i na to dodaju, verovatno u nekom smislu, to bolje znaju hemioterapeuti, šta će dati od dodatnih lekova, pa na njima možemo čak i HER da radimo. Mislim, cijela priča postaje vrlo komplikovana, uvodi nove biomarkere, nova molekularna testiranja, traži reklasifikaciju. A da li mi možemo na ovo da odgovorimo? Šta vi mislite? Jer vi treba da imate fenomenalnu patološku laboratoriju, morate da imate strašno stručan, edukovan kadar i pri tome morate da imate dovoljan broj zaposlenih i patologa i laboratorijskih tehničara da bismo sve ove zahteve mogli da zadovoljimo. Hvala vam.
Da. Imamo ova prva 2.
Da. Draga Svetlana, zaista si nam dočarala i približila patološki aspekt endometrialnog karcinoma. A sada bih volila da pitam moju dragu koleginicu Irenu Jovanić, patologa sa Instituta za onkologiju, da li mislite da je vreme da se nova FIGO klasifikacija za karcinom endometrijuma uvrsti u kliničku praksu i da li mislite da je potrebna neka dodatna edukacija da bi se zapravo moglo utvrditi da li mi mismatch repair deficient ili se radi PPD-3 mutiranom endometrialnom karcinomu. Znači, prosto kako vidite neku blisku budućnost karcinoma endometrijuma?
Mi smo već uvrstili. Znači, u našim nalazima od kraja prošle, odnosno od početka ove godine, radimo po novoj FIGO klasifikaciji, radimo sve što je po preporukama, znači P53, MMR deficijenciju i neka posebna edukacija patologa za MMR jeste i nije potrebna. U stvari uvek je potrebna. Oni koji imaju iskustva sa tumačenjem MMR-a u karcinomima debelog creva sigurno im manje treba. Ono što je različito, to su neke cut-off vrednosti i šta je bitno? Bitno je koje se antitelo koristi. I neka specifična bojanja koja mogu da se jave recimo u ventaninom antitelu u odnosu na Dakovo antitelo, u tom smislu bi bila potrebna edukacija. Inače, metoda kod nas se znači normalno radi što se tiče nas i naše kuće. Mislim i Ceca i vi ste FIGO isto uvrstili klasifikaciju.
Pa nismo mi još uvrstili, jer za razliku od vas mi nemamo svoju imunohistohemijsku laboratoriju, znači mi smo tu u dogovoru sa Institutom za patologiju da se taj deo priče radi. Mi ne možemo da utičemo bar za sada, ali pretpostavljam da bi ljudi našli tu, da kažem, zajedničku temu, dilemu i ostalo, kada su u pitanju vrste antitela, odnosno proizvođači, ali ono što nas razlikuje od vas, to je vaše ogromno iskustvo. Imajte u vidu da vama dojka i razne prednosti, tipa recimo debelog creva i slično, daju veliki korak ispred nas i mislim da je za nas, a da ne pričamo ljudi iz sekundarnih zdravstvenih ustanova, apsolutno neophodna edukacija. Jer recimo osnovne polemike koje se vode kad je u pitanju P53 jeste kako vršimo tumačenje kontrole za pozitivnu reakciju za P53. Tako da mislim da će tu biti potrebno neko vreme, tako je da se mi ušemimo što se tiče tih delova.
Isto je i za MMR, gde se gleda baš pozitivna kontrola, što recimo u karcinomu debelog creva nije tako, ovde se baš gleda intenzitet pozitivne kontrole i u odnosu na taj intenzitet se tumači kakva je ekspresija. I procenat, znači cut-off vrednosti nisu iste za karcinom endometrijuma i karcinom debelog creva, što se tiče MMR.
Dobro, znači ipak izvesna edukacija je potrebna. A sada bih volila da pitam Radu Janković kako ona vidi molekularnu klasifikaciju u Republici Srbiji i kako uopšte predlažete da prevaziđemo eventualne probleme iste.
Dobar dan. Pa, kada pričamo o molekularnoj klasifikaciji, onako jednostavno viđeno je da 3 podtipa mogu da se odredi kroz imunohistohemijske markere. Znači, ostane čuveni poli, koji je onako kamen spoticanja već na par sastanaka kojima sam prisustvala. Naravno, prva misao je NGS, jer on jeste deo panela, većine NGS panela za solidne tumore. Međutim, imajući u vidu kapacitete i naše laboratorije, koja, mislim, najviše radi tog testiranja i vrlo ograničene drugih, postoji ta opcija koja je do skora dostupna. Kako kažem, proizvođači uvek idu u korak sa terapijama, vremenom, klasifikacijom, tako da postoji opcija za to brže i efikasnije. To je metoda kvantitativnim PCR-om koju mi koristimo za EGFR, RAS i sve ostale analize. Znači, postoje komercijalni testovi, a takođe postoji opcija in-house testa koji može se lako razviti, jer je srećna okolnost da pol ima hotspot mesta, znači 4 do 6 koji se mogu dizajnirati, tako da ja vidim da je to neka prihvatljivija opcija za nas sada i koju bi mogli da prihvati laboratorije u Nišu, Institutu za onkologiju Vojvodine koje to radi.
Ne mnogo skupa?
Nije mnogo skupa i relativno je brza. Znači, dobiju, sad zavisno od broja analiza, ali to je metoda koja je 2-3 dana. To je to.
Hvala. Ja mislim da je sada vreme da čujemo hirurge. Nisam sigurna da treba da bude ovo što je sada na ovom panelu. Znači, volila bi da čujem novinu o endometrijalnom karcinomu iz ugla hirurga, Petar Radlović.
Hvala najlepše. Samo drugo predavanje.
I volila bih takođe da zovem paneliste da budu ovde sa mnom. Da. Ti ostani tu za svaki slučaj. Panelista Lazar Nejković, Katarina Stefanović, Aljoša Mandić.
To je to. Poštovane koleginice i kolege, tema mog predavanja je hirurgija u lečenju karcinoma endometrijuma. Karcinom endometrijuma je na zapadu praktično najčešći ginekološki tumor, kod nas je drugi po učestalosti, ali u svakom slučaju najčešći hirurški lečen tumor koji se obično otkriva u početnim stadijima bolesti i obično se leči samo hirurgijom. Cilj hirurgije je u suštini ekstirpacija tumora, osnovni cilj, što podrazumeva histerektomiju i adneksektomiju, i to je do pre, da kažemo, 20 godina praktično bila standardna procedura za pacijente koji imaju početni endometrijalni karcinom. Međutim, od tada je praktično neophodno i da se tokom operacije uradi hirurško stažiranje bolesti, odnosno da se evaluiraju limfni čvorovi koji su najčešće ekstrauterusno mesto metastaziranja tumora. Obično se ranije i inicijalno se radili su se disekcije pelvične ili kombinacija pelvičnih i paraortokavalnih disekcija i to je bio način evaluacije čvorova. Pritom, za početni endometrijalni karcinom većina pacijenata nije imala metastaze i radila se u suštini iz dijagnostičkih razloga jedna vrlo agresivna hirurgija koja je bila praćena naravno i intraoperativnim i perioperativnim morbiditetom i postoperativnim morbiditetom u smislu limfedema bez ikakvog osnova. Poslednjih godina postoji tendencija, poslednjih 10 godina, ali da kažem da je od 2018. praktično u NCCN guideline-u prvi put navedeno da je Sentinel tehnika u suštini preferabilan način evaluacije čvorova za početni endometrijalni karcinom. Drugim rečima, ovaj vid evaluacije čvorova nosi sa sobom mnogo manji morbiditet, perioperativni, postoperativni, jednostavnija tehnika i predstavlja najprecizniji način evaluacije limfnih čvorova. Razlog za to je taj što je praktično integrativni deo postupka ultrastažiranje. Drugim rečima, Sentinel čvor se ultra fino seče imunohistohemijski boji i na ovaj način je moguće odrediti praktično metastaze malog volumena, što standardnim presekom nije moguće. Jer recimo standardnim presekom te subkapsularne metastaze se praktično ne vidi. Obzirom da je, a to omogućava naravno ne samo prognostički aspekt, nego i kreiranje adjuvantne terapije kod pacijenata koji imaju nod pozitivnost. Naravno i molekularno profilisanje je vrlo važno u tome i ta Portek 3 studija je druga neka priča, ali ne bi sad širio temu u tom pravcu, bit će prilike kasnije za to. Da bi odredili Sentinel čvor, potrebno je uraditi naravno mapiranje i u tu svrhu se intracervikalno ubrizgava boja i radiofarmak ili samo boja, kod endometrijuma obično tako, bilo da je to metilen plavo ili indocijan green, indocijanin green, u svakom slučaju princip je u ove praktično tehnike isti. Poenta je da se praktično čvor koji se nalazi u karlici, obično su u karlici Sentinel čvorovi, to su predadokciona mesta za Sentinel čvor kod endometrijalnog karcinoma, prebojavaju čvorovi i što se vidi na levoj slici metilen bojom sa aferentnim tim limfnim putevima ili na desnoj indocijan greenom. Indocijan green ima prednosti u smislu što je stepen detekcije Sentinela otprilike 20% veći u odnosu na metilen plavo. Senzitivnost, znači odnosno mogućnost da se otkrije metastaza ukoliko je prisutna je ista. Drugim rečima, kad se mapira čvor bilo kojom tehnikom, mogućnost da se otkrije da je prisutna fokalna metastaza je ista preko 90% u ove grupe. Mi smo naravno imali priliku u proteklih nekoliko meseci da koristimo ICG i mogu da kažem zaista da je sjajan. Na slici gore se vide jasno aferentni putevi i u desnoj hemipelvisu se vidi jasno praktično mapiran Sentinel čvor koji se na donjoj slici vidi kako je jasno odvojen nakon ove pristupanja retroperitoneomu. Laparoskopija za sentinel tehniku svakako ima mnogo prednosti i preferabilniji način sprovođenja ovog tipa hirurgije u odnosu na otvoreno, jer se bolje vide detalji, tako da nema dileme da je to i sa drugih aspekata, da kažemo, danas preferabilan način i pristup hiruški što se tiče endometrijalnog karcinoma. U svakom slučaju, ukoliko se ne mapira ili ukoliko je mapiranje čvorova neuspešno, potrebno raditi limfonodalnu disekciju sa jedne ili sa obe strane u zavisnosti gde se nije prebojio čvor, kako bi se adekvatan dijagnostički aspekt tokom operacije pribavio nakon toga. Karlice u svakom slučaju predilekciono mesto za pojavu čvorova i skipping metastaze, odnosno izolovane paraortokavalne metastaze kod endometrijalnog karcinoma su ekstremno retke, manje od 1%. Češće su kod neke neendometrioidnih histopatologija. Druga važna stvar, to je hiruški pristup. Znači, pre 20 godina dominantno su se pacijenti operisali otvorenom hirurgijom, obično medijalnom laparotomijom. Posljednjih godina postoji tendencija da se mnogo više, odnosno da se većina pacijenata operiše minimalno invazivnom hirurgijom. 2 trijala su ključna. Znači, prvi je LEP2 trial koji je pre 15 godina završen u Americi, koji je randomizovao pacijente za otvorenu i laparoskopsku hirurgiju i taj trial je pokazao da je praktično izvodljivost, cilj je bila izvodljivost laparoskopske hirurgije kod endometrijalnog karcinoma, pokazuje da je ona izvodljiva, da je kraći boravak u bolnici i da je bolji kvalitet života kod pacijenata koji se operišu minimalno invazivnom hirurgijom, a sekundarni odloženi, da kažemo, rezultati tog trijala su takođe pokazali i onkološku bezbednost, u smislu da su obe grupe, što se vidi na krivuljama, i recurrence rate i overall survival isti praktično, tako da nema razlike. Drugi trial, to je LACE trial koji je pre nekih 7-8 godina publikovan. On ima za cilj isključivo onkološki aspekt, takođe pokazao da je taj disease-free survival i overall survival u obe grupe i kod otvorene hirurgije i kod laparoskopske hirurgije identičan. Kao rezultat tih trijala praktično i u NCCN guideline-u i u ovom ESGO guideline-u minimalno invazivna hirurgija se nameće kao jedan standardan pristup koji se radi kod početnog endometrijalnog karcinoma, tako da postoje izvesno ograničenja naravno za to, a to se pre svega odnosi na veličinu materice. Znači, često imamo pacijente koji imaju napredne tumore ili imaju miome uz tumor, obzirom da komadanje preparata nije dozvoljeno zbog histopatološke analize i zbog drugih onkoloških razloga, takve pacijente obično preoperativno selektujemo i radimo ih otvorenom hirurgijom, zatim jake adhezije u trbuhu, premda i tu postoje isto tako šta su jake adhezije, to je relativan pojam, tako da dosta pacijenata može realno minimalnom invazivnom hirurgijom da se operiše, ali ne mogu pacijenti koji su imali peritonitise ili, ekstenzivne hirurgije ponovljene u trbuhu, jako ih je teško uraditi. Zatim kardiopulmonalno nestabilni pacijenti, oni ne mogu da se operišu i takođe lokalno uznapredovana metastatska bolest predstavlja relativnu kontraindikaciju. U suštini mogu da se tretiraju jedan broj pacijenata laparoskopski, ali kod njih je više ideja da se uradi ekstenzivna hirurgija i pristup je tu u drugom planu. Što se tiče IORS-a, kod nas se danas praktično 3/4 pacijenata od svih endometrijalnih karcinoma analizom u posljednje 2 godine tretira minimalno invazivno. Jako je niska stopa konverzije, oko 1,5%, i praktično samo pacijente koji su navedeni u prethodnom slajdu tretiramo otvoreno. Poslednji je slajd u pitanju. Znači, ono što je danas trend u svetu, to je da se robotska hirurgija praktično uvodi u onkoginekologiju. To je naravno prisutno u Americi posljednjih 25 godina. Kod nas, naravno, to nije. U Evropi danas malo koja bolnica i nema robot. Konkretno za endometrijalni karcinom ne vidim da robotska hirurgija, odnosno na laparoskopsku, ima prednosti, osim možda za grupu pacijenata koji imaju jako visok body mass index, gde je stopa konverzija u odnosu na laparoskopsku hirurgiju, kod robotske hirurgije manja, ali u principu ove operacije se svakako mogu bezbedno raditi laparoskopski, ali robotska hirurgija daje jedan veći komfor i neke druge mogućnosti, to je svakako budućnost hirurgije. Hvala vam na pažnji.
Hvala Petre, zaista sjajno i slikovito predavanje. A sada da čujem sve ove naše divne hirurge. Da li, počet ćemo od Vojvodine, da li vi imate sentinel ili koristite? Vi posle Laza da nam odgovorite da li je to kod vas uobičajeno, a posle da vidimo kako je to u Višegradskoj od strane Katarine. Pa, dobro, okej, naravno. Prvo, dama.
Ovako, mi ne radimo Sentinel jer kontrast nije registrovan, ne možemo da nabavimo. Kada radimo pelvičnu limfadenektomiju, radimo i paraortalnu, znači odižemo mezo kod high risk pacijenata, to je što se tiče endometrijuma. A ako mogu da dodam, vezano za FIGO klasifikaciju endometrijalnog karcinoma koja unosi mnoge ovako zabune i nama deluje mnogo komplikovano i u neku ruku to i jeste molekularna klasifikacija i skupo je i ne radi se kod nas ili se delom radi, delom ne i tako dalje. Mislim da treba poentirati to što je histološka klasifikacija prvi put uvedena, znači u FIGO stadiranje tumorske bolesti. Jer nije isto kad kiretiramo, znači kod krvarenja ili iz bilo kog razloga, ako je veća debljina endometrijuma, ako iskiretiramo i u kiretmanu dobijemo serozni papilarni ili dobijemo dobro diferentovan endometroidni. Znači, to nismo ranije u klasifikacijama ranije dobijali taj podatak. Taj podatak smo dobijali, to je high risk patient na osnovu, je li tako, čisto patohistologije. Ona ima značaja sada u FIGO, ako izuzmemo tu molekularnu, na koju ne moramo da poentiramo, jer ona nije standard u svetu, još uvek do kraja nisu stavili tačku na i, mislim da je mnogo bitnije to što su uveli histološku klasifikaciju, jer kažem, nije isto da li imamo low grade ili high grade, znači da li imamo dobro diferentovan endometroidni ili imamo karcinosarkom, serozni papilarni, sve nešto što ide i širi se i ponaša na drugi način u odnosu na dobro diferentovan. Isto tako, prvi put je sad ovde uvedeno da kod endometroidnog karcinoma jasno se zna, znači da u treći stadijum tumorske bolesti je stadijum koji obuhvata, znači žlezde su zahvaćene. Ovde sada ide kolike su mikro i makrometastaze, tačno, i to sigurno da ima neki prognostički značaj, jer ne bi bilo uvedeno. To je ono što je za nas kliničare bitno i za ostale koji će kasnije da leče, da uključuju terapiju, da kontrolišu. Isto tako bitno je da je važno, ranije smo to znali, ali nije bilo uvršćeno u FIGO klasifikaciju jasno da kada je peritoneum male karlice zahvaćen je treći stadijum tumorske bolesti, a kada je omentum je četvrti stadijum tumorske bolesti van male karlice. To je nešto što kliničari, što je sada ovde jasno onako distinkcirano, to je ono što mi treba da znamo, što nama i vama pomaže. Eto recimo, možda bi to poentiralo za novu klasifikaciju, isto tako, ako budemo još nastavili diskusiju, pošto sam ja na odeljenju onkofertiliteta i bavimo se očuvanjem plodnosti i u poslednjih 10 godina mi smo endometrijalni kancer i atipiju, kada je znači lokalizovana samo na endometrijumu, poštedno tretirali u određenom procentu, u određenim slučajevima, to znači nije standardni vid lečenja, žene nisu završile reprodukciju i mi smo se strogo ograničili magnetom i ultrazvukom i histologijom, to smo čak i radili ekspertizu, uvek Svetlana pogleda, koja je stvarno, moram da kažem, eto, ona je Jasmina doajen u tome, znači svaki HP šaljemo kod nje na ekspertizu. Znači, mi smo strogo konzervativno tretirali žene gde je endometrijum bio, samo da je endometrijum zahvaćen ili u polipu. Po novoj FIGO klasifikaciji iz 2023. kažu da kada imamo endometrijum, znači samo kada je endometroidni adenokarcinom samo na endometrijumu, ali kada imamo konkomitantni endometroidni jajnika, ukoliko nema transtubarnog širenja, ukoliko nema limfovaskularne invazije i ukoliko nema invazije miometrijuma veće od 50%, možemo konzervativno tretirati. To je nešto potpuno novo, nešto što još ne znam da je zaživelo, mislim da i nije, jer stvarno to baš treba, nije zaživelo i pitanje, ne znam kako će to da zaživi, mi to nismo radili, mi smo uvek svaku patologiju na jajniku koju smo otkrili, znači te žene nisu išle u konzervativno tretiranje, jednom smo ili u 2 slučaja konzervativno tretirali, onda nam se učinilo da nešto ipak postoji na jajniku i našli smo konkomitantni tumor, tu smo uradili histerektomiju, znači po sad najnovijem FIGO 2023. Ako je to odvojen, ako je praktično to
odvojen tumor, odnosno ako je multifokalno poreklo, onda to konzervativno može, mislim da to, ne znam da li još neko radi u svetu, to je novina FIGO 2023. gde oni kažu da preporučuju konzervativno, a ko je taj ko će baš da dokaže da je to konkomitantni, je li tako, Svetlana? To je nešto što recimo unosi dilemu mnogo više nego molekularno testiranje koje može, a i ne mora. Eto, i ima sigurno značaj, ali to je ipak neka daleka budućnost, moram da kažem.
Lijepo je što je dotaklo ovu temu, jer oni već pokušavaju, od kad sam ja u ginekološkoj patologiji, da reši dilemu da li je to istovremeni početak oba tumora na jajniku i endometrijuma ili su tumori sa metastazama. Sada su potpuno zaboravili kategoriju intrakanalikularnog širenja. Ste primetili, svi kad smo učili, to je postojao kao jedan od vidova širenja, sada to više niko ne pominje. Sada smo mi dužni da procenjujemo samo u slučajevima, ovo zapamtite, low grade tumora. Samo tada imamo pravo da govorimo o tumoru koji ima istovremeni početak i na jajniku i na endometrijumu. S tim što se moraju ispoštovati karakteristike da je tumor na jednom jajniku, da nema limfovaskularnu invaziju, da se ne radi o tumoru koji infiltruje manje od polovine debljine miometrijuma. Znači, daju nam neke preduslove. Setite se, ranije je bilo gde je veći tumor. Pa ako je veći tumor na jajniku, mi ga proglasimo odatle, sve je palo u vodu. Pri čemu ja i dalje ne mislim da su ovo idealni kriterijumi koji su oni nama predložili, što nam pravi još veću zabunu. I činjenica je da, znači, kad vidimo high grade tumor, nikako ne smemo da ga stavimo kao istovremeni početak, uvek se smatra metastazom iz endometrijuma. Ne znam da li se sećate patoloških knjiga od relativno skoro, ako ste imali prilike da vidite, ako imate i intraepitelni serozni u endometrijumu, promenu na jajniku ćete smatrati metastazom. I nije prvi put da se otkrije, recimo, preko invazije limfatika, odnosno limfnih žlezda, da žena ima intraepitelni karcinom serozni, koliko god to nama izgledalo čudno.
Dobro, zato i kažemo da je jako važna i ta histološka dijagnoza, klasifikacija koja je ušla u FIGO, jer histologija već sama po sebi dovoljno govori o kakvom stepenu rizika je i šta ćemo da uradimo.
Ja se slažem s koleginicama, ali mi kliničari moramo biti oprezni. Ovo su sve samo preporuke i FIGO 23. još uvek nije deo standarda, znači mi kliničari donosimo završnu odluku. A sada da vidimo, Lazo, kako je u frontu što se tiče Sentinela, kako je u frontu što se tiče uopšte i FIGO klasifikacije i svega, kakav je tvoj način razmišljanja u odnosu iskustvo, u odnosu nove situacije. Izvoli.
Ovako, što se tiče Sentinel limfnih čvorova i njihove detekcije, pre jedno 12, 13, 14 godina, otprilike ne mogu više da se setim, prvi put sam se susreo sa mapiranjem kod endometrijalnog kancera i to su radili neki pioniri Nadima Burustum u Memorial Sloan Kettering Cancer Centru u Njujorku i radio je Marijani sa Mayo klinike. I tu su bili različiti rezultati, onda se, naravno svi znamo da su Sentinel limfni čvorovi ili čvorovi stražari koji predstavljaju limfni čvor i put širenja pretpostavlja se lokalnog karcinoma u limfni sistem kao prognostički znak, jel te? I ideja je bila da, s obzirom da metabolički sindromi kod endometrijalnog kancera su vrlo često zastupljeni, to internisti znaju bolje, kod procena sa statusa, težilo se da jednostavno komorbiditeti se zaobiđu uz minimalno invazivne procedure odstranjenja i maksimalno dobijanje podataka o limfonodalnom statusu. To je suština zašto se počelo sa mapiranjem limfatika uz pomoć trejsera. Uglavnom su to debele žene, uglavnom su to žene sa proširenim venama, uglavnom su to žene koje imaju ili infarkt ili moždani udar ili dijabet i tako dalje, što svi već znate, govorimo o adenokarcinomu, ne o high grade-u. High grade ima neku drugu sliku. I težilo se, znači, da se minimalno invazivnom procedurom, s tim da poseban osvrt je bio na hiruški pristup, gde to uopšte nekad nije lako ni uraditi. Znači, zaputiti su malo u karlicu i krenuti sa čišćem limfnih čvorova nije uopšte lak posao ako imate body mass index 35, 37, 38 pa i 40 nekad. Tad smo prvi put doneli limfne žlezde i mi smo počeli kao pioniri sa metilenskim plavim. To nam je bilo dostupno, intracervikalna aplikacija i to je vremenom ušlo u udžbenike, odnosno u preporuke NCCN i FIGO klasifikacije, jezgoa, ESMO, ESTRO i ovo što vi pratite medikalni onkolozi. Intracervikalna aplikacija, duboka površina na poziciju 3,9 sati u količini 1 do 2 ml, tamo dok se operete, uradite, govorim za otvorenu hirurgiju, dok se operete, otvorite trbu, krenete u detekciju limfnog čvora i onda se zauzeo stav. S obzirom na mali procenat paraortokavalnih metastaza u endometrijalnom kanceru, to je nekih 2-3%, lična procena hirurga je da hoće li da je radi ili neće da je radi i naravno koliko postoje bulky nodes, svakako da će da radi kompletnu i svakako da će raditi paraortokavalnu. Ukoliko nema detekcija limfnog čvora stražara, radi se istostrana kompletna limfanektomija, kontralateralna ukoliko ima detekcije, opet kažem sentinel, a ukoliko nema kompletna limfanektomija. U novije vreme smo nabavili kontrasinducijan grin, idemo u korak sa svetom, sa jednog kongresa MD Andersona u Madridu, profesor Pažin i ja smo doneli neke prospekte, kao i sve što se u ovoj državi radi, svako negde nešto vidi pa donese pa traži. Doneli smo te neke specifične kamere koje mogu da detektuju na otvorenoj hirurgiji indocijan grin koji se ranije koristio u digestivnoj hirurgiji kod procena rada na jetri, kod krvarenja, kod anastomoza i tako dalje. Indocijan grin, posebna kamera, čim je nešto posebno odmah košta, čim je posebno koštaju te ampule, ograničenog su roka za ograničen broj pacijenata, onda smo probali da napravimo centralizaciju preko udruženja ginekologa, onkologa, da svi koji imaju takve pacijente otvorimo jednu ampulu, na jedno mesto ih smestimo, bez obzira da li su iz Kamenice, da li su iz instituta, da li su iz fronta, na jednom mestu da se skupe lekari koji će da urade proceduru, da ne bismo, štetili na tom kontrastu. Kao što kaže koleginica profesorka Jeremić, taj kontrast ni do dana današnjeg nije registrovan, ali mi ga koristimo u Narodnog fronta i koristimo ga u laparoskopskoj hirurgiji, gde kamera koja koristi se za vizualizaciju tokom laparoskopskog rada ima dugme koje se pritisne i ono detektuje tačno mesto najčešće metastaze, odnosno limfnog čvora stražara. Da li radimo imunohistohemiju? Ona bi trebala nekih dodatnih 10% da podigne stopu detekcije. I ono što bih dodao ovde, to je ono što doktorka Milenković, čijim predavanjem sam fasciniran, jer je up to date, apsolutno za endometrial kancer, sve što možete čujete, čuli ste u tom predavanju. Teško je za praćenje, ali kad budete ušli u materiju, vidjet ćete da to što je koleginica iznela je sve što treba da znate. Ostala jedna nedoumica, to su isolated tumor cells, koje to koleginica nije pomenula, koje postoje kao tumorske ćelije u cirkulaciji, ali mi njihov značaj ne znamo. Niti znamo da li nešto predstavljaju, ili su naša imaginacija, ili će nešto tek predstaviti.
Hvala, Lazo.
Pitam Lazo, izvini, koristili li tehneciju?
Mi nemamo mogućnosti za radioaktivne izvore, a nismo, pravo vam kažem, ni skloni da se zračimo.
Zaista, zainteresovani. Aljoša, da li vi imate mogućnost da koristite Sentinel?
Mene je fascinantna priča o indocijan grinu, Narodni front i IORS, kako Pera kaže, počeo. Mi sa upravnim odborom se borimo jer to nije registrovano. Dajte ljudi, budite kolegijalni, recite nam kako nabavljate indocijan grin. Jednostavno, imamo sve, nemamo indocijan grin kameru, nemamo indocijan grin, nije registrovan. Onda dođem Narodni front, to mi rutinski radimo, nema problema. IORS mi su počeli, dajte ljudi nam recite kako vi nabavite.
Aljoša, ide radni ručak, vas trojice odmah posle ovog, da se dogovorite i sve će ovo biti rešeno.
Fascinantno to, radimo metilensko plavo isto, nemamo registrovano, ne može da uđe u kuću. Osim kroz nekakve studije, bla bla i ostalo. Nije metilsko plavo, radili smo s tehnecijom. To smo započeli priču zato što je senzitivnost, međutim Pera je jako lepo prikazao pravilno korištenje metilenskog plava ili patent blue, koji je čak bolji, mada i on nije registrovan pa i njega nema, bolje u tome što sporije ide praktički, brže i lakše dolazi do, nema razlijevanja toga kao takvog i senzitivnost je relativno dobra i sa indocijani kao takvim. Tako da smo se vratili zato što je jako komplikovano korištenje tehnecijuma, zato što morate po procedurama administracije, projekcije, svega na nuklearnoj medicini, jasno definisano kako proći edukacije vezano za sve to da bi uradili. Dosta je komplikovano bilo i onda smo krenuli pa posustali, odustali od toga. Te priče i sada koristimo baš kroz neke razgovore i kažem zahvaljujući Petru i ovim našim stalnim pričama, vratio se jednostavno na metilensko plavo i radimo sada metilensko plavo čekajući neko da vidimo kako da dođemo do tog indocijan grina kao nekog. Tako da osnov je da se to polako radi u Srbiji. Osnov je da se polako pristup laparoskopije kao pristupa standardne terapije početnog karcinoma endometrija radi polako. Edukacije imaju svoju liniju učenja, svi nove generacije dolaze koje treba forsirati. Stubovi više nisu problem kao što je bilo prije 10 godina, nemamo stubni, borimo se sa hiruzima, hiruzi nam ne daju ovo. Praktički sad i hiruzi i ginekolozi u departmanima gde postoje imaju te stubove i ide to. Mislim da to ide i da hirurgija nije apsolutno po meni problem nikakav. Nemojte zaboraviti, ljudi moji, prije 10 godina klasično smo radili sve to preželjavanje petogodišnje stadijuma 1 koji je apsolutno 75% i dan danas postoji kao takav, 85, 90%, ne znajući ništa od ovoga što sad znamo, praktički samo boli glava. Ja bih samo jednu stvar napomenuo, nemojte zaboraviti, zahvaljujući novim tehnologijama, patolozi, molekularni biolozi, jako puno otkrivaju stvari i novina koje kao takvi. Međutim, nemojte zaboraviti osnovno pitanje čemu to služi. Nemamo odmah i paralelu da znamo ono što je najvažnije, preživljavanje, da li ima kakvog prognostičkog ili prediktivnog značaja kao takvog ti markeri. Ne ovi standardni koji jesu. Danas se jako puno, evo Ceca je apsolutno update sve rekla kao tako, ali mi nemamo taj odgovor u klinici šta je problem. Mi nemamo odgovor u klinici i poli imaju svoje probleme kao takve. Čak se i postavilo pitanje, dobro, uradit ćemo i nemojte zaboraviti kao treba NGS, treba sve. Ma nije, u velikim bogatim centrima se ne radi to. Radi se osnovne stvari. Zašto? Zato što kaže poli je, Ceca lijepo rekla, samo za stadijum 1. Evo, čisto pitanje. Imate, i za 2, dobro, ali evo imate čisto pitanje. Imate mutirane pacijentkinja kao tako, endometrioidni karcinom i sa pozitivnim limfnim čvorovima.
Pa to tebe pitamo samo.
Šta ćete na konzilijumu reći? On je dobar, nećemo davati. Kad sam pitao to, odgovor je bio adjuvantna terapija, apsolutno.
Ali sad ima Portek 3 studija, čak i za 3. stadijum bolesti ostaje otvoreno. Ja ne znam da li se čuje ili ne. U Portek 3 studiji za poli mutaciju i za 3. stadijum bolesti ostaje otvoreno da li
ali imaš...
I tendencija je u suštini da se ne daje nikakva dodatna terapija.
U nastavku je rečenica da nemamo odgovora na upravo to efikasnost toga i pristupa kao tome svemu. Tako da moramo računati na sve to. I samo još jednu stvar vezano za molekularnu klasifikaciju u odnosu na hirurgiju kao takvu. Ne MD Anderson, nego slovo memorija.
Da li bi ti značilo to?
Znači nam u tom adjuvantnom pristupu kao takvog. Ne znači u smislu da ću promijeniti tip. Osnovno je bilo pitanje. Dakle, osnovno je pitanje. Zato što se predlaže da se radi iz kiretmana. Da se radi iz kiretmana, međutim, evo čikam vas sve za neku narednu, uzmite u svim vašim kućama i uradite komparaciju kiretmana versus definitivni nalaz. To je jedna stvar, koliki je materijal, kako se on šalje. Drugo, čikama sa još jednom stvari, endometrijalni karcinom može da radi svak sekundarna ustanova sa svojom patologijom kakva jeste, kako će to doći do toga, do centralnih laboratorija. Onkologiju ne možemo promatrati, imamo centralnu koja ima sve i ona liječi 40% pacijenata. A gdje oni 60%? Zašto oni ne mogu da dobiju to? Prema tome, to su sve stvari koje druga stvar je, zašto ne rade poli? Isto, u Italiji. Zato što žena dođe brzo na operaciju, dok bude gotov poli kao to. I onda kaže, ne mogu čekati da se radi, da vidimo kako ćemo raditi, ali ne mijenja tok vrste operacije. Zašto? Zato što vam je Sloan Memorial Kettering radio jedna studija vezano molekularni staging versus pozitivnost sentinela. I u polimutiranim pacijentima je dokazano 4 do 5% pozitivnih čvorova. Na osnovu toga je pitanje bilo, a da li onda uopšte trebamo raditi limfadenektomiju, nego samo znamo to? Ne. I dalje se radi kao ovako jer nemamo odgovora, a 4% je njima puno da se promakne da ako kao polipa nećemo raditi limfadenektomiju. Samo kod sentinel noda kao takvo. I onda je na pitanje bilo da li ćete, ako je pozitivan čvor, poli stadijum 1, da li ćete kao pustiti ga. Nemamo odgovora, može se razmisliti, adjuvantna terapija je, pitajte Gemelli hospital, pitajte bilo gdje.
Mi malo promičemo vreme, Lazar, nešto bitno bilo da
Nije,
još
samo
kažeš?
da se nadovežem malo još i dotako taj moment. Nekad se desi da dobijete iz kiretmana obskuran potpuno nalaz s kojim uđete u operaciju, razigrate se u operaciji, radikalno uradite i u definitivnoj histologiji ili ne dobijete uopšte malignitet ili ne dobijete histologiju koja vam je primarno sa stepenom diferencijacije rečena. To je nešto...
Ništa da ne dobiješ, ali njena dijagnoza ostaje ona koja si dobio
Ostaje.
kiretana.
Tako, ali se postavlja sad pitanje verodostojnosti tog prvog nalaza, pa onda idete u revizije i ono što bi možda nama bilo dostupnije, a ne ova science fiction tehnologija uz imunofluorometriju i tako dalje kod sentinela, radi određivanja tačnog mesta u sentinel čvoru gde možda bude metastaza, mislim da bi bolje bilo da se bavimo više četkicama, brisevima i eventualno histologiji iz nekih minimalnih invazivnih procedura gde bismo iz tih ćelija imali definitivnu dijagnozu koja nam ne bi oponirala u definitivnom preparatu nakon operacije i kiretmanu, što bi nam naravno uz patologe dalo tačnu smernicu kako ćemo raditi.
Hvala, drage moje kolege, ali vreme nas jednostavno ne da nam da idemo dalje u diskusiju. Ja vas molim da idete na vaše vreme. Vi biste mogli da ostanete sve vreme ovde. Zato što imam neki utisak, mislim, ona je, kako kažu, zaista jedan eminentan stručnjak, ovde može mnogo da pomogne, mi najmanje znamo o svemu ovome, a kad god nešto ne znamo, onda će Svetlana da nam uleti da budemo, da patolog reši sve što imamo kao probleme. Vi svi znate ko su panelisti, izvinjavam se, moj vid je, kao što vidite, malo problematičan. Znači, Radmila Janković, Anđela Karaferić, Mirjana Miković, i Marija Žijupović. I Radmila Janković i naravno Svetlana. Sad da vidimo šta ja vidim, a šta ja ne vidim i odakle. Ja ću sad ipak ove naučare. Kad se ostavi, nije lako. Sada da vidimo kako ćemo mi, medikalni onkolozi, uopšte da razmišljamo dalje o endometrijalnom karcinomu. Da će nas glava boleti, to je jasno. Pa, prvo što bih htjela da vam kažem, ja kao medikalni onkolog, evo ovo je moja slika, možete zamisliti da ovako izgledam, uopšte ne znam da li mi baš za svaki karcinom endometrijuma zaista treba da znam molekularni podtip. Kada generalno znam da većina endometrijalnih karcinoma imaju odličnu prognozu i nakon lokalnih tretmana su praktično izlečeni. I oni zapravo nikad neće stići mene ni da upoznaju. Ali, nažalost, postoji ona manjina koja uprkos odličnoj hirurgiji, koju uradi neki naš eminentan hirurg, bili su malo pre ovde, svi su sjajni, ili nakon odlične radioterapije, nakon toga brahiterapije, ipak doživi relaps. I da li ipak molekularna klasifikacija meni može da znači u smislu prognoze, znači da bude prognostički marker, i da li mogu da je koristim kao prediktivni faktor, da mi negde ukaže koju terapiju da koristim, a koju i kada da izbegnem. I svi znamo da je zastarela podela na neendometriju mnogo godina iza nas i da je, naravno, tumorski genomski atlas vrlo jasno predočio da postoje 4 osnovna tipa, copy number low, to je nespecificirani tip karcinoma, MSI high, copy number high je P53 mutirani i koliko ih je najmanje i koji imaju sjajnu prognozu. I kada pogledate upravo ovaj atlas i ove krive preživljavanja, vidimo da poli toliko ima dobru prognozu da ga možda ne moramo ni lečiti. I da, 21. godine su zaista eksperti napravili nove ESGO-ESTRO guidelines gde su uvrstili i integrisali histopatološke i molekularne karakteristike, gde su najpre išli u pravcu da poli bude sjajne prognoze, a s druge strane P53 uvek treba ozbiljnije shvatiti, a evo i ova FIGO 23. Klasifikacija koja naravno je uvrstila i tumorsku biologiju i anatomiju i molekularne podtipove, negde najpre o njoj smo dosta pričali, želim da kažem da kao što i Svetlana rekla, polimutacija negde pomera stadijume ka nižim, a P53 negde uvek ka višim. Međutim, kada ispred sebe imate polimutiranog pacijenta, a u pitanju je rani karcinom endometrijuma, zna se da imaju sjajan ishod i da verovatno adjuvantna radioterapija nije ni potrebna, međutim, još mnogo toga moramo da naučimo. Znamo za P53 mutaciju da zaista uvek je treba mnogo ozbiljno shvatiti i gotovo svi stadijumi trebaju ipak i hemioterapiju i radioterapiju. A tu su sada oni sa intermediate prognozom, to su ovi koji su mismatch repair deficient i oni koji imaju taj nespecificirani molekularni profil low grade, kod njih već imamo neko još uvek nepoznanicu da li treba dati vaginalnu brahiterapiju ili možda uopšte ne treba i adjuvantni tretman. Ali da vas podsjetim, danas, 15. novembar 24. još uvek nemamo level 1 dokaza da uopšte možemo ovu molekularnu klasifikaciju koristiti u nekoj redovnoj kliničkoj praksi. Da, Portek 3 nam je pokazala, vidite ovo divergiranje krive kod P53 mutiranih, da HT, znači hemioterapija plus HTRT zaista daje benefita. Svi ovi drugi nemaju neki poseban benefit od dodatka hemioterapije, ali ovo su male studije, mali brojevi. Tako da ja još uvek ne znam i još uvek me boli glava, ali kada bude gotova ova studija, Rainbow, 2030. onda ću moći zaista da vam kažem da li ću moći endometrijalni karcinom koji je operisan, koji je P53 mutiran, da dodam i hemioterapiju, možda i olaparib, da li ću mismatch repair deficient ranim karcinomima endometrijuma pored radioterapije davati durvalumab, da li ću ovom nespecificiranom molekularnom podtipu možda dati hemioterapiju ili ću možda dati uz radioterapiju hormonoterapiju. A kod polimutiranih u svim stadijumima možda ću hrabro reći ne trebate adjuvantnu terapiju. Ali danas još uvek ne. A šta je sa metastatskim karcinomom endometrijuma? Znamo da postoji opet TCG Atlas i Promis koji naravno sve ove histološke forme ipak dele na dve osnovne podele. Polimutirane i poly-wild type. A poly-wild type mogu biti mismatch repair deficient ili mismatch repair proficient. I zapamtite, mismatch repair proficient je zapravo heterogenija grupa, ona ima taj gadan P53 abnormal, mutirani, a ima i ovaj nespecificirani koji ćete vidjeti da je zaista malo čudan i na neki način još uvek možda najmanje poznat. I kada imate polimutirani, a ipak je uspeo da relapsira i ipak i jeste metastatski, s obzirom na te ultramutacije, brojne, sve ove studije su zapravo pokazale sa checkpoint inhibitorima da imamo jako veliki benefit i najverovatnije ćemo ove metastatske polimutirane lečiti checkpoint inhibitorima. A evo mismatch repair deficient podtip. Za sada FDA dokazano da pembrolizumab i dostarlimab imaju apsolutno odobrenje za relapsirani endometrijalni karcinom u drugoj liniji nakon platine. I brojne rane studije su pokazale sjajne response za endometrijalni karcinom, skoro 50% ukoliko se daju checkpoint inhibitori, čuvena Keynote 158 sa pembrolizumabom, a 23. godine smo bili svedoci da imamo sjajne rezultate 4 studije koje su dokazale apsolutno preimujstvo ukoliko checkpoint inhibitore primenite uz hemioterapiju u prvoj liniji mismatch repair deficient metastatskih karcinoma endometrijuma. I ove Ruby studija koja je apsolutno pokazala da dostarlimab uz hemioterapijski dablet u odnosu na samo hemioterapijski dablet, a kasnije dostarlimab ide do ukupno 3 godine, da je jasan benefit. Ova hijerarhijska analiza prvo se analizirala kod deficient mismatch repair karcinoma i vidimo u ovoj kohorti da imamo takvu divergenciju krive, taj impresivni hazard ratio 0,28, znači zapravo 72% redukcija rizika za progresiju, intention to treat, analiza all kamera takođe pozitivno u smislu PFS-a, a ovde vidimo da je Ruby dala vrlo jasan benefit, statistički značajan u pogledu ukupnog preživljavanja samo nakon 25 meseci follow-upa. Vidimo da Energy 018, studija sa pembrolizumabom je takođe dala sjajne rezultate, nećemo ići u detalje, nemamo vremena, ali ja mislim da je dovoljno da pogledate krivu kod deficient mismatch repair i da vidite da su to zaista sjajni rezultati. Opet hazard ratio 0,30 i Attenda sa atezolizumabom daje slične rezultate, opet hijerarhijska analiza. Zašto OS negde nije još uvek dosegnut? Zato što je ipak kratko praćenje, ali vidite, nedovoljna zrelost podataka, nedovoljna evenata, ali definitivno checkpoint inhibitor imaju mesto. DUI je specifičnija malo studija, ovde hoću pre svega da vam kažem da je durvalumab sa hemioterapijom, uz samu hemioterapiju pokazuje jasan benefit, ali ovde imamo i PARP inhibitor koji ima dodatno svoje mesto, ali u mismatch repair deficient tumorima nije se pokazao za sada efikasnim. Međutim, ono što je važno, da imamo i taj Ruby Part 2 gde se ispitivalo da li možda niraparib ako se dodatno sa limabu ima dodatni benefit i da, jeste hazard ratio 0,48 kod mismatch repair deficient tumora, ali pogledajte kada to pokušamo da integrišemo u benefite Rubija koji je bez nirapariba, ima hazard ratio 0,28, vidite da možda ipak niraparib donosi ovde više toksičnost, a ne toliko dodatni benefit. I sada kada poređemo sve ove studije i vidimo ove hazard ratio koji se retko uopšte u ginekologiji mogu videti, vidimo da smo apsolutno sigurni da će svi ovi lekovi vrlo brzo biti na listama kako evropskim, tako naravno i u našoj zemlji, ali gledajte ove crvene zvezdice, odnosno strelice, pa to su izvesno neki određeni pacijenti koji imaju rezistenciju na checkpoint inhibitore, njih treba posebno analizirati i videti zašto i overkamovati, odnosno prevazići te probleme. Čućemo uskoro i da li postoji mogućnost možda da eventualno i zaobiđemo hemioterapiju koju naši pacijenti jako mrze. I za sad su neke studije negativne, uskoro imamo još neke studije. To ćemo malo diskutovati jer nemamo dovoljno vremena sada, nego prelazim na ovaj treći, a jako bitan i najagresivniji P53 abnormal, koji ima neke svoje specifične odlike. S jedne strane, zaista vrlo često ima i deficijenciju homologne rekombinacije, možda će trebati da dodamo PARP inhibitor. On je i najhemiosenzitivniji, istovremeno vrlo često ima HER2 overekspresiju i verovatno trastuzumab je sjajan lek. A ono što je bitno i želim ovde da napomenem, da možda baš ti P53 mutirani možda imaju benefite od PARP inhibitora, ali sigurno ne zato što su BRCA pozitivni, a i o tome bih isto malo više u diskusiji. I kada govorimo o seroznom, papilarnom, uterusnom karcinomu, vrlo često su HER2 pozitivni, imamo nekoliko studija, ova studija je pokazala benefit u pogledu ukupnog preživljavanja, tako da o trastozumabu moramo da mislimo, a desni pan tumor 0,2 je pokazao nekoliko godina nazad da trastuzumab deruxtecan donosi benefit 85% objektivni response rate ukoliko je HER2 3+ pozitivan endometrijalni karcinom i apsolutno će sigurno uskoro ovaj antitelo drakonjugad biti deo standardnih preporuka za ovaj podtip karcinoma. I sada ovaj najnespecifičniji, najheterogeniji i najčudniji podtip endometrijalnog karcinoma. Vidite, strašno neki nedovoljni benefiti, znači ni i na checkpoint inhibitore ne reaguju onako dobro kao mismatch repair deficient, ni na PARP inhibitore, takođe svi su neki odgovori dosta umereni. Keynote 775 je pokazala da u drugoj liniji levantinib i pembrolizumab donose sjajne benefite i najverovatnije da bi to sada bio standard lečenja, ali ovaj lek o kome ćemo sigurno u nekoj vrlo bliskoj budućnosti mnogo čuti, XPO1 inhibitor je pokazao u fazi 2 PFS skoro 40 meseci i vidimo da ćemo uskoro čuti rezultate faze 3, konfirmatorne, gde će sigurno selinexor biti jako važan za ovaj podtip. A imali smo i fazu 2 sjajne rezultate sa palbociklipom i letrozolom, mehanizam je vrlo jasan, ali samo kod onih koji su low grade steroid receptor pozitivni. Nemamo konfirmatornu fazu 3, ali definitivno i ovo jeste deo preporuka. I kada ja sada razmišljam kao kliničar o nekoj mojoj bliskoj budućnosti, a ispred mene moji pacijenti koje želim da lečim najbolje što mogu, ako imaju deficijentni mismatch repair metastatski karcinom, gledat ću da najpre primenim hemioterapiju uz checkpoint inhibitore. Ako imaju P53 mutirani karcinom, daću verovatno i hemioterapiju, možda i PARP inhibitore i checkpoint inhibitore. Ako su HER2 pozitivni, sigurno ću razmišljati o HER2 blokadi, verovatno i o trasozumabu, derokstekanu, a definitivno i o PARP inhibitoru u jednom momentu, ali ako su mi ovaj podtip nespecifični molekularni podtip, dala bih selinexor ili eventualno kombinaciju cikliba i inhibitora aromataze. I evo me danas, razmišljam, je li ja treba molekularni profil da mi neko kaže, tipe Svetlane i Rade Janković, pa iskreno, da, zaista bi mi pomoglo da utiče na moju odluku kada lečim pacijenta sa ranim karcinomom dojke, ali sutradan, ja sam sigurna da će apsolutno zaista moći da krojim terapiju za svakog pojedinačnog pacijenta, personalizovano. A u metastatskom settingu ja već danas se osjećam jako komfortno sa ovim sadašnjim, odnosno jučerašnjim saznanjima da ću praktično svim mismatch repair deficient karcinomima uz hemioterapiju, hemioterapijski tablet dodati checkpoint inhibitore, da ću razmišljati o PARP inhibitoru, posebno u grupi P53 mutiranih, ali očekujem da već sutra dan, nakon svih studija i rezultata završenih, zapravo za svakog svog pacijenta ima mečovan određeni tip terapije koju biram individualizovano, personalizovano, jer želim da moji pacijenti žive što duže, što bolje i što kvalitetnije. Hvala. Ćemo malo da diskutujemo sa mojim dragim kolegama. Naočare su pogrešne. Elem, Radmila Janković, da li vi mislite da će naša laboratorija na institutu biti spremna da obezbedi sve neophodne parametre za molekularnu klasifikaciju i naravno i našu patologiju? Uopšte kako mislite, da li je ovo previše veliki zadatak za vas ili smatrate da ste toliko uigrani da to uopšte neće biti problem za vas, a bit će naravno veliki benefit za naše pacijente?
Moram da se pozovem na izlaganje doktora Mandića, prvo da se utvrde ti parametri na konzilijumu kada je to potrebno, koliko pacijenata ima i kao neko iz laboratorije koja radi NGS dosta, ja moram isto da kažem da ne moramo da se zalećemo svaki put sa NGS-om, ne zaleću se ni mnogo bogatiji, naročito u situaciji kad ima drugih opcija, to sam malo pre spomenula, znači postoji opcija ciljanog testiranja kvantitativnim PCR-om, i to je opcija koja je jednostavna, uigrana i za nju nam ne treba dodatne obuke. Ono što hoću da iskoristim priliku ovde da kažem da mora još laboratorija da se uključi intenzivno u ova testiranja, znači po centrima, i da se uopšte razvija ta strateški molekularno-dijagnostički laboratorij. Tu mislim i na veći broj patologa i molekularnih biologa, jer smo mi u situaciji da tih testiranja će biti sve više. To je to. Ali i eto tu apelujem, znači Institut za onkologiju Vojvodine, Niš, konkretno NGS zahteva dosta obuke implementacije, ali metode kvantitativnog PCR-a to je relativno jednostavno. Iako ne govorimo o velikom broju pacijenata, ne treba posebnog treninga.
Hvala. Svetlana, imaš ti nešto da dodaš?
Ne, ja sam samo htjela da kažem da koliko god se nama čini, ovo što je Laza malo pre rekao i Aljoša, ne radi veliki broj centara kompletnu dijagnostiku, tako da potpuno se slažem sa doktorom Radom, apsolutno moramo definisati slučajeve u kojima će se to raditi. Znači, postaviti prave indikacije gde će se dovesti do kraja, s tim što svi mi moramo, znači i vi kao molekularni i mi kao patolozi da prođemo odgovarajući trening, jer indikacije su različite, zavise od mnogo toga, da sad ne ulazimo u detalje zbog čega i kako, i da nam se jednostavno jasno definišu cut-offovi. To je kod nas ogroman problem za koji većinu nemamo, uključujući, recimo, zamislite kad bi vama sad rekla da estrogen koji se određuje kod karcinoma endometrijuma nema definisani cut-off. Znači, neki kažu to je 1% pozitivnosti, drugi kažu ne, to je 10% pozitivnosti. To nije mala razlika. Znači, moraju se definisati, tako mora biti i za deficijenciju, odnosno MSI, jer mi drugačije nećemo moći funkcionisati, imat ćete lažno pozitivne ili lažno negativne rezultate. Mislim da nas čeka veliki zadatak. Recimo, jedna čuvena Ester Oliva koja piše sve ginekološke knjige iz patologije, kaže, ali ja nemam polimutaciju. Ja radim samo u određenim slučajevima i šaljem me u druge centre. Se postavlja pitanje kako ćemo raditi potpunu centralizaciju. Jer to podrazumeva i molekularnu, i patologiju, i hirurgiju, i sve drugo.
Svakako o tome moramo da razmišljamo. Interesuje me da mi doktorka Anđela Karaferić kaže ima li mesta PARP inhibitorima u karcinomu endometrijuma?
Pa ima mesta PARP inhibitorima u karcinomu endometrijuma. Videli smo kad smo prošli, kako si ti lepo izlagala, kroz ove studije, videli smo da PARP inhibitori, naročito kod deficient MMR, imaju odgovor na PARP inhibitore karcinomi i nije nam potrebno brka testiranje, jer smo videli da kod P53 ovih pozitivnih pacijenata imaju odličan odgovor na PARP inhibitore.
Hvala. I za radioterapeuta Mirjanu Miković pitanje, da li vi smatrate da u slučaju oligoprogresije treba nastaviti lečenje istom sistemskom terapijom i da se primini SBRT na, recimo, koliko imamo izolovano samo supraklavikulnu žlezdu i koliko imamo parcijalnu remisiju svega onog što pratimo, a zapravo imamo samo izolovano jednu malu žlezdu koja je krenula da raste. Da li mislite da ipak ako smo na putu nekog dobrog odgovora, da bi tu SBRT imao nekog svoje mesto? I gde se radi?
Radi. Radioterapija, stereotaktična radioterapija je apsolutno indikovana u takvim slučajevima. Znači, ja bih dala, znači to je moje lično mišljenje, mislim da se i kolege radijacioni onkolozi slažu. U slučajima, znači to je oligoprogresija, u oligometastatskoj bolesti svakako se daje, tako da već smo to radili, znači imali smo metastaze u ramenom pojasu, sve drugo je bilo pod kontrolom, znači parcijalna regresija, samo je tu postojala masa koju smo ozračili i žena je zaista, znači to je zračna terapija bez nekroze, radionekroze, držala je nekih 1,5 godinu dana do progresije.
I samo da nam malo objasnite, da li se SBRT radi i u našoj ustanovi, na institutu, ili isključivo kod Biljane Šehje na neurohirurgiji?
Radi se i kod nas.
I kod vas, da li se radi takođe? Recite nam gde vi radite, pa da samo...
Univerzitetski klinički centar Kragujevac, za sada se SBRT ne radi standardno, očekujemo da ćemo u toku naredne godine da počnemo, ali imamo iskustva, kao što je rekla koleginica Miković, sa slanjem pacijentkinja, kada verifikujemo oligoprogresiju u Centar za X-nož da se sprovede lečenje do kraja. I odličan je odgovor uvek.
Hvala. Miro, znači radi se i kod nas. A kada se vi, Mirjana, odlučujete da šaljete u drugu ustanovu, a kada se odlučujete da to uradite vi lično?
U principu, da kažem, serijski pošaljemo u drugu ustanovu, znači ipak su mogućnosti X-noža malo preciznije nego naših linearnih akceleratora, ali
Princip je isti, je tako?
Princip je isti, ali u slučaju da se odluči da to ipak ne može da se uradi na X-nožu, mi možemo da uradimo i drugačijim tipom frakcioniranja, možemo da uradimo i stereotaksu, znači sve moguće. Pokazat ću posle u svom predavanju šta radimo, zaista.
Pa mi moramo zbog vremena da idemo dalje i sad ćemo upravo od Mirjane Miković čuti novine u karcinoma endometrijuma iz ugla radioterapije. Ja molim da ostanu ovde doktor Tomašević, doktorka Marija Živković. Miković, izvoli tamo. Vi, gospođo, ne znam da li treba Svetlana da idete. Svetlana? Ne, Svetlana... Kontroler. Uzmi ovaj. Mnogo često.
Uvaženi gosti, veliko mi je zadovoljstvo što mogu sa vama da prodiskutujem neke nedoumice koje je ova nova FIGO klasifikacija unela u rad konzilijuma i specijalno za donošenje odluke o adjuvantnom lečenju. Samo da vidim. Radioterapija ima veoma značajno mesto u lečenju karcinoma endometrijuma. Moram pomenuti jednu studiju, to je GOG 258, gde je praktično poređen režim PORTEK 3 studije, konkomitantne hemioradio sa sekvencijalnom hemioterapijom i poređen je sa isključivo hemioterapijom. Naravno, drastična razlika je bila u relapsu bolesti u grani koja je imala samo hemioterapiju. Zapitali smo se odakle im ideje uopšte da izbace radioterapiju u konstrukciji takve studije. Kako je dajemo? Dajemo je uglavnom u postoperativnom settingu, znači sve što može da se operiše, treba da se operiše. Može da se da kao brahiterapija, kao transkutana i brahiterapija i da se time završi lečenje, kasnije praćenje, a može da se da u kombinaciji sa hemioterapijom brahiterapija, što će biti praktično sleduje transkutana zračna terapija u višim stadijumima bolesti. Radikalna zračna terapija se sprovodi ukoliko je hirurgija iz bilo kog razloga kontraindikovana. U slučaju lokalne progresije bolesti, znači da je tumor neresektabilan, znači u slučajevima komorbiditeta, senijuma ili ekstremnog obesitasa, kada jednostavno se očekuje da zaceljivanje neće ići dobrim tokom, možemo da sprovedemo radikalnu zračnu terapiju. Palijativna zračna terapija pelvisa se vrlo efikasno sprovodi u slučajevima zaustavljanja krvarenja u hemostatske svrhe, a takođe da dajemo palijativnu zračnu terapiju na metastaze, znači kako koštane, ali simptomatske koštane metastaze. I ovde moram napraviti malu digresiju. Astro je dao vrlo specifične preporuke za te koštane metastaze kada se daje samo single shoot, kada se daje frakcionirani režim, a samo single shoot ne treba da zaboravimo da je to specifično onkološko lečenje i da je nekada najbolja suportivna terapija od maltretiranja pacijenta da dođe da bi se isplanirao za zračenje. Stereotaksa, upravo smo rekli, odnosno pomenuli, apsolutno ima ulogu u oligometastatskoj bolesti, kao i u određenim, znači, manjim oligoprogresijama, kada može da se nastavi sa hemioterapijskim protokolom i da se elegantno sprovede zračna terapija. Sad ono što mi radimo, transkutana zračna terapija, znači je po najvišim svetskim standardima kod nas uvedena od 2018. godine, kraja 2018. godine, i to kao AMRT, vidite i sami doznu distribuciju, sve ovo što je zeleno je pokriveno zračnom terapijom, ovo što je sivo praktično ne prima dozu koju prima volumen od interesa. VIMAT tehnika još bolje može pokriti ono što nam treba. I ovde može da se vidi, znači, jedan postoperativni plan gde su praktično limfatici, vagina i ožiljak odlično pokriveni, a vidi se položaj vrlo nepovoljan creva u karlici, koja će svakako primiti neku dozu, ali neće primiti punu dozu kao što je rađeno ranijim tehnikama. 3D CT MR planirana brahiterapija, CT ili MR planirana brahiterapija je nešto što mi rutinski radimo, međutim, to su sve time consuming tehnike koje zahtevaju minimum sat vremena planiranja, minimum, znači skener, a kada je u pitanju magnet, samo snimanje magneta traje 40 minuta, možda tu negde pola sata do 40 minuta. Zašto su nam one bitne? Jako je važno da vidite i kateter u bešici na ovom jednom na ovoj jednoj slici, mi možemo tu manipulacijom ispunjenosti bešike i rektuma da dovedemo do željenog položaja i da utičemo na položaj organa od rizika da prime manju dozu, a da bude ozračeno, znači ono što treba da bude, a to je zid vagine i ožiljak. Takođe, manuelnom optimizacijom možemo da utičemo na pozicije ovog izvora, vidite crvene tačkice, znači u samom vaginalnom aplikatoru, tako da zadržavanjem tih pozicija i njihovim mestom mi možemo da utičemo koliko će praktično ti organi od rizika da prime. Međutim, šta je stvar? Stvar je u tome što ovo traži vreme. Nama broj tih 3D, CT, MR planiranih brahiterapija diktira broj pacijentkinja, znači koji je veliki. U decembru 2020. godine već smo videli na jednom od prethodnih predavanja, mislim Marijaninom, upravo ovu tabelu. ESGO, ESTRO i SP preporuke su stigle, znači i low, intermediate, hard i high, intermediate, high grupe su prepoznate. Uveden je pojam molekularne klasifikacije, još uvek se nije znalo koliko će ona uticati zaista na preživljavanje, ali i dan danas ne znamo kako utiče na izbor terapije. Takođe, limfovaskularna invazija je definisana kao nepostojeća, fokalna ili ekstenzivna, znači ne samo prisutna ili odsutna, tako da jednostavno tu smo već dobili neke podatke koji će u sadašnjoj FIGO klasifikaciji biti malo više razmotreni. Reagovao je nacionalni radioterapijski tim odnosno radna grupa za izradu nacionalnog protokola i mi smo u julu 2022. godine dobili nacionalni radioterapijski protokol za lečenje karcinoma endometrijuma od CT planiranja do pregleda plana i izvođenja same zračne terapije. Evo kako izgleda. Znači, ja sam ovde izabrala samo tabelu za adjuvantnu radioterapiju i za palijativnu radioterapiju. Znači, ovde imamo vrlo jasne preporuke gde treba praćenje, gde treba samo brahiterapija, gde treba da se da kompletna zračna terapija. Stigla nam je onda FIGO klasifikacija 2023. godine. O njoj smo puno diskutovali na prethodnoj kancerološkoj nedelji. I definisani su najvažniji nezavisni prognostički faktori koji direktno utiču na ishod lečenja. Pre svega patohistološki tip tumora, histološki gradus, molekularni podtip ako je dostupan, prisustvo ekstenzivne limfovaskularne invazije i stepen proširenosti bolesti van endometrijuma. Ali vidjet ćemo da li je to baš tako. Najveće promene su izvršene u prvom i drugom stadijumu. Prvi stadijum je razložen na 3 podstadijuma, prvi A podstadijum na još 3 podstadijuma. Endometrioidni adenokarcinom gradusa 3 svrstan je u visokorizične tumore sa praktično najvećim benefitom od ovog molekularnog testiranja. A ekstenzivna limfovaskularna invazija je takav prognostički faktor da povećava stadijum nezavisno od podtipa tumora. Kontroverze, znači, sa kojima se mi susrećemo svaki dan na konzilijumu, znači kako ovo može da se interpretira. Stadijum 1C, puno je bilo reči o njemu, znači agresivni histološki tipovi ograničeni na endometrijum. Da li ostaviti pacijentkinju bez terapije ili sprovesti samo brahiterapiju ili ipak uraditi transkutanu zračnu terapiju, ipak se radi o agresivnim histološkim tipovima. 2B stadijum su neagresivni histološki podtipovi ograničeni na uterus sa ekstenzivnom LVI, znači koja je izolovana kao sama po sebi izuzetan prognostički faktor. Ali šta uraditi kada imamo mali tumor sa negativnim žlezdama, imali smo tu dilemu pre jedno mesec dana, 0 žlezda pozitivno od 9 izvađenih, što nije mali broj izvađenih, sa plitkom invazijom 3 mm miometrijuma i znači ekstenzivnom LVI. Šta uraditi? Mi smo ipak doneli odluku za brahiterapiju. Stadijum 1A3, takođe puno se pričalo o njemu, niskogradusni endometrijoidni karcinom endometrijuma sa ekstenzijom na unilateralni ovarijum uz ispunjene sve one uske kriterijume da bi to iz 3. stadijuma bio u stvari 1A3. Šta uraditi? Da li bismo se usudili da pacijentkinju samo pratimo ili bismo joj dali adjuvantnu terapiju? Ovo je sad bila samo priča bez molekularne klasifikacije. Molekularno profilisanje je unelo još neke dodatne nedoumice, jer su se izdvojila 4, ali u stvari dva dijametralno različita subseta pacijentkinja, znači oni sa poliultramultiranim, tumorima i one koje su P53 pozitivne. Ali videli smo da i ta pozitivnost nije baš tako jednostavna. Ono što nas najviše buni na ovim konzilijuma jeste stadijum 1A M polimutirani. Šta to znači? Endometrijalni karcinom ograničen na korpus uterusa, ne na endometrijum, nego na korpus uterusa, sa ili bez cervikalne ekstenzije, nevezano za stepen, znači može da nema LVI, može da ima ekstenzivnu LVI i za njega je apsolutno preporuka u ovim poslednjim nekim predavanjima, diskusijama, da se ne radi ništa. Da li bismo se usudili da pacijentkinje ne damo baš ništa? A stadijum 2C, P abnormalni, znači endometrijalni karcinom, ograničen takođe na korpus uterusa sa bilo kakvom miometrijalnom invazijom, znači čak i plitkom, sa ili bez cervikalne invazije, recimo da nema cervikalnu invaziju, i nevezano status LVI, recimo da nema LVI uopšte, znači plitka invazija, nema LVI i nema cervikalnu invaziju. Znači ona bi po preporukama trebala da primi komplet terapiju. mi bismo ovde najverovatnije za takav subset dali samo brah. Potpuno je neverovatno da idemo iz krajnosti u krajnost. Indikacije za adjuvantnu terapiju smo očekivali, znači kao dopunu onih ESGO-ESTRO ESP preporuka prošle godine na ESGO kongresu, pa onda na ESTRO kongresu, međutim i dalje ih nema. ASCO i ASTRO za sada takođe se ne oglašavaju, znači kolege iz Memorial Sloan Kettering bolnice su rekli da oni neće prihvatiti još uvek tu FIGO klasifikaciju, ali će da je prate. Svakako, oni mogu da testiraju sve, znači njima je sve dostupno, ali jednostavno za sada nema snažnih preporuka šta raditi dalje. Šta je onda nama činiti na konzilijuma? Individualizovan multidisciplinarni pristup, znači tim mora da donese odluku o lečenju za svaku pojedinačnu pacijentkinju na osnovu onoga što praktično ima. Hvala vam na pažnji.
Da prodiskutujemo, pošto vreme leti. Prvo za doktorku Mariju Živković, radioterapeuta, možete li mi reći da li vi smatrate da ovim novim tehnikama, konformalnim IMRT i VMAT, uspevamo da zaštitimo od creva mokričnu bežiku u dovoljnoj količini i dovoljno kvantitativno prema vama, ili mislite da treba nešto ipak da se učini još bolje za naše pacijentke? Koliko se vi u vašoj redovnoj kliničkoj praksi susrećete sa ipak cistitisima, kolitisima i tako dalje?
U našem centru standardno primenjujemo sve te tehnike i mogu da kažem koliko god da se trudimo da poštedimo organe od rizika, one kod pacijentkinja sa ginekološkim malignitetima zaista prime znatnu dozu i ta doza nije beznačajna, pogotovo što su pacijentkinje sve manje, a rizik od kasne toksičnosti je ekstremno veliki. Zbog toga bi nam zaista bilo od velike koristi i da imamo i dodatne istraživanja, pogotovo kada je u pitanju poliultramutacija, da strogo selektujemo pacijentkinje kod kojih je praćenje bezbedno, da izbegnemo radioterapiju, što je značajan benefit i za pacijentkinja i za zdravstveni sistem uopšte. Međutim, očekujemo rezultate Rainbow studije, Portek 4a, da možemo ipak da donesemo neke pouzdane zaključke.
Hvala mnogo. Profesore, odnosno docente, direktore Tomašević, Aleksandru, šta se i sve. Reci mi, molim te, da li ti smatraš da bi ti voleo sada, prilikom odluke, da li ćeš zračiti ili kako ćeš zračiti svog pacijenta, da ipak čuješ od naše Svetlane i Rade molekularnu klasifikaciju za pacijente koji imaju...
Voleo bi svakako, molekularna klasifikacija će da utiče definitivno na definisanje, odnosno redefinisanje grupa rizika koji već postoje i tako da će uticati na odluku kod koje pacijentkinje sprovesti transkutanu zračnu terapiju, kod koje sprovesti samo brahiterapiju, pa je spasiti postiradijacione toksičnosti, koju samo pratiti, a kod koje možda sprovesti sistemsko lečenje. Kratko samo, što se tiče radioterapije, nama je najinteresantnija ona intermediate risk grupa pacijentkinja i tu čekamo Portek 4 trial da se završe, se objave rezultati. To je prva studija koja je od starta uzela u razmatranje molekularnu klasifikaciju radi određivanja koja će pacijentkinja primiti koju vrstu adjuvantne radioterapije. Tako da to mislim da se očekuje 25 sledeće godine na ESTRO ili ESGO kongresu i to će biti interesantno.
Sjajno, hvala. A sada da čujemo od doktorke Ilinke iz Niša. Da li biste vi sada da možete sve i da vam RFZO apsolutno sve dozvoljava, kad biste imali mismatch repair deficient pacijenta u metastaskom endometrialnom karcinomu, da li biste volili da date checkpoint inhibitor uz hemioterapiju? Da li mislite da ovi rezultati o kojima smo pričali su dovoljno ubedljivi ili ipak ne?
Hvala Marijana. Pre nego što ti odgovorim na pitanje, dozvoli mi da ukratko kažem da smo svedoci da poslednjih godina u našoj zemlji stopa incidenca endometrialnog karcinoma raste. sve je više endometrijalnih karcinoma sa primarnom prezentacijom kao lokalno odmakla bolest, sve je više rekurentnih endometrijalnih karcinoma i to je jedna strana priče. Druga strana priče je da mi više od 2 decenije, 25, ako ne i više godina, evo ispravite me, osim doksorubicina, cisplatine, hormonoterapije koju pacijentkinje kupuju same i unazad 2 godine sistemske terapije po režimu TC, faktički nemamo ništa da ponudimo u terapijskom smislu tim pacijentkinjama. Obzirom da se mi mnogo pomogla iznoseći sve ove studije, pre svega RUBI studiju, pre svega NRG studiju 018, koja je ispitivala, znači, dodavanje checkpoint inhibitora, koji inače kod mnogih tumora prave pravi pomak, preokret u terapiji i u tom terapijskom algoritmu, pa tako i kod endometrijalnog karcinoma. Vidimo da je hazard ratio 0,28, 0,30, znači 70% pacijentkinja ima smanjen rizik od progresije bolesti ili smrti, a čak ova NRG studija 0,18, kada se pogleda i ukupno preživljavanje, koje je jako bitno, jer ono direktno implicira na naš svakodnevni klinički rad, isto daje ovako značajan pomak i u tom opštem preživljavanju, jer je hazard ratio za ukupno preživljavanje 0,55. I one krive razdvajanja, znači kad se pembrolizumab dodaje standardnoj hemioterapiji taksol karboplatina, krive razdvajanja počinju već veoma rano da se razdvajaju, što mi klinički onkolozi to volimo da vidimo i što je dobro, ali se zapravo to razdvajanje jako dugo održava i u samom periodu praćenja pacijenta. Znači, to je apsolutni dokaz da kod mismatch repair deficijentnih pacijentkinja treba dodati i ne bežati od toga, pogotovo ako Republički fond to, nadamo se, recimo u neko skorije vreme već do godine ili kako god, to dozvoli da ide, znači, preko fonda. Treba svakako standardnoj hemioterapiji taksol karboplatina dodati pembrolizumab, jer je efikasnost i u smislu PFS-a i u smislu ukupnog preživljavanja i u smislu stope odgovora i u smislu dužine trajanja odgovora impozantna, a s druge strane neželjeni efekti, jer i o tome treba voditi računa čisto zbog onog, kako da kažem, zbog pacijenata, da budu što više komplijantni pacijenti, znači iz tog razloga isto nemamo dokaze, zapravo pokazano je da dodatak pembrolizumaba standardnoj hemioterapiji nije povećao neželjene efekte hemioterapije koju mi standardno dajemo, sa kojom se nosimo, možemo da kontrolišemo te neželjene efekte, a s druge strane imunološki posredovani neželjeni efekti dodatkom pembrolizumaba nisu bili ništa veći nego kada se pembro koristio sam kao monoterapija. Znači, svakako bih uvrstila.
Hvala, Ilinka. I sada da čujemo još samo Lidiju Pavlović da proba da nam objasni da li možda možemo kod rekurentnog metastatskog karcinoma endometrijuma u nekoj bliskoj ili možda malo daljoj budućnosti očekivati da možemo izbeći hemioterapiju.
Pa, ja se nadam da se čujem. Mi smo otvorili Pandorinu kutiju, šta ćemo sve dobiti, od još uvek ne znamo, ali ono što definitivno znamo da i što su u svetu pokazale i studije i klinički podaci da primena imunološke terapije u drugoj liniji na progresiju nakon hemioterapije kombinovane sa imunološkom terapijom je pokazala odlične rezultate i u ukupnom preživljavanju i u response rate-u. Tako da se ja iskreno nadam da će to biti standard za lečenje znači progresije, tačnije rečeno, karcinoma endometrijuma i da će biti kao monoterapija bez hemioterapije standard lečenja endometrioidnog karcinoma u budućnosti. Za sada još uvek to kod nas nije, a za svet ponegde jeste, u većem delu sveta ne. Ja se iskreno nadam da će kod nas doći i za prvu liniju u kombinaciji sa hemioterapijom, a i druga linija kao na progresiju ili kao progresija na prvu liniju kao monoterapija.
Hvala vam. Evo za sada još samo da dodam na ovo LEAP studija koja je trebalo da dokaže da je hemioterapija vrlo easy da se izostavi je za sad negativna. Imamo 2 još uskoro, Dominika i još jedna koja vidjet ćemo da će biti pozitivna. Naše pacijentkinje bi stvarno volele da budu efikasno lečena, ali da izbjegnu hemioterapiju. To svakako neće biti tako jednostavno, ali ne i nemoguće. I ja ovim završavam današnji sastanak. dugo je trajao, ali da znate, nismo mi toliko probili termin, nego oni mnogo pre nas, tako da, da znate, mi smo ipak u nekom tajmingu. Idemo dalje, važi, a sada ide Astrin sastanak, molim da svi ostanu, bit će jako interesantan i na sledećem sastanku da znate da ćete čuti nešto mnogo bitno i nešto novo, a za sve nas i za naše pacijente sa karcinomom jajnika jako, jako važno. I ako vam se ide na pauzu, nemojte sada. A šta znači? Sad idemo na ručak? Ne, nemojte ići na ručak, sada nema ručka, pa reci da nema ručka. Ručak je posle. Znači, moći ćete da ručate posle.
Nestao ručak.
Sedimo. Daj vodu. Evo, pričam ceo dan bez vode. Odme mi do čaše, odme mi. Piješ čaše? Ja krećem, ja svojim ne. I šta, nikako uvodim se po pasu. Ti krećem. Kako je do sada išao? Za brk. Evo Lilja završi sastav. Nekada će da dođe. Pogledaj ko nam je u zadnjem došao. E pa, stigli smo sada do nečega što je, kažem, mnogo bitno. Oni koji su ostali u sali čuće nešto mnogo važno. Oni koji su izašli, bolje da uđu, zato što zaista biće jako važno, a ne znam da li ćete stići da čujete posle od nekoga. Znači ovako, pričamo o karcinomu jajnika, zapravo hronika karcinoma jajnika od brka početka do HRD horizonta. I ono što sam htjela da vam kažem, ok, što se ono kaže, ruka je stare tehnike. Ok. Pa, svi znamo da imati iskustvo sa karcinomom jajnika je zapravo zaista frustrirajuće i teško, ali negde imamo i neko svetlo zahvaljujući određenim... Nisam to ja. Pa na koji kliker ne radi? Ali, okej. Neću diram ništa. U svakom slučaju, zaista godinama već radimo sa karcinomom jajnika i jeste frustrirajuće jer je to podmukla bolest koja zapravo ne može skoro nikako da se prepozna u prvom i drugom stadijumu jer ne daje apsolutno simptome, a u trećem kad kreće da daje simptome vrlo često budu posljedica kompresije tumora na okolne organe, tako da često zaobilaze ginekologa, idu prvo kod gastroenterologa, pa urologa, a tek onda stižu kod ginekologa. I naravno, uprkos odličnoj hirurgiji i primjeni hemioterapije, definitivno negde oko 70% pacijentkinja ipak relapsira unutar prvih 3 godine i apsolutno je bilo više nego jasno da moramo da učinimo nešto, da produžimo to vreme do relapsa, da učinimo da naše pacijentkinje što duže budu bolje, jer znamo da svaki sledeći relaps nosi sve veću rezistenciju na terapiju. I ono što je bitno i najvažnije što se desilo u karcinomu jajnika u poslednjih godina je zapravo SOLO-1 studija koja je pokazala da primjena PARP inhibitora kod brka pozitivnih high grade seroznih karcinoma u maintenance terapiji donosi jednu apsolutnu prednost u pogledu redukcije rizika za progresiju i relaps bolesti 70%, ali isto tako imamo više nego jasan benefit i u pogledu ukupnog preživljavanja, jedan jasan trend i jasan numerički benefit sa redukcijom rizika za smrtni ishod 45% i ono što je 7-godišnja deskriptivna statistika pokazala da nakon 7 godina zapravo imamo definitivno oko skoro 70% pacijentkinja sa karcinomom jajnika 3. i 4. stadijum koji su i dalje žive, što je ranije bila mislena imenica jer su uglavnom živele do najviše 3 godine. I da, mi imamo naravno divno iskustva i sa Solo 2 i Solo 1 studijom, dugo već dajemo olaparib, imamo naravno iskustva i sa PARP inhibitorima, ali moje najvažnije pitanje jeste zapravo za Radu, kako izgleda izvođenje analize BRCA mutacija i kakvi su naši rezultati vezano za BRCA mutacije?
Dobar dan svima, hvala na pozivu kompaniji AstraZeneca. Na početku bih da kažem da je kompanija AstraZeneca uz nas dosta doprinela razvoju NGS testiranja, što nije malo reći. Ajmo dalje. Ne.
Da klikam, ali vredi. Zabagovala tehnika, that's it.
Ništa, ide ovdje. Put pacijenta, kako to volimo da kažemo, što se tiče novodiagnostikovanog karcinoma ovarijuma seroznog tipa visokog gradusa, počeo je 2021. godine. Moram da kažem da je to vrlo važno zbog razloga jer smo tad prvi put u Srbiji uveli takozvano refleksno testiranje, odnosno patolog šalje uzorak. Evo gledam u doktorku Milenković i doktorka Jovanića koja je tu. Nije to bilo lako uraditi, ali smo uradili iz prostog razloga što je vrlo važno imati rezultate na vreme. Tako da je svaki dan bio važan. Sad nema ništa, ali dobro.
Ovdje ima. Bolje ti da sad siđete dole.
Evo ga, okej. Ali idu sad? Ne.
Što sam do sada radila?
Da, nismo završili ni prethodni slajd, ja se izvinjamo, nešto stvarno nije u redu, ali ajde, dobro. Ok. Patolog ili konzilijum upućuje uzorak na tumorsko testiranje, tumorsko BRCA testiranje. Kad kažem tumorsko, radi se iz uzoraka tumora, ali pokriva i germinativne somatske mutacije, što je vrlo važno, što je bila naša racionala da krenemo od tumorskog tkiva. Testiranje se završava naravno rezultatom gde detektujemo mutaciju koja je klinički značajna i koja čini pacijenta senzitivni za PARP inhibitorom ili ne detektujemo mutaciju. Prema tome, taj pacijent je wild type. Pošto se radi o testiranju iz tumorskog tkiva, ja uvek moram da spomenem, a što piše na našim rezultatima, kad se detektuje mutacija, to jeste dovoljno za lek, da pacijent bude kandidat za terapiju, ali što se tiče porodične istorije bolesti i procene rizika, procena je da se pacijent upućuje u savjetovalište za nasledni karcinom. U slučajevima kad taj kalup nije bio dobar, a drago mi je reći da je tih slučajeva sve manje, onda smo radili testiranje iz krvi, odnosno radilo se germinativno testiranje. Ovo su naši rezultati, kao što vidite, dosta već testirano pacijenata, nešto preko 800 od 2021. godine. Ono što vas molim da obratite pažnju, to su procenat BRCA mutiranih koji se kreće u literaturnim podacima i na broj neuspelih analiza koji je rapidno manje nego prošlih godina. Naravno, tu zahvalnost opet dugujemo patolozima, edukaciji, ali i samom testu i samom aparatu koji sada koristimo, tako da taj broj uspešnih analiza raste iz godine u godinu. I zahvaljujući tom procentu BRCA mutacija takođe možemo reći da ta analiza ide dobro, da je validirana i da je dobro ustaljena u našoj laboratoriji. Naravno, to što mi znamo da je dobro nije dovoljno za ostale, tako da ja apelujem uvek kada pričam da sve laboratorije učestvuju u eksternim kontrolama kvaliteta, odnosno da proverimo da li je to što mi radimo dobro, jer taj rezultat odlučuje o sudbini pacijenta. Drago mi je da kažem da smo u 2 rana eksterne kontrole kvaliteta svetski priznatih tela imali maksimalni broj poena za određivanje somatskih BRCA1 i BRCA2 mutacija kod pacijenata sa karcinomom ovarijuma. Naravno, sledeće pitanje, da li je to dosta? Pa u molekularnoj biologiji nikad nije dosta i uvek znamo da jedan biomarker povlači druge, što je dobro. Tako da pitanje za vas, molim vas da skenirate ovaj kod i da glasate, da li vam je poznat pojam HRD, odnosno šta je HRD testiranje? To nam je važno da nastavimo.
Pa oni sve znaju, što smo mi ovde?
Dobro. Sad ja idem, da. Okay. Dobro. Onda me ispravite ako ja nešto pogrešim kad pričam, pošto svi sve znamo, ali tako? Dobro, idemo dalje. Sam pojam znači deficijencija homologne rekombinacije. Homologne rekombinacije je jedan od puteva popravka dvolančanih prekida u DNK pri popravci ćelije i deobi ćelije. Usled raznih grešaka dolazi do tog sindroma deficijencije i ona je utvrđena do čak od 50% pacijentkinja sa karcinomom ovarijuma. Kako se ona definiše? Pa mi smo prvo krenuli sa brka mutacijama, vidite taj puls leve strane i to prvo sa germinativnim brka mutacijama, koji kod karcinoma ovarijuma bilo oko 17%. Testiranje iz krvi uvek jednostavnije, bilo je već ustavljeno u našoj laboratoriji u okviru naslednog savjetovališta za nasledni kancer, pa je bilo logično da time krenemo. Međutim, utvrđeno je atlasom tumorskog genoma da ima 7 do 8% koji se samo nalaze u tumorskom tkivu. Naravno da nije bio cilj izgubiti tu trećinu pacijentkinja. Šta se dešava dalje? Osim brka mutacija, brka 1 i 2 mutacije su važni geni u putu popravke dvolančanih prekida DNK, to je homology recombination repair, ali nisu sami. Tu imamo ukupno 28 gena, čiji gubitak funkcije takođe utiče na pojavu HRD, a osim mutacije na to utiču i različite druge genetičke alteracije, kao što je hipermetilacija, različite promene i tako da mi...
Imamo mi nešto, neke logističke zahteve, sad mi kao kliničari prema vama, jer treba neke zahteve posebno da pišemo.
Što se tiče kliničara, patologa, ne menja se ništa. Znači, put pacijenta ostane isti, ostaje ista indikacija. Ono što se menja, menja se kod nas u laboratoriji, evo vidim devojke pa i mašem, znači upravo se radimo na uvođenju metode, setujemo uzorke, što je ono najuzbudljivije, ali eto i velika je odgovornost. Što se tiče konkretno HRD-a, ako ga pogledamo, šta mi detektujemo, možemo ga detektovati, kako oni to lepo, kroz uzrok i posledicu. Uzrok su upravno te mutacije, znači u BRCA genima, ostalim HRR genima, metilaciji, to je uzrok. A šta je efekat? Sve te promene, eto, opet. Ja se izvinjavam ceo dan. Znači, efekat su, upravo je taj HRD, odnosno taj genomski zapis, jer usled svih ovih alteracija u HRR genima, ostalih genetičkih alteracija, dolazi takozvani, kako ih zovu u literaturi, genetičkih oželjka, skarova, koji predstavljaju te aberacije i koje se mogu različito definisati. Ovde su date 3 najčešće i to ste verovatno čitali jer je prvi panel koji je validiran za procenu HRD skora, ja ništa ne pritiskam, a to ide samo, ali dobro, ali ja ću ubrzati. Znači, koje su 3 najčešća genetička oželjka kad se spomenu, pa to su disbalans alela u telomerama, gubitak heterozigodnosti i velike tranzicije na nivou hromozomnih brejkova, koje takođe dovode sve do tih genetičkih oželjaka koje zovemo HRD zapisom ili HRD signaturom. Kao što vidite dole, osim ovih vrsta testova, može se koristiti i funkcionalni testovi, gde se, na primer, ispituje funkcionalnost proteina u kulturama, ali to baš nije zaživjelo u dijagnostici, a ovde imamo Postoje par testova, naravno, kako vam kažem, kada neki lek uđe u listu sa određenim indikacijom, biomarkerom, eto nama puno testova koji ulaze na tržište, svi se validiraju u odnosu na prvi My Choice test, ima ih dosta, mi ćemo pričati danas malo kasnije o nekom koji smo mi izabrali, ali je bitno da budu IVD validirani i testovi. Sada, sa strane istraživača, nama je jasno šta je HRD i šta se povećava. Šta znači kliničarima?
Kliničarima znači mnogo, vidjet ćete. Ja pre svega želim da vam kažem da mi do sada možemo da lečimo oko 20 do 20% high grade seroznih ovarijalnih karcinoma brka mutiranih. Sa HRD-em očekujemo da to bude još 25%. Znači, to je ključ, da ćemo mi danas moći već sutra u stvari da 50% pacijentkinja uspešno lečimo, sada to možemo kod 25%. Sada, zašto i kako? Pa Paola studija je zapravo studija koja je trebalo da dokaže da li dodavanje limparze u maintenance režimu, bevacizumabu, kod pacijentkinja koji su imale odlične odgovore na prethodnu hemioterapiju uz BEV, znači parcijalni odgovor i kompletni odgovor, a radilo se naravno o high grade seroznim ovarijalnim karcinomima faze 3 i 4, da li to donosi dodatni benefit, pre svega u pogledu redukcije rizika za progresiju, a tu su naravno i sekundarni ciljevi, PFS2, ukupno preživljavanje, vreme do sledstvene terapije, vreme do sekundarne sledstvene terapije i kvalitet života. Sada, ono što je najvažnije, to je da je Paola studija pokazala prilično sličnu stratifikaciju pacijenata kao što se inače dešava i u svetu, a to je da je otprilike u ovoj studiji bilo registrovano ukupno brka pozitivnih 29%, a onih koji su brka negativni, a HRD pozitivni, znači imaju deficijentan mehanizam homologne rekombinacije, bilo ih je 19%. Ono što je takođe važno, to je da je studija Paola apsolutno dosegla svoj primarni cilj, odnosno u ukupnoj populaciji pokazana je jasna redukcija rizika za progresiju, praktično 40%, statistički i klinički značajna. A onda je urađena naknadno specificirana stratifikovana analiza podgrupa, gde je pokazano da u grupi brka mutiranih imamo apsolutno hazard ratio 0,31, što znači redukcija 70% za progresiju, prilično slično kao što imamo i u Solo 1 studiji. A onda kada pogledamo brka nemutiranu populaciju, ali HRD pozitivnu, vidimo takođe hazard ratio 0,33, znači sjajan rezultat kombinacije PARP-a i bevacizumaba, a kod HRD negativnih, kao proof of concept, imamo hazard ratio 1, znači nikakav benefit od dodatka limparze. Sada, definitivno, medijana PFS-a je gotovo 4 godine sa lekom limparza. Imamo 46,8 meseci u odnosu na samo 17,6 sa hemioterapijom i BEV-om, 3 puta duža medijana PFS-a, jasno statistički i klinički značajno. A sada, vezano za ukupno preživljavanje, da li to vidite, vidimo da zapravo nakon 5 godina 65,5% pacijentki i dalje živo, samo 48% bez limparze i vidimo zapravo 38% redukcija rizika od smrti ukoliko uz BEV, prethodnu hemioterapiju i BEV dodamo i limparzu. I mene interesuje sada vi, kad ste kliničari i ispred sebe imate pacijenta, da li biste vi razmišljali toliko o adverziventima, o kvalitetu života vaših pacijenata, ili bi vam ovi impresivni rezultati Paole mnogo značili i ipak biste jako razmišljali o efikasnosti i o mogućnosti da produžite život vašim pacijentkinjama, ili uopšte niste razmišljali o tome, u što naravno sumnjam. Pa sjajno. Naravno, kvalitet života, profil neželjenih efekata je važan, ali važna je naravno i efikasnost. Apsolutno nam je sve važno i treba da naravno sve to dobro analiziramo i dobro uvek promislimo individualizovano i personalizovano o svakom pacijentu. Ali Ono što je bitno, to je da je u studiji Paola pokazano da nije bilo neke kumulativnih neželjenih događaja, već su svi neželjeni događaji odgovarali već poznatim, prepoznatim sigurnosnim profilima, pojedinačno leka limparza i pojedinačno leka bevacizumab, i naravno da smo morali, da ćemo morati skrupulozno i pozorno gledati svaki pojedinačni neželjeni efekat, na vreme prepoznati, na vreme redukovati dozu i dobro hendlovati sve neželjene efekte i na taj način omogućiti dobru adherenciju i persistenciju i naravno kontinuiranu primjenu terapije. Jer zapamtite, dobro je redukovati dozu ako je neophodno i to neće kompromitovati efikasnost. Znači nikada ne treba po svaku cenu ići sa istom dozom. Zaista poštujte sve preporuke koje guidelines jasno predoče. I sada da vidimo, Rado, da li možete nešto da nam bliže kažete o HRT testiranju, kako se ono radi i kako da ga interpretiramo. Za nas je to još uvek malo nedovoljno jasno.
Pa prvo o nekim smernicama vremenskim, pošto je to jako bitno. Verujemo da će testiranje, ako bude sve u redu, krenuti u prvoj nedelji decembra, znači bliži se, pripremamo se. Ovde vidite vrstu testa za koji smo se opredelili. Prvi razlog je bio što Sofia DDM koristimo softver za analizu već godinama za naše tumorsko testiranje i familijarne smo s njima. Šta ovaj test pokriva? Pokrivaće, što sam malo pre spomenula, znači uzroke, pokriće se somatske i germinativne mutacije u BRCA i HRR genima. Znači, osim BRCA gena, bit će još 28 gena koji učestvuju u putu homologne rekombinacije popravke DNK. Ono što sad potpada već pod domen matematike i što moram sad napomenuti da je ovaj test koji ćemo raditi najkompleksiji NGE test koji ulazi u našu laboratoriju, znači u sve ostale, kombinuje deep learning algoritam low pass whole genome sekvenciranja, znači radi se o vrlo kompleksnom panelu, pri čemu je taj algoritam dobio svoje zaštićeno ime, odnosno odražava se na genomski integrity index koji predstavlja u stvari taj HRD score, kalkulacijom svih tih promena kako uzroka, mutacija, snipova, takođe metilacija, ostalih hromozomskih aberacija, sve da se preračuna u stvari taj skor deficijencije homologne rekombinacije. Sam, kao što smo spomenuli, znači za lekare, za patologe se ne menja, šalje se isti uzor tkiva, priprema se biblioteka, radi se sekundarna, tercijarna analiza. Ono što je bitno da će na rezultatu biti odvojene BRCA mutacije i HRD skor. Mi se nadamo da će ići relativno glatko, pošto jedan od najčešćih prepreka je upravo ta analiza rezultata, odnosno validacija, pošto se radi o testu koja je IVD i radi se o vremenskim okvirima, vrlo je bitno da to bude sve jasno i da lekaru bude jasno kad pogleda test i naravno koleginicama kada pogledaju samu interpretaciju varijanti. Kažem, test je nov, kreće se. Ono što može takođe da bude prepreka, imajući oblik kompleksnost testa i taj sekvenciranje celog genoma, doduše low pass, znači da ćemo moći manje pacijenata odjednom, ali to ćemo se dogovarati usput kako će ići grupe, ali imat ćemo i duže rokove. Kako će izgledati rezultat? Ovo je sample report samog testa. Bitno je, kao što vidite, da ima dve odvojene kategorije. Jedna je BRCA status, gde će pisati pozitivni i negativni, i genomic integrity status, koji će takođe biti pozitivni i negativni. U zavisnosti od testa, cut-off je definisan različito. Ovde je cut-off 0, znači sve pozitivno, bit će GI pozitivno, odnosno HRD pozitivno. Naravno, svaki test, ovo je sample report, mi ćemo ga prilagoditi našim potrebama, naravno ono što svaki put stavljamo procenat tumorskog tkiva, broj uzoraka koje je poslao, koji geni su uključeni, ali to će ličiti ta prva strana, dobijat ćete rezultat za BRCA i dobijat ćete rezultat za HRD. Kako tumačimo rezultat? To je sada nije komplikovano, ali treba znati. Znači, na primjer, ako imamo levo brka mutiran, on je naravno HRD pozitivan. Tu nema dileme. Takvih će biti 23%, to je ono što mi sada radimo. Kako dosežemo onih još 23% da povećamo tu grupu pacijentkinja koje će biti kandidati za terapiju, tako što gledamo kroz HRD skor, koji nam sada daje isto rezultat. Znači, HRD pozitivan može biti ako je brka pozitivan, ali takođe može biti ako je brka negativan, a HRD pozitivan. To je taj ostatak od 20 i nešto posto pacijentkinja koje povećavaju pul za dobijanje leka. Znači, biološki fenomen koji je iskorišćen na najbolji mogući način kao jedan sveobuhvatni biomarker koji će povećati grupu pacijentkinja za dobijanje leka. Sada moje pitanje za Marijanu. Marijana, dobijete brka pozitivne i dobijete HRD pozitivne. Ti pacijenti idu po istom režimu? Ajde, malo.
Da, to je jako važno pitanje i možda u stvari najvažnije. Znači, ono što je bitno, gde se mi nalazimo? Znači, vidite, s obzirom da je Paola više nego jasno pokazala da je medijana PFS-a gotovo 4 godine praktično kod svih HRD pozitivnih pacijentkinja i da 2 od 3 pacijentkinje su žive još nakon 5 godina, znači apsolutno imamo benefiti u pogledu ukupnog preživljavanja, jedan dosledan, prepoznatljiv sigurnosni profil. Naše je sada da mi kliničari testiramo sve pacijentkinje na HRD testiranje. Neće više biti posebno brka testiranje, posebno HRD testiranje. Testiranje kreće u decembru. To je prva promena. Drugo, ako vi sada dobijete da je pacijent brka pozitivan, s obzirom da smo dobili određene sada mogućnosti da po Pauli lečimo određeni mali broj pacijenata, one koje su brka pozitivne i dalje lečimo kao solo 1, one pacijentkinje koje su brka negativne, HRD pozitivne, zahvaljujući Astri, moći ćemo da lečimo kombinacijom bevacizumaba i olapariba u skladu sa Paola studijom. Ono što mi moramo da radimo već od početka decembra, da svi zajedno sa udruženjima pacijenata, nađemo načina, a naći ćemo da ubedimo fond da je svim našim pacijentkinjama s uznapredovalim karcinomom jajnika, koji je vrlo često u Srbiji sa velikim tumorskim opterećenjem, da zapravo sve pacijentkinje, i brka pozitivne, i HRD pozitivne, apsolutno idu na Paolu, odnosno da dobiju i BEV, i hemio, i PARP inhibitor. Zato što je to najbolja terapija za naše pacijentkinje. Do momenta dokle RFZO ne napiše to u službenom glasniku, mi moramo da se ponašamo kao do sada, odnosno da čekamo da nam Rada ipak kaže da li je pacijent HRD pozitivan ili brka pozitivan, a onda se odlučujemo isto kao do sada, Avastin ili ne, to moramo isto da radimo tako, ali ako nam Rada kaže da je HRD pozitivan pacijent, mi naravno odmah krećemo sa bevacizumabom, ništa ne čekamo i zaista biće komfornije za nas lekare, za naše pacijente, da te mukotrpne razgovore koji nekad ne budu baš jednostavni i laki za naše pacijente, pa ni za nas, nadamo se da više nećemo imati potrebe da ih radimo. Tako da, vrlo brzo imaćemo najbolju moguću terapiju za naše pacijentkinje i nadam se mnogo bolje ishode u daljem lečenju. Hvala. A sada ručak.
Sorry for this delay, but onda vi ostajete tu. Ko je sad prvi? Ko je sad prvi?
Hello, good afternoon. Dear friends, dear colleagues, thank you very much for your presence. It is an honor to announce our thyroid cancer masterclass that is possible only thanks to our great friends and important speakers on international level who accepted our kind invitation to join. Along with them, we have selected a few people who are experts in this field from Serbia, and I think that by doing that, we have provided a high-quality program for everyone who is doing thyroid cancer surgery in Serbia and region. It is a great honor to say that thanks to big support of European Society of Endocrine Surgery, this masterclass has gotten even more interest and more value. It is also endorsed by European Society of Surgical Oncology, So I think that this confirms how high quality program we have prepared for today. I would like to thank our colleagues from the endocrine surgery in the Clinical Center of Serbia and from Bežanijska Kosa and other hospitals who has joined us today, and I hope that even more of them will join later. Kyriakos, as the chief of the Education Training Committee of European Society of Endocrine Surgery, will continue to moderate the first part of the masterclass with Professor Žarković from Serbia, and I will also ask you to say a few words regarding this masterclass, please.
Dear colleagues, it is a great pleasure for me and the other members and the senior members of the European Society of Endocrine Surgeons to be here in the beautiful city of Belgrade. This is a very interesting masterclass on thyroid cancer. It is endorsed by the European Society of Endocrine Surgeons since a lot of senior members of the society are involved in the program. And I want to thank Ivan Markovic and Nada Sandrak for giving us the opportunity to be involved in this very, very interesting meeting. Thank you very much. We will start with my co-chair, Milos Žarković, with the first part of this thyroid cancer masterclass, the diagnostics and pathology of thyroid cancer. Do you want to introduce? Okay, we will start with Dr. Pablo Valderrabano from University Hospital of Madrid, with the evaluation and management of thyroid nodules, integrating imaging, cytology, and molecular markers.
Is this working? Yeah. Thank you. Thank you very much for your kind introduction. Thank you very much to Nada and the organizing committee for this kind of invitation. I'm going to start very quickly with a disclosure here. I've been site PI in a multicenter clinical validation study for ThyroidPrint, and both the institution and the research team received grant money, and also have received advisory fees from Biocartis, who's commercializing ThyroidPrint. I have one extra disclosure, and that's that I like to give good news to patients, but this is the kind of news that when you're dealing with indeterminate thyroid nodules makes me feel weird. Right, because you're supposedly giving a good news, and yet, when the outcome is benign, but then, you kind of think that surgery could have been avoided. And so it has that kind of mixed feelings, right? And thyroid surgery is not as it used to be 100 years ago, very cruel, bloody, and dangerous, but it still has its risks and complications. So what can we do to avoid these surgeries? And for that, I think the first thing we need to do is to understand what is that we're dealing with when we're treating patients with indeterminate thyroid nodules. I used to think when I was doing the fellowship that benign cytology identified benign nodules, malignant cytology identified cancer, and indeterminate cytology identified a mixture of benign and malignant nodules that the pathologist somehow was unable to differentiate. This is how I think about it right now. I think that indeterminate thyroid nodules really identify, or indeterminate cytology really identify a set of precursor pre-malignant lesions. In fact, the mutations that you find in malignant nodules and benign nodules in this with this indeterminate cytology bear the same mutations, and actually are the same mutations that nodules with benign cytology show. So it is no longer a fault of the pathologist that is not able to say whether this is or not cancer, but it's rather the work of the clinician to identify whether this particular nodule that the patient in front of you has is in the benign end of the spectrum or the malignant end of the spectrum, so that you can decide whether that's worth taking out or you can just observe. So how can we do that? Why is it important to spend time in really looking at all the details of that nodule that you're dealing with? First of all, it's very important to understand that the need for immediate surgery that is going, to treat an aggressive cancer that's going to end the life of the patient has been calculated or estimated to be the same of dying by choking on food. I'm pretty sure you all had breakfast without any anxiety this morning. So this is the first message that you need to really think about when you're dealing with a patient with an indeterminate cytology. You have time on your side. This is not something that you need to address right away. But then, if you're going to stratify the risk of malignancy, how can you do that? First, you need to understand what's the current diagnostic approach to see where there is room for improvement. And currently, we have a linear approach to the evaluation of thyroid nodules. We do an ultrasound, decide which nodules meet criteria for biopsy, and decide basically management on whether we have a benign cytology or a malignant cytology. And then we have these indeterminate thyroid nodules that are a little uncomfortable. And for this, we have seen the development of several molecular tests in recent years that try to help us make this decision on whether the nodule needs to be resected or not. For these molecular tests to be helpful, ideally, they should achieve a very high negative predictive value, over 95%, so that is similar to that of a benign cytology, and so that we accept that our observation is reasonable in lieu of surgery, and a very high positive predictive value, so that we minimize the number of diagnostic surgeries on benign nodules. Fortunately, we have several tests with prospective multicenter blinded studies that have already achieved these figures. And actually, these are the diagrams that the companies use to commercialize these tests. And now these can be a little misleading because they're plotting here the negative predictive value and the positive predictive value of the test. And I'm not going to get into many details with the statistics, but this is really key to understand how we can stratify the risk of malignancy of indeterminate thyroid nodules, because the negative and the positive predictive value are not inherent to the test, but rather dependent on the sensitivity, the specificity, and very importantly, the underlying prevalence of malignancy. And these curves got popularized with molecular testing to understand this concept. In red, you have the negative predictive value, in blue, the positive predictive value, and in green is the benign call rate, which is the number or the proportion of nodules called benign by the test. And in the x-axis, you have the underlying prevalence of malignancy that you're testing. And you can see how, as the prevalence of malignancy increases, so does the positive predictive value at a cost of the negative predictive value and the benign call rate. And this has obviously implications for the interpretation of the results, but also to see whether it is useful in your situation. And more importantly, this can be applied to any diagnostic test. This is not just happening for molecular testing, but to any diagnostic test. So when I started to get interested in stratifying the risk of malignancy of thyroid nodules some 10 years ago, we decided to look first at applying this concept to the thyroid ultrasound, because the ATA guidelines had just been published. They showed this classification system for thyroid nodules, 5 different categories with very different estimated risk of malignancy for each one of these. So we said, well, if you have an indeterminate thyroid nodule, which is the diagnostic test, that cytology, and you have this underlying prevalence of malignancy, which is the sonographic pattern that is clearly different, could we apply that to the interpretation of that indeterminate cytology? And so we did this study in which we looked at the sonographic pattern of around 400 nodules with indeterminate cytology, either Bethesda 3 or 4. And of course, we found a difference in the prevalence of malignancy depending on the sonographic pattern. So those that had high risk suspicion pattern had around 55% risk of cancer, whereas those with lower intermediate risk of malignancy had around 20%. And not only that, but we could also see differences in the types of cancers that we find with each of those patterns. So the sonographic pattern of the nodule is giving a lot of information that we're not using as much as we should. Now, should this translate into the application or the interpretation of molecular testing, because now we have another test that is adding information to the performance of the molecular testing. And of course, it does, right? If we plot here the Afirma GSC and the ThyroSeq version 3, which are the most extended tests in the United States, and we see the 20% and the 55% prevalence of malignancy that we were mentioning for low and high risk sonographic pattern, we can see how the negative predictive value drops, so does the benign cold rate, and increases the positive predictive value. And this has been shown in a paper, recent paper, looking at the performance of both tests, Afirma and ThyroSeq, according to the sonographic pattern. And you can see how the risk of malignancy, the pre-test risk of malignancy of high suspicion nodules is almost unchanged by the test result. Furthermore, almost none of those nodules had a benign result. So probably we should not be using molecular testing in highly suspicious nodules. In low and intermediate risk nodules, this molecular testing seems to have a role in helping us decide whether the risk is lower or higher. Now next we moved on cytology, because I like to compare these indeterminate thyroid nodules with a salad. Everybody knows what a salad is, right? But if you go to a restaurant, 3 different restaurants, you get 3 different salads. So you need to know what's the salad that you have in your institution, right? Because there is a great heterogeneity in this group, and you need to really go and look at the details to know whether the piece that you've picked with your fork is a tomato or an onion. And so you need to go and look at the details. In this group, you may have a nuclear atypia that resembles that of papillary thyroid cancer, that is focal or mild. You can have microfollicles or overlapping cells, which is suspicious for a follicular neoplasm. In fact, if you see this in a very cellular specimen, this will be a Bethesda 4, otherwise will be a Bethesda 3. You can have oncocytic cells. And in Bethesda 3, on top of these 3 scenarios, which are shared by Bethesda 3 and 4 nodules, you may have many other things, because by definition in Bethesda 3, you can fit anything that the pathologist does not feel comfortable fitting into any other category. For example, these are atypical epithelial cells in a cystic aspirate. So all these aspirates look very different. Do we really need to act the same no matter what the details are? This is, to me, sounded very weird, so we decided to look into this as well. And obviously, we are able to stratify the risk of malignancy depending on this. We found that patients or nodules with nuclear atypia in the aspirates had about 50%, almost 45% risk of cancer, which was much higher than for nodules with architectural atypia. We further validated this into posterior meta-analysis, and this is something that we need to be looking at. And not only that, but again, we are able to really select or find differences in the types of cancer that we identify in each of these cytological scenarios. So again, going back and reading the details of the pathologist's report is key to understand what is that you're dealing with, what are your chances of having cancer there. And again, we said, well, if this stratifies the risk of cancer, can we really stratify the risk or the interpretation of the molecular testing? And of course we can. If you plot here again Afirma GEC, which is the previous version of the test, and GSC, you can see how the expected positive and negative predictive values change. And this has been shown in publications with both tests. You can see how, I don't know if this works, yeah. But you can see how the benign cold rate in nodules with architectural atypia is much higher in both tests, and also how the risk of cancer increases in those with nuclear atypia. The last thing I want to comment about this is about the utility of molecular testing, right? Because Bethesda 3, the traditional recommendation was repeat FNA. Now, since 2015, all the guidelines say, well, repeat FNA or do molecular testing, but which is best, right? Because not all the countries have available molecular testing, plus it's very expensive. Should we be fighting for this or not? And what we can see in this randomized clinical trial is that molecular testing allows avoiding surgery in almost 50% of the patients. But what does repeating FNA add to this? And we did a meta-analysis and we found that repeating FNA in a Bethesda 3 reclassifies as benign 50% of the nodules, which have a very high negative predictive value indeed, and reclassifies another 15% into more definitive categories, Bethesda 4, 5, or 6. So in my opinion, repeating the biopsy should still be the first line choice for Bethesda 3 instead of molecular testing. This is how I envision now the algorithm for the management of thyroid nodules. We have still a stepwise approach, but in which we collect all the information that we get from each of those tests to individualize the risk of malignancy and be able to personalize management. And this is a specific algorithm that we've proposed for the management of Bethesda 3 and 4 nodules. We would first consider checking serum calcitonin, particularly if there is oncocytic changes, to be sure that you're not missing that case of medullary thyroid cancer that may go undiagnosed by cytology. And then you evaluate whether there are any circumstances that make surgical necessary. For example, very large nodules, compressive symptoms, etc. If that is the case, you don't need to do anything else. The patient is going to go to the OR, take it out. If not, then you need to look at the sonographic pattern, because if it's a benign-looking nodule, that nodule should have not been biopsied to begin with. So you probably can just do nothing and observe. If you have a TRADS 3 or 4, and architectural atypia, we're probably talking about the low end of the spectrum here, probably around 10%. And my preference in these cases, if it's not a large nodule and not having any other criteria for surgery, would be to observe these nodules, really. If we have a TIRADS 3 or 4 with nuclear atypia or oncocytic changes, or a TIRADS 5 with architectural atypia, we're probably dealing here with a 25% risk of malignancy. For Bethesda 3, we would recommend repeating the biopsy. For Bethesda 4, using molecular testing if available. If not, probably diagnostic surgery. For TIRADS 5 with nuclear atypia or oncocytic changes, we're probably dealing here with something that has over 50% risk of cancer. We would still repeat the biopsy in Bethesda 3 and probably go straight to do diagnostic surgery in Bethesda 4 because molecular testing in this setting isn't likely to be very useful. And with that, I would end the presentation, and I think questions are at the end?
Yes.
Perfect.
Thank you very much.
Thank you.
Questions from the panelists and the audience at the end of both lectures?
Thank you. Now I have a great pleasure to announce the Professor Svetislav Tatić, our pathologist from University of Belgrade School of Medicine, and he will talk about aggressive histological variants of thyroid cancer and the implication in clinical practice. Professor Tatić, please.
Dr. Žarković, thank you very much for the introduction. Colleagues, good afternoon. I wish to thank the organizers, especially Professor Marković and Dr. Santrac, for their kind invitation for me to participate in this Congress. And I'm really honored to be with you today, talking as a topic about more aggressive histological variants of thyroid cancer. As Professor Žarković said, I'm a pathologist in Institute of Pathology, Medical Faculty, University of Belgrade. In reality, dealing in daily practice with thyroid glands. Yeah, it's okay. I'll start with WHO classification, the 5th edition of WHO classification of thyroid neoplasms, accentuating some details in malignant neoplasms, in the category of malignant neoplasms, because there are some subtle and non-subtle changes. Papillary microcarcinoma is not present more in this classification, and pure squamous cell carcinoma is not present still. It will be anaplastic in biological behavior. And in this group, follicular-derived carcinoma, high-grade carcinoma, we have traditionally well-known, poorly differentiated thyroid carcinoma, but the new one entity, I'll talk about a little bit detail later, is differentiated high-grade thyroid carcinoma. We must begin with papillary thyroid carcinoma because it is the most frequent malignancy in this gland, with good prognosis after total thyroidectomy and lymphadenectomy if needed. And this is a classical histotype as a paradigm for all histotypes of papillary thyroid carcinomas, having papillae with fibrovascular core lined with cells which have typically hypochromic ground glass, orphan N nuclei, and so on and so on. Having excellent prognosis, we may say. But among numerous histotypes, in this picture left, we have trabecular, and on right, solid type of PTC, which may have not so good prognosis. And also in some instances, diffuse sclerosing type, sometimes with unilateral or bilateral involvement of thyroid gland, with lymphatic permeation, with squamous metaplasia foci inside, and even with sonoma bodies typically. These are so-so prognosis, and sometimes aggressive behavior. And finally, group of really, we can have aggressive histological variants. These are columnar, tall cell, and hobnail. What is interesting in this picture? Here is the picture or figure of pseudostratification nuclei inside the columnar cell histotype, which sometimes paradoxical or not paradoxical immunohistochemistry with expression of CDX2 as marker typical for the digestive system, but it is not so peculiar because endodermal origin of the thyroid gland. So markers typical for thyroid carcinoma, but also some other in up to 50% of cases. Then the hobnail variant upstairs with papillae in this picture, but with cells with abundant cytoplasm and nuclei bulging from the surface, having some apical snouts, something similar to apocrine breast carcinoma or some ovarian type of hobnail carcinoma. And downstairs is tall cell histotype as the criterion. That means the height of these cells, tumor cells, is 3 times the width, at least. Some types, such as papillary carcinoma with desmoid type stroma, a new defined clear cell type and spindle cell type, are practically in small series, and the prognosis is still not well defined. But maybe it may behave aggressively. I wanted to emphasize oncocytic thyroid carcinoma because in this classification from 2022, WHO classification, it is a distinct entity with, in reality, more aggressive behavior than follicular thyroid carcinoma. Upstairs, we have a node with capsular invasion like Vulcano, and on the left, vascular invasion. We know for tendency for hematogenous dissemination, and have in mind that some patients have bone metastasis 15 years, 20 years after total thyroidectomy. And downstairs, the typical picture of oncocytes. In reality, we talked previously Hirtle cell, but it is misnomer because Hirtle described C cell, not this oxyphilic transformation of thyrocyte. So the abundant cytoplasm, eosinophilic granular, is the result of accumulation of dysfunctional mitochondria. And it's okay for diagnosis. It is not difficult for pathologists to diagnose it. The problem is decreased uptake of radioactive iodine in these patients, so it is not so good for therapy. And finally, on this scheme, we talk about, look at left, papillary, follicular, and oxyphilic, or oncocytic, it's better to say thyroid carcinoma. They are typically with low mitotic activity, practically without mitosis on the preparation and without tumor necrosis. They have low mitotic activity, and in daily practice, we very rarely do immunohistochemistry with Ki-67. It's very low. Excellent prognosis for papillary thyroid in some histotypes, and decreasing in this excellence with follicular and oncocytic one. We know that purely differentiated thyroid carcinoma typically synonym insular because it is the most frequent situation. I will show the figure later. They have great number of mitosis and tumor necrosis typically, going to intermediate prognosis, and high-grade differentiated thyroid carcinoma. That means if we see papillary, follicular, or oncocytic thyroid carcinoma with the mitosis which are great in number and some areas of necrosis, we must put the diagnosis or have in mind that it will be high-grade in its behavior. Of course, we know that anaplastic or undifferentiated is with dismal or often horror prognosis. This is a typical picture of insular carcinoma, having these ovoid islands with tumor cells having convoluted dark nuclei, sometimes a description as raisin-like. And here we see area of necrosis on the right side, so typical purely differentiated. What is interesting, purely differentiated are typically with RAS mutation, whereas high-grade differentiated thyroid carcinomas are with BRAF or BRAF mutation often. And this is a picture where we can say that see papillae lined with cells with hypochromic nuclei. We may say, yes, it is papillary thyroid carcinoma. Even upstairs, some tall cell component maybe, but on the left, we see great area of necrosis. It will be high-grade differentiated, papillary, but high-grade differentiated thyroid carcinoma, and I'll tell that they are practically, in some of thyroid carcinomas, relatively rare, creating 1 to 7% of all thyroid carcinomas. More often in Europe and South America, patients over age of 50, slight female preponderance, large at operation, 4 centimeter and more, macroscopically visible areas of hemorrhage and necrosis. In many instances, extrathyroidal involvement, extrathyroidal spreading to soft tissues of the neck and lymph nodes, even perineural invasion, and sometimes distant metastasis. The problem is, again, decreased or up to 50% of these high-grade differentiated without radioiodine uptake or with insufficient. So when you talk about immunohistochemistry, they still retain properties for thyroglobulin, TTF, PAX8, and what is interesting here, if we do immunohistochemistry with Ki67, it will be about 10 to 30%. That means very, very active proliferative index. And according to strict criteria, we see that poorly differentiated as minimum for diagnosis has mitotic count equal or more than 3 per 2 square millimeters. Previously, we talked about high power field. It is the most precise, 2 square millimeters, tumor necrosis, and typical convoluted nuclei in cells. And the minimum requirement for high-grade differentiated thyroid carcinoma is mitotic count equal or more than 5 per 2 square millimeters, and areas of tumor necrosis. What I've mentioned that pure squamous cell is expelled from new classification. The biological behavior of squamous cell carcinoma is very bad, practically equal to undifferentiated or anaplastic carcinoma, and that is the reason that we may say in this picture upstairs that it is anaplastic carcinoma, anaplastic thyroid carcinoma with squamous cell differentiation in this picture, and behavior is horror or very, very bad. But have in mind as a therapy, as a possible therapy for candidates with BRAF positivity in this tumor, practically all patients with anaplastic carcinoma ought to be tested to BRAF because BRAF mutated may have BRAF and MEK combination of inhibitors as a possibility. Downstairs, we see sarcomatoid anaplastic thyroid carcinoma, something closely to sarcomas, spindle cells, fusiform cells. And what is interesting, many of these details we know, But talking about carcinomas entirely generally, we have two global different directions of this multi-step process of transformation and dedifferentiation. Talking about papillary, characteristic BRAF V600E, but not only this one, because it said like. That means ALK fusions, RET, MET, NTERK, RK, and so on, are also in this group as early driver changes. Among follicular thyroid and generally carcinomas with follicular pattern, we have, when we talk about RAS-like, implying not only KNH RAS mutations, but also some other, even DICER1 or PTEN, or even BRAF, but K601E. Late event changes or secondary changes are, of course, numerous or expectedly numerous, but TP53 mutation and especially TERT promoter mutations are, I may say, dangerous. Why? Because look at this. Practically all differentiated and all high-grade differentiated thyroid carcinomas have as a secondary change this hotspot mutation in promoter sequence denoted as C228T and C250T in promoter, TERT promoter, and of course some other are practically revealed in these other types. But it is very, very characteristic TERT promoter mutation for these purely differentiated and high-grade differentiated carcinomas. Immunohistochemistry can help in identification of different molecular aberrancies having therapeutic and prognostic significance in this region of pathology, in this area of pathology. Look at this. A figure is not so well seen, but BRAF positivity in tall cell thyroid carcinoma, or in B figure, we see pan-RAS positivity of immunohistochemistry in follicular carcinoma. Then on C is NTRK, and on D, ALK positivity. And on E picture, it is global loss of PTN. Finally, briefly about C-cell carcinoma, medullary thyroid carcinoma, I want to emphasize because Gradin's heme for this type of carcinoma was introduced 2 years before. So in new 5th edition of WHO classification, having the same parameters, similar parameters, tumor necrosis, mitotic count more than 5, and Ki67 proliferation index equal or more than 5%. And what is interesting, high-grade tumors have at least only one of these three features. So in this picture on the left side, A figure is area of necrosis inside the medullary thyroid carcinoma. What is interesting, there is no amyloid. That means it is worse in differentiation, even it is without amyloid material. Then on B, we can see two mitotic figures. It's too much for one field of this magnification. And on C, this Ki67 is estimated about 35%. That's high number. And some kind of take-home message or accentuation, talking about papillary as the mutation of BRAF we've mentioned, or RET PTC rearrangements which exclude each other. Anaplastic, I've mentioned BRAF mutation, and the group of follicular thyroid carcinomas with follicular, even follicular adenoma, thyroid carcinomas with follicular pattern of growth, we expect as the most frequent RAS mutations. Thank you.
Yes, thank you, Professor Tatic. It was a great lecture. Now, I think we have a discussion. So, any questions for the audience? Well, may I ask you a question? Can you compare your algorithm, your flowchart, with the flowchart for thyroid nodules guidelines in ETA for 2023? They're quite similar, but there's some, I believe, some differences between those approaches.
So I have,
It works. So I've not been able to see yet the 2023 guidelines, or
2023.
But do you mean the Bethesda, or what? I'm so sorry. You refer to the ETA guidelines are expected to come out
No,
next
ETA,
year?
European Thyroid Association.
ETA. All right.
2020.
ETA. Yes. In fact, yeah, the ETA guidelines, I think, align better with this approach than the ATA guidelines. I don't think they take all this granularity regarding ultrasound and cytological scenario and merge them together to provide expected risk of malignancy. And I'm not sure they are so specific about preferences in terms of what comes first in all these different scenarios. But I think we'll be going there. We're trying to provide more individualized management. It's an approach that it's going slowly, I think, but it makes sense. So I think we'll end up going there. Yeah, definitely.
Thank you very much.
Do you have any comments and questions from our panelists? Joaquin?
Pablo, in your fantastic algorithm, you don't have into account the age of the patient. Don't you think could be important also?
Sure. I mean, you cannot fit everything into the algorithm, but sure, age is a factor that you need to take into account when you're dealing with a patient. It's probably not the same management you're going to offer to a 3-centimeter nodule and 85-year-old lady than a 35-year-old woman. Obviously, the younger, the more likely I'm going to be to take that patient to the OR because there is a lifetime for the nodule to grow even slowly. Whereas, age and comorbidities will set me back on doing anything. Obviously, these we need to keep into, we need to have present that these tumors are usually benign. When not, they're usually low-risk neoplasms, and therefore probably there is not much harm into waiting unless there are some other pressing circumstances that prompt us to do surgery.
Hello, is it working? I wanted to ask you, have you had the opportunity to see the NICE guideline that was done by the NHS? If you haven't, I want to explain you what they're talking about. We are talking now about the possibility to distinguish benign lesions from malignant lesions. The NICE study that was performed by NHS looked at the cost effectiveness of these studies, and it's generally in line with your finding that in all cases apart from Bethesda 4, it is cheaper to actually do a hemithyroidectomy, a diagnostic hemithyroidectomy, than actually perform any of the gene sequencing tests like Afirma or Thyroid 3, version 3. So I don't know what are your experience with this. Did you consider the cost effectiveness? I think that the genetic testing is a really good thing, and it is the thing of the future, but at the moment it is very expensive, and it costs maybe in America around $10,000–$15,000, the Afirma test, whereas the lobectomy costs around $20,000–$25,000. So at the moment it is cheaper, but in the end it comes to what will be refurbished by the government. And in that sense, what do you think? Is there a possibility, since you are closely now cooperating with the people who are doing these tests, is there any possibility for the price of these testings to actually be reduced to maybe reduce the amount of markers that are looked for, that maybe be more precise and in a sense get a cheaper test that will be able to be applied more frequently?
Sure. So the question about cost effectiveness, as you're referring, is a delicate question that needs to be addressed specifically in each country probably, and maybe more local setting, because it depends on how much the molecular testing cost, how much operating the patient cost, whether that's covered by the government, whether it's the patient paying for it. In the United States, the more you do, the better for the hospitals because they get a chunk of everything they do. So it just makes sense to do more things. In countries where there is public coverage of the health problems, the healthcare, you need to take into consideration how much that is and how much benefit it's going to take. Right now, we only have available, it started to be commercialized earlier this year, but we only have commercialized thyroid print, which is being now, has been mounted into, to be supported by the IDELA platforms, which are in every institution. So the test can be run within the institution. You do not have to ship the samples. It's still expensive. I think it's about 1,500 euros that they are charging for that. But that is cheaper than hemithyroidectomy in our country. Now, I don't know if they'll change the price for each country and depending on what's the price of things, but what it's key is selecting which patients are going to benefit. So it's very important to first make sure that the patient does not have other surgical indications, to make sure that the physician and the patient are happy to follow that nodule if the result is benign, to make sure there are no high-risk features. And then those patients, probably 2 out of 3 may have a benign result. So if you count, for our institution, we did the count, and it could help avoid about or save about 40,000 euros a year if we were using it right. But that is our own calculation for our institution, and we're fighting to get that purchased by our hospitals when they start using it. The other thing is about the price. Obviously, the more chances that we have, or the more options that we have, probably is going to lower the costs. There is still this situation that's common to most tests, that is that you need to ship the samples to a central lab, which is a little complicated in terms of logistics, particularly if it's different nations. That complicates things a little bit. But I'm sure the cost will go down as all the new technology keeps developed. So sure, we will be using it. I still don't think it's something we need to do in every patient. Finding the mutation is probably going to be uninformative in most cases, because you're going to find a RAS or RAS-like mutation in most indeterminate thyroid nodules. And those nodules are going to be low-risk follicular neoplasms anyway, most of the time. So not going to change the approach much.
Okay.
Okay.
Professor Markovic.
Thank you. My question for surgeons is how after the operation information of high aggressive tumor that we have operated, probably with hemithyroidectomy for small tumors, how this information will affect on your decision when you speak with the patient? What do you plan to do, something more, the more extensive operation or so? Because as I understand, we get this information later from our pathologist.
Yes, well, concerning the aggressive forms of papillary cancer, I think there are 3 aspects we need to think about. Is the preoperative scenario, where we'll try to evaluate the patient with the fine needle aspiration biopsy, and we know that there are many pitfalls in the cytology of aggressive forms, especially with some forms which are close to Hashimoto and that. So anyway, we very rarely actually preoperatively know that we are dealing with aggressive type. But then again, we have to look at the clinical signs that we can see preoperatively. Usually these tumors present as large bulk mass tumors in the neck with lymphadenopathy. They're usually firm and they're usually not mobile, because they are, in all of them, you have a presence of extrathyroid extension. So in that sense, we can maybe suspect that we are dealing with a very aggressive form of thyroid cancer preoperatively. Of course, intraoperatively, we will verify our preoperative findings in the way that we'll see if is there extrathyroid extension, is there a lymphadenopathy, is it a big tumor, does it infiltrate the surrounding tissues? But in the end, it comes down to the pathology in the end, but that's most of the cases where we actually get the diagnosis in the end. And I think that with these tumors, since some of them show less radioiodine avidity than some other papillary thyroid tumors, I think we should try and be as aggressive as possible. Absolutely, I think the main course of action for treatment of these patients with aggressive tumors is to do a radical dissection, total thyroidectomy, dissection of the lymph nodes if they are involved, of course, and whatever is possible to remove the bulk of the disease, since sometimes the radioiodine therapy won't be possible, won't give any effect. And in patients where we cannot resect the disease completely, I think that we should consider radiotherapy as well afterwards if it's not possible to resect the tumor. Do you agree?
Yeah, completely agree. And it's important to explain the patient what is going to happen, because sometimes surgeons who treat patients with papillary thyroid cancer sometimes before to have the diagnosis, we tell the patient, okay, doesn't matter, it's a small, low-risk tumor, but if not, well, you have to explain the patient and to explain what is going to happen, and iodine, more surgeries, whatever.
A question for Professor Tatic. Based on your experience, which is the most aggressive subtype of papillary thyroid cancer? In case that we have, after lobectomy, such an aggressive subtype, we should make a completion thyroidectomy or even a lymphadenectomy. The most aggressive.
I'd say tall cell. I'd say tall cell in our series. And I want something I have thinking about mitosis and necrosis as a criteria for high grade. I'll emphasize mitotic count, because if you have great tumor, more than 5 centimeters at operation, it will logically have areas of necrosis inside, many tumors. So I think that this criteria, having the numerous area dispersed inside the tumor and not the central area of coagulative necrosis in some instances of bulky tumors, you know. So mitosis, I think it's the crucial.
Thank you very much.
The number of mitosis, Ki67, and so on and so on.
Could I just add, I think we shouldn't forget the columnar cell variant.
Yes.
It is even more aggressive when it's not encapsulated. When it's encapsulated, it has prognosis as ordinary papillary thyroid cancer, but if it's not encapsulated, which is quite frequent the case, it is very, very aggressive. On our series, in the last 10 years of these aggressive forms, we had 2 columnar cell, and 50% died, okay? So, I mean, of course, it's a small series, but, I mean, it's a very rare tumor, but it can be very, very aggressive and deadly.
And for us, the percentage of, in a papillary thyroid cancer of tall cell, 30% to consider advanced, or?
Yes.
30%?
About 30%. Okay. Yes.
But there are some studies that suggest even smaller percent, that if any, Lavisto said that if 10% is present, we should already think about the aggressive form, but generally it is 30% is the consensus at the moment.
We encountering a lot of times problems with hobnails, and we have to reoperate the patients. Is that so aggressive?
Yes, it is.
Okay.
I think more than in ovarian, in some comparison, you know. And I haven't mentioned, maybe very rare, but we had one, not in our institution, but also in Belgrade, secretory carcinoma, mammary analog of thyroid carcinoma, which was very aggressive. I have in mind it was last year, but it's rarity, practically in the one case.
Okay. So I believe we can close.
Yes, please. Okay. So we can close this session, and now we continue to the next session, and there are new moderators. Please.
Okay. Professor Koutelidakis and Markovits, please.
let's go on with a very important masterclass. And first of all, I want to thank Professor Markovic and Dr. Sandrak for calling us to participate and get involved in this very important program. And thank you very much once again. Let's go with the part 2. Let's talk about differentiated thyroid cancer and its approach in every way. And first of all, let's start with surgeons. And I call, is already on the podium, Joaquin, who is a professor of surgery in the University of Madrid, who is the most capable person to talk us about surgery of differentiated thyroid cancer. Please.
Thank you very much. It's a great honor to be here. Thank you, Nada. Thank you to all the organizing committee for inviting me. Thank you, Nicola, for your hospitality. And I'm going to talk about when should we be less aggressive in thyroid carcinoma. And you know, personalized surgery is trend in the current medicine, and of course, thyroid cancer happens in the same way. For this, I think it is quite important and quite useful to try to classify patients into 3 groups you consider. And of course, we are not going to talk about aggressive tumors, more than 4 centimeters. We all are agree because that this tumor should be managed in an aggressive form, thyroidectomy, no dissection, etc. And we are going to focus in these 2 groups. You know that these 2 groups have in common that there are low-risk tumors. And you know, there are a lot of classification of what is a low-risk tumor. This is one of the most famous, the ATA. You know, these are tumors without invasion of tissue or structures, not aggressive histology, no vascular invasions, intrathyroidal, and no distant metastasis, etc. And if we focus in this subtype of low-risk patient of less than 1 centimeter, is where the option of not even operating this patient has arisen. And regarding the management of this patient, we usually find 2 different scenarios. One is that after surgery, usually for another reason, we find a papillary microcarcinoma in the resection specimen. And another different scenario is when we have a preoperative diagnosis of cancer. And if we talk about this incidental diagnosis after surgery, it is widely accepted in all guides and protocols that thyroid lobectomy alone is enough treatment for this small unifocal intrathyroidal carcinomas in the absence of prior head and neck radiation and other risk factors, of course. And that is because it has been shown that there are no difference in terms of survival in these patients between total thyroidectomy and lobectomy. And although, as always in medicine, there are isolated cases with extrathyroidal lymph node involvement, which it may be necessary to complete the thyroidectomy, but not as a general rule. So the first message I can summarize is that for incidental microcarcinoma, lobectomy is enough for the majority of patients, of course. And if we talk about the preoperative diagnosis, you know that it's more and more frequent that we have in the clinic patients with less than 1 centimeter diagnosis of papillary thyroid carcinoma. You know that it began 25, 30 years ago in Japan that 2 surgeons began to treat these patients in a conservative way with an active surveillance. And they have published a lot of papers with their amazing results. Probably one of the most important paper on to understand what they want to tell us is this table and these figures. And as you can see there, patients diagnosed at the age of 70s or 60s, the probability to have a tumor enlargement, or any problem with nodal metastasis or disease progression is less than 3%. And this is not the same for younger patients, but we can think that we are operating in an unnecessary way, and the vast majority of older patients with papillary microcarcinoma. And they also stratify these patients in the ideal, appropriate, or inappropriate patients to active surveillance. And probably the group, most of us, and we can discuss later, we agree with them, are patients with a solitary thyroid nodule, older patients with comorbidities, well-defined thyroid nodule with an experienced multidisciplinary team, with an experienced radiologist, endocrinologist, and probably these patients is going to be the best situation to manage in a non-operative way, if not have any progression, of course. And if we talk about probably the most large group we have to deal in the clinic, that are patients with low-risk tumors between 1 and 4 centimeters, you know, the evidence, as in general in thyroid cancer, is not much, but there are some articles I want to show you. And this is the first, it's a meta-analysis published less than 3 years ago, in which they include 13 studies. And they compare recurrence and survival. And they divide the patients into 3 groups, according to the size of the tumor, and see how they are the difference in terms of mortality of patients treated by lobectomy or total thyroidectomy. There are no difference between total thyroidectomy and lobectomy in tumor less than 2 centimeters, and there is a slight difference in favor of total thyroidectomy in tumors between 2 and 4 centimeters. Of course, there is a high recurrence in patients in all groups, but if you read the article, read the paper, or read the studies, most recurrence occur in the contralateral lobe. So if after exclusion of this lobe, after of the cause of the recurrence, the recurrence rate was similar between groups. So they conclude that there are no difference in recurrence between lobectomy and total thyroidectomy in patients with tumors less than 4 centimeters, and a slight higher mortality in lobectomy in tumor between 2 and 14 centimeters treated by lobectomy. This is very similar. This is another systematic review, also published, with included 8 articles, studies that are some heterogeneous, and as occurs in most thyroid cancer series, as you know. And they conclude that there are no difference in recurrence of survivals, and the need to complete thyroidectomy is about 30% of the cases. And this is the last article that I wanted to comment. This is a meta-analysis published in BGA that includes 10 studies. Again, compares recurrence and survival between groups of patients treated with by lobectomy or total thyroidectomy, less than 4 centimeters, low-risk patients. And they conclude that there are no difference between one strategy or another. And so it is being picked up by the most current guidelines. And most of them even suggest lobectomy for, as I have told you, patients, of course, less than 1 centimeter, of course, less than 2 centimeters, and individual, tailor the decision in patients between 2 and 4 centimeters with no node metastasis or less than 3 or less than 5 with a small metastasis, classic histological variants, and all you can see there. And even they propose a follow-up. You know, one important thing of total thyroidectomy is that you can use the thyroglobulin and the TSH, but even with a lobectomy, they propose the follow-up. But the thing is, you know, that the majority of recurrence are going to happen, if happened, in the thyroid bed, and you are going to be able to detect by an ultrasound, and probably is the most important tool we have in this patient is to have a good ultrasound. And because one thing we have to be clear, and is that the main reason for performing a total thyroidectomy in these patients is to be able to give iodine. And for years, it seems that low-risk tumor, it has been not necessary, but this important article of last year, you know, and confirms that there are no difference in patients in low-risk patients treated by with iodine or not. So they conclude with a high level of evidence that the treatment with iodine is not necessary in low-risk tumor, so total thyroidectomy could be not necessary. And it is extended in most guidelines and consensus, such as this one recently published by Laura Boccai in JAMA, that they indicate lobectomy the first option for patients with less than 4 centimeter low-risk tumor. So my conclusion, my message are that lobectomy is enough for low-risk patients less than 1 centimeter. Lobectomy seems to be enough in low-risk patients less than 2 centimeters, and of course, high-risk tumors should be managed in an aggressive way. Thank you very much.
Thank you, Hakim. I'll now ask Professor Milo Žarković, Professor of Endocrinology from Faculty of Medicine, the University of Belgrade, to talk about optimization of the follow-up of differentiated thyroid cancer.
Thank you very much for inviting me here, and now I will talk from viewpoint of endocrinologist. Okay. Now, what are the most important things when you want to follow up someone? Actually, follow up differential thyroid cancer patient. But first of all, and the most important, to enlist help our patient and the family. And to do it, you need to inform patient what's follow-up and how it's done. Then what's thyroglobulin, how it's measured and why. Then we need to inform patient of two nasty things. One is lifelong thyroid hormone replacement and lifelong monitoring of thyroid function. Another thing is to inform him when to seek advice from a healthcare professional and who to contact. On the other thing, what are we supposed to do? Well, for DTC follow-up, there are two things. One is laboratory, another is imaging. And in laboratory, we usually measure thyroglobulin and thyroglobulin antibodies. So thyroglobulin, it's a nasty little substance actually. It's actually thyroglobulins. It's large, it's heterogeneous, it's iodinated glycoprotein. And then we have antibodies, and different assays use different antibodies. So different assays will give you different concentrations. Now, there is recent certified reference material, BCR457, and that reduced intermittent variability from 60 to 30%, but 30% is still high. So we should stick to the same lab and to the same method. Now, is it good? Well, thyroglobulin is actually very good. negative predictive value is almost 100%. Positive predictive value is not so good. That's diagnostic performance. For prognostic performance, it's the same. Negative predictive value is fantastic. Positive predictive value is not good. So when thyroglobulin is negative, that's very good. When thyroglobulin is positive, that might and might not be bad. Now, the other thing is thyroglobulin antibodies. Well, thyroglobulin antibodies can be a friend and an enemy. The problem is, whatever you use to measure thyroglobulin antibodies, whether it's immunometric, whether it's mass, there are two different types of mass detection, where you use they will always change the concentration. And what's important, the higher thyroglobulin antibodies, the lower thyroglobulin. And that is because when you have thyroglobulin antibodies, there is quite quick, quite fast removal of thyroglobulin antibodies complexes from the systems, probably due to FcNR receptors. So you see, this is thyroglobulin concentration after radioiodine treatment with Graves' disease. And you see, when you have high thyroglobulin antibodies, the clearance is faster. So even when you change NACI, even you use MS, and MS is a bit of a problem because sometimes you can use an MS and do not detect any thyroglobulin. So yes, thyroglobulin in presence of thyroglobulin antibody. So thyroglobulin is a bit different to detect. Now, what about thyroglobulin antibodies? If you look at thyroglobulin positivity and risk of cancer persistence and recurrence in this large meta-analysis, you see that the thyroglobulin antibodies are quite good predictor. But even better situation is when you look at the trend. And when you look at the trend, odds ratio for increasing trend in 9.90, that's very, very big. And if you look at the trend and risk of cancer mortality, it's 15. So if you have increasing thyroglobulin antibody, that is a concentration, that is a bad sign. So we have three possibilities: decreasing, stable, and of course de novo. So if you have decreasing thyroglobulin antibodies, it's a good sign, especially have high drop, more than 50%. If you stable or rising thyroglobulin antibodies concentration, well, that is a strong suspicion of persistent or recurrent illness. Now, the first possibility is de novo thyroglobulin antibody positivity. Well, it doesn't seem to be very important. However, that if there is sustained positivity or increase of thyroglobulin antibodies that were absent before, then, okay, then you need some other clinical follow-up. Now, in patients with lobectomy, thyroglobulin antibodies are not reliable. Okay, that is laboratory. What about imaging? First of all, ultrasound. Now, usual standard criteria for increase in nodule growth is increase of 20% in at least 2 nodules, with the minimum increase in two nodule diameters, with minimal increment of 2 millimeters or nodule volume increase of over 50%. Well, that is for all thyroid nodules. However, recent guideline for tumor progression. So this guideline is one published by Koreans. These are for the watchful waiting for proven cancers. So you have a thyroid cancer, you're just monitoring, you don't operate, you don't do nothing. So three things are important: tumor enlargement, new ultrasound features, or gross extrathyroid extension or lymph node metastasis. If we want to say that it is growing, so it must be that in maximal tumor diameter increase of over 3 millimeters or increase of over 2 millimeters or in at least 2 dimensions. So these are ultrasound criteria. So ultrasound monitoring in patients who are operated, so it should be performed at 6 to 12 months and later periodically. Depends on the risk for recurrent disease and thyroglobulin status. If positive, results should change management. Suspicious lymph nodes of 8 to 10 millimeters smaller diameter should be biopsied, and also a thyroglobulin measurement in needle washout fluid should be done. And the thyroglobulin measurement with washout fluid is very, very good marker. Small lymph node should be followed, and if there is growth or if there is threatening of the vital structure, then we can do something more. So low risk patient with negative cerebral ultrasound and a low cerebral thyroglobulin on thyroid hormone therapy on a sensitive assay, we can just follow them. Okay. Now, what about scintigraphy? So patients with low to intermediate risk who have a negative initial whole body scintigraphy after radiotherapy, along with undetectable thyroglobulin levels, negative thyroglobulin antibodies, and clear ultrasound do not require follow-up whole body scintigraphy. However, diagnostic whole body scintigraphy is useful for monitoring patients at high or intermediate risk of persistent disease 6 to 12 months after radioactive iodine therapy. Now, what about PET? So PET can be very, very useful. So first of all, it should be done, should be considered in high-risk DTC patients with elevated serum thyroglobulin and negative radioactive iodine imaging. Of course, it can be used as a part of initial staging in poorly differentiated thyroid cancer, in prognostic tools, in patients with metastatic disease, and of course as an evaluation of post-treatment response following systemic local therapy. Why prognostic tools? Because you see, this is an interesting paper from 2000, and you see that PET positive, that the patient with the PET positive metastasis has worse prognosis than patient with PET negative metastasis. So this is why the PET can be very useful as a prognostic tool. Cross-sectional imaging, usually we don't need it. However, sometimes you need it because ultrasound is very good for the neck, but sometimes when you go deep in the neck, you need cross-sectional imaging for the bulky changes in the neck to assess potential disease that there is a problem with aerodigestive tract invasion, when you cannot appropriately visualize with ultrasound. And then sometimes you need a CT without IV contrast to visualize pulmonary parenchyma, or with IV contrast if you want to visualize mediastinum. Of course, you can image any other organ that you think that there is potential metastasis, including the brain, abdomen, etc. Now, but how often do we need to follow our patient? How long? Those are really problems. First, this is something that you know. So first, you stratify by response to excellent response, biochemical incomplete response, structural incomplete response, and of course, indeterminate response. Based on that, you can measure non-stimulated thyroglobulin if there is excellent response every 2 years, or biochemically incomplete every 6 months, or structurally incomplete every 6 months, while indeterminate you will need to decide every 6 to 12 months. So these are all depending on response to therapy. Another is stratifying by risk of recurrence, low, intermediate, and high. And depending on the risk of recurrence, you will decide what are you going to do, what are TSH goals, and of course, when are you going to do MRI or PET. So if we look at the different guidelines, you will see that there are slight differences, but not very big. So NCCN guidelines, they also define what to do, how you follow up by the extent of the treatment. So if you did just lobectomy, they said physical examination, TSH, and neck ultrasound, and no lab tests, because lab tests are unreliable. If you did total thyroidectomy without radioactive iodine, physical examination, TSH, thyroglobulin measurements, and of course neck ultrasound. And finally, if you have total thyroidectomy with radioactive iodine, then you can use a lot of different things, because the way you measure, you can measure and follow up patients in more than one way. So, and of course, these are the ESMO guidelines, and they're also similar to previous. So, depends what you do, whether it's lobectomy, total thyroidectomy, right? And depends on the risk of recurrence, you have different choices. So, generally, you will stratify the patient and decide how you're going to follow up. Now, what are the new things? Well, we can use liquid biopsy or try to find cell-free DNA or RNA in the blood. Unfortunately, at this moment, I'm not quite sure that these things are clinically useful. I believe that in the future that looking for the DNA or MRA in the blood, in peripheral blood, will be very useful, but I think we will need to wait for it. Thank you.
Professor. Now let's continue to the genetics. And let's call to the podium George Simakis, endocrinologist, military endocrinologist in the military hospital, whose research is based on genetics and thyroid cancers in general. So please, George, let's go on.
Thank you very much for the introduction, dear moderators, dear colleagues, ladies and gentlemen. I really would like to thank the organizing committee and especially Professor Nada Santrak for this invitation to be among distinguished speakers to talk about thyroid cancer and genetics. So, as we are in an oncology congress, we have to remember to keep in mind that thyroid malignancies account only for about 4% of all cancer cases. As we know, the most common type of thyroid cancer is DTC. In general, the 5-year survival rate is almost 100%, but this falls dramatically when we have a poorly differentiated or anaplastic thyroid cancer. And what do we mean with the terms differentiation and de-differentiation? It means that cancer cells look more like normal cells under a microscope and tend to grow and spread more slowly when they are differentiated versus the poorly differentiated or undifferentiated cancer cells. There are two basic models regarding thyroid carcinogenesis. The multi-step carcinogenesis model, where acquired molecular alterations occur and lead to dedifferentiation and finally to anaplastic thyroid cancer, and the fetal cell model, where molecular alterations occur early in the fetal thyrocytes. In this slide, we can see all the molecular alterations that occur and step by step lead to dedifferentiation and anaplastic thyroid cancer. The same we can see in this slide, and we have acquired molecular alterations that lead to the differentiation. And what happens when these molecular alterations occur? We have an increased ERK transcriptional program, and on the other hand, we have a decreased transcription of thyroid differentiated genes. This leads to reduced expression of the sodium iodine importer, reduced expression of the gene that encodes sodium iodine importer, and thus we have loss of the ability of the thyroid cancer cells to concentrate Rye, and we have decreased oxidation of Rye and limiting its effective half-life. And why it is so important, radioiodine for thyroid cancer? It is our major therapeutic tool because it has direct and indirect effects in the thyroid cancer cells, decreasing proliferation, increasing apoptosis, and leading to cell cycle arrest. Even from the half of the previous century, radioiodine started to be studied in the thyroid physiology and in treatment of thyroid cancer. Radioiodine refractory thyroid cancer is not so common. It's very rare. Only, as you can see, I don't know if. As you can see, about 5% of thyroid cancer cases become Rye refractory, and in these cases, the 10-year survival rate is under 20%. And what we have to to see, so as to say that thyroid cancer is refractory. We have to see absence of RAI uptake in all lesions on scintigraphy, absence in some but not in all lesions, progression despite RAI uptake, or we have to reach the maximum recommended RAI activity, which is 600 millicuries. But if we look more carefully in these terms, it's not all the same. Absence of RAI uptake in all lesions, we could say that this is RAI insufficiency. Absence in some but not in all lesions, we can say that this is RAI indifference. And progression despite RAI uptake, this is RAI resistance. And all these are explained because the term differentiated strictly implies a distinct morphologic differentiation. Iodine metabolic functionality is highly variable and is determined by the genomic and transcriptomic expressions in thyroid cancer cells. Regarding the genomics, in the RAS mutation-initiated cancer, we have diminished capacity for iodine processing. In the BRAF mutation-initiated cancers, we have significantly depressed iodine metabolic function, and the oncocytic cancers, we have absent iodine processing capacity. Regarding the epigenomics, we have DNA methylation and histone acetylation and deacetylation processes that lead to the differentiation. And we have different patterns regarding hypo and hypermethylation according to histology, according to the mutational state, and according to the phenotype, BRAF or RAS-like phenotype. BRAF cancers tend to be hypomethylated versus RAS type that they are hypermethylated. Regarding the deacetylation, when this occurs, there is inhibition of transcription of the thyroid differentiated genes, and this procedure leads to the differentiation. In this complex slide, we can see all the molecular mechanisms and paths that lead to the differentiation. And so is there any tool that could help us find a solution in this very complex mechanism? This is the thyroid differentiation score with the mRNA expression in level of 16 genes related to thyroid metabolism and function. And as you can see, the less the thyroid differentiation score is, the higher is the BRAF expression and the ERK signature. And on the other hand, the higher the differentiation score is, we have higher expression of the thyroid differentiated genes like thyroglobulin, TPO, etc. There is association between TDS score and survival outcomes in papillary thyroid carcinoma, as we can see in this slide. And now, from the clinical point of view, when we have refractoriness, what are we going to do? The first step is local treatment. But when we have rapid growth, according to RECIST criteria, then we initiate systemic treatment. Redifferentiation strategies focus on reversing the transcription program towards differentiation. This is one of the first studies for differentiation with selumetinib, but there was no statistically significant difference in complete response rate 18 months after RAI was initiated. The MERAIOD phase 2 trial, which is one of the larger trials and with the longer duration, tried to redifferentiate undifferentiated thyroid cancer, leading to expression of NIS and increasing the RAI uptake. And this is the update of this trial. You can see that no patient showed complete response, but 50 and 40% had stable disease or partial response. And in this study, there was a second try to redifferentiate the thyroid cancer 6 months after the first time TKI were given. Targeted therapies for thyroid cancer classified on their main category FDA approval status and clinical experience as a differentiation agent are showed in this slide. These are the published redifferentiation studies with a percentage of the redifferentiation evidence by imaging. And here are the ongoing redifferentiation clinical trials. In general, what we do is 1 week before redifferentiation is to assess, to evaluate metastatic disease. Then, during 6 months, we initiate the TKI treatment according to the molecular profile. After these 6 weeks, we stop the treatment and we evaluate the redifferentiation. And after 6 months, in general, we see again what is happening to the patient. In the Marriott study, we show that in some patients, they tried again to go on with a second redifferentiation. What we have to keep in mind is that during redifferentiation, there might be elevation of thyroglobulin levels, and this should not be misinterpreted as disease progression. It is a good sign, not a bad sign. And this is a patient from our series. You can see that we initiated dabrafenib to this patient. She had a BRAF mutation with thyroglobulin levels over 4,000. The thyroglobulin increased, and there was a mixed response in the chest CT scan. Then the thyroglobulin started to decrease, and there was progression in the lung metastasis of this patient. We added trametinib to this patient, and there was again a mixed response in the CT scan. So a thyroglobulin increase is not a bad news in such patients. The most useful imaging tool to assess radioiodine refractoriness is FTG PET, because we can see that the more refractory the thyroid cancer is, the more avid will be the lesions in FTG. But even here we have resistance to redifferentiation, and why this may happen, as you can see in the lower part of the picture, when we have SW or SNF complex mutations or loss, there is no restoration of RAI avidity, and this is accompanied with a low thyroid differentiation score. And this is explained with this mechanism. On the left, we can see that when there are no mutations, the chromatin is in an open state. So the transcription progress can be initiated, and we can redifferentiate our cancer. In the second picture, when the chromatin is locked, transcription cannot be initiated, and so these cancers are resistant to redifferentiation. It is remarkable that more than 8 years after riboswar introduced, we still try to find solutions for RAI to act better to our patients. So redifferentiation appears to be an alternative for refractory thyroid cancer, but clinical data are still preliminary. It is feasible based on genomic studies and has already provided significant clinical benefits in a limited number of patients. However, it needs to be optimized, its toxicity, because you cannot give radioiodine again and again to the same patient, and whether the strategy might afford benefits in patients with anaplastic thyroid cancer carrying a targetable mutation has to be tested in specific trials. Of course, we have always to keep in mind the Hippocratic philosophy, either help or do not harm. And I thank you for your attention.
Thank you. You can join us here. I'll now call, I'm sorry, the panelist, Kyriakos here came already, yes, and Professor Tatic. Thank you.
I want to thank all the talkers for the nice presentations. I believe also that less is more nowadays in thyroid surgery, but we have to insist in the preoperative imaging for finding patients with microcarcinomas, but who have already metastasis in lymph nodes. So we have to insist, so we don't need to operate them again. In my department, we operate a lot of patients who have already been operated after lobectomy. They have undergone lobectomy or total thyroidectomy alone, and we have to operate them again because there were clinical lymph node metastases prior to surgery, even with small papillary thyroid cancers, less than 1 centimeter. So I believe that we have to insist in the preoperative imaging.
Yeah? Okay. Yeah, you're right. But you know, ultrasound in the central compartment is not a very good tool. It's a difficult situation. I don't know how to how to deal with that, because the thing is, you know, you're going to have at least probably 20-25% of node metastasis in this patient, but what is going to affect this metastasis to the patient in the future is we don't know. And but the ultrasound, I would like to insist all my radiologists, but the ultrasound in the central net compartment is quite difficult to assess the node metastasis.
I'm saying not only in the central neck, okay, it's very difficult because the sensitivity of ultrasound is decreased, but also in the lateral compartments. They lose lymph nodes in the lateral compartment. I mean clinical metastasis, not indolent metastasis in the central compartment.
Yeah, for sure. You have to work in a multidisciplinary team with experienced radiologists or even endocrinologists or even surgeons with experience in ultrasound.
And a last comment. I believe that all that you have presented is right with the requirement that we have a very experienced radiologist or endocrinologist or surgeon to evaluate the existence of lymph node metastasis. Then, okay, then we can choose the less is more strategy on this type of tumors.
Yeah, for sure. And if you read the paper from Japan, and the algorithm always is the same in the presence of a multidisciplinary team to perform an active surveillance or less is more with lobectomy in papillary thyroid cancer, for sure.
But the Japanese school wasn't always so less aggressive. I started 30 years ago with this surgery with my professor, and they were very famous at despite ATA guidelines or something. The Japanese Thyroid Association and Association of Surgeons were very radical in surgery. It was approximately a very big percent of prophylactic lateral neck dissection. So the history and the data are changing, and so we are changing the trends. But I said it just like a comment, because the concept of wait and see is, as you said in the previous session, very difficult to explain to the patient. Probably there are traditional differences, and they will ask, and probably when they read that the papillary thyroid cancer gives lymph node metastasis, they will ask, will you do it, or why didn't you do it? So maybe some comments on that, because and the other thing, the wait and see and that follow up is very difficult. It's very tough for the patient to come every 6 months to on the controls.
I want to add something to Professor Markovic, so you can answer, and the endocrinologist and the surgeon, is that the Japanese, as Professor Markovic said, 30 years ago, they were cleaning everything. Now they are cleaning nothing, in a way of saying. In the first, this was done because they have problems with iodine. We know what problems they had. Now they want to do less. But the problem with the guidelines in the ATA guidelines, not in the European ones and not in other guidelines, is that they don't take in consideration the nationality. This is what for me is very important, because it's another patient, the patient in the States, another patient is the Greek patient, another patient is the Serbian patient, the German patients. I think we should take under consideration this, and I want from you to have a feedback about your experience in your countries about that.
Yeah, I want to comment that why you are completely right, and they start in Japan probably because third surgery has two main limitations for them. That is the scar. That is quite important, and the fact that in Japan occurs something similar to United States, that a lot of thyroidectomies are performed by non-experienced surgeons, and they have a high rate of complications even with a lobectomy. And I think you have to take into account these two things, because in medicine, of course, is a balance between risk and benefit. And if you are an experienced surgeon and you are going to perform a lobectomy, probably the rate of complication is very low, and you have to balance this with the follow-up of a 40, 45, 50 years of a patient of 30, 35 years old. So it is complicated. In Spain, well, Pablo probably can't tell us, but it's not very extended, the active surveillance of papillary carcinoma, because it's quite difficult to explain a patient, okay, you have a cancer, but doesn't matter. We are going to control you, to follow up. It's complicated.
Well, I believe you're right. I think the huge cultural difference is between, I don't believe that any of our patients will say, okay, you have cancer, but we'll wait. They won't accept it. And in Japan, I believe, at least talking with my colleagues who have experience in Japan, they have simply huge trust in physicians. They really want a physician to make decisions. So those are two different things. So yes, we can wait. And actually, both Japanese from 2020 and Koreans guidelines for follow-up of watch and wait, they have very good ultrasonographic criteria. What's growth, we can leave, what. But there is another thing. What do you think? I'm asking our surgeons about thermoablation. We got to one guideline for 2021, European Thyroid Association, European Society of International Radiology. And they state that, okay, thermoablation is possible. And then we got several meta-analyses and some other studies that show that thermoablation is quite a good solution for some of the papillary cancers, small papillary cancers. So can you comment on that?
Do you want to comment as endocrinologist?
Yes, you can perform thermal ablation, but I think that in all these things that we discuss, and Professor Koutelidakis talked about taking in consideration different nations in the guidelines. I think that every country should issue their own guidelines according to the ATA and ETA guidelines, because many times it is a matter who will take the responsibility. The doctor doesn't want to take the responsibility to advise the
the patient for follow-up. So the first of all is the doctor to believe in this decision. If the doctor doesn't believe it, the patient will not follow this.
Right. This is what I'm wanting to hear from someone. Let's ask the audience if they have questions. Yes, yes, please.
Hello, my name is Milan Jovanovic from Clinic for Endocrine Surgery. Thank you for your...
Louder, please.
Hello, I'm Milan Jovanovic from Clinic for Endocrine Surgery. Thank you for nice presentations and really good discussion. I have one question for Professor Žarković, but for everyone else. You mentioned that some guidelines doesn't recommend theroglobulin checkout after lobectomy, but also there are some other papers and guidelines that recommend to check out theroglobulin after lobectomy, to have baseline after lobectomy, and then that can be one of the markers for follow-up if theroglobulin is elevated to look out for some metastasis. What is your opinion and everyone else? Thank you.
So definitely some guides do not suggest using thyroglobulin or thyroglobulin antibodies, like I show you NCCN guidelines. So they don't think that there is. So now, on the other hand, I think as American guidelines, they suggest using thyroglobulin with a very high cutoff of 30 after lobectomy. I mean, I'm talking about non-stimulated, suppressed or non-stimulated thyroglobulin. So this is really quite a big difference between one of those things. Now, as I said, the thyroglobulin is a nasty molecule. You can try to measure it. And I spoke with people who really do, Carol Spencer, and sometimes even if there is a huge quantity of thyroglobulin, MS can miss it. So it's a very assay-dependent molecule. And it's a real problem. So you must know the assay you use, the lab you use, and I really believe that the most important thing is the changes in thyroglobulin and thyroglobulin antibodies. But if you have a huge remnant, so if you did like just a lobectomy, I really tend to side with the NCCN. I mean, just followed with the ultrasound, physical exam, and thyroglobulin antibodies are not so reliable in that situation. So that would be my opinion.
Kirsten Lorenz from Halle, Germany. I want to comment on your comment, Ioannis. I think it is not only the mentality and different nations that we need to consider, but also the thyroid cancer environment. Because, for example, in Germany, we have a high rate of multinodular large goiters. It's a complete different situation to follow someone with a multinodular goiter with maybe harboring microcarcinoma. That's completely different from Japan. It's different from the US. It's even different from Italy. So our cancer rate is 1 to 15, which is really bad. It's 1 to 5 in the Scandinavian countries, 1 to 7 in Italy. So it's a completely different harbor or patient cohort. So I think it's not only mentality, but also who follows up. And of course, it's a question of resources and investment and responsibility. But with regard to thermoablation, I think in Germany, we have guidelines for thermoablations as well, because the risk are not less than surgery. The only difference is scar. But I think there's also drawbacks because we don't have histology. You don't know what you're harboring except for the FNA when it's positive. And it's hard to follow up someone after thermoablation because the nodule is so obscure after the intervention. So I think there's many drawbacks with thermoablation bought by only few advantages. Plus, I think as a surgeon, it's hard. If you wanted to sell this, say, well, I may be 50 to 60% successful with the procedure. I don't think any patient would succumb to surgery if I say, well, maybe 50 to 60% success rate. I don't think we'll get anyone on the table. Thank you.
Professor Tatic, okay? Oh, no.
No comment.
Okay, if there is another question? No. then good news. The coffee just approaches so we'll take a little break, and thank you very much for your comments.
This works. Okay.
Hello, hello, hello. Coffee break is over. So we kindly ask you to sit because we will start the next part of the master class. Thank you.
Okay, we'll proceed with the program. Our first speaker has to drop his coffee first. Okay, it's my pleasure. This is a very exciting next session about advanced thyroid cancer. And we'll start with George Simiakis from Endocrinology Department of the Military Hospital in Athens. And he's talking about precision medicine and advanced thyroid cancer, clinical utility of genetic testing in the tumor agnostic era. George, please.
Thank you again for the introduction. I'm really honored to be here with you. So, this is the previous slide, so I believe everyone that were here before saw these slides. And we proceed with the advanced DTC. We talked before about the metastatic and dry refractory thyroid cancer and how we characterize refractoriness. And the mutations that take part in the refractoriness and the metastatic dynamic. So, when we want to initiate the TKI treatment, we have to choose the best treatment for our patient. So we have to proceed to molecular profiling. There are two possibilities. One is multi-step testing. It depends on the availability of infrastructures and money, of course. We can check for the BRAF mutation, for RET and TRAC ALK fusions, or on the other hand, we can proceed with NGS and see with thyroid-specific panels and look for possible therapeutic targets. Here is the distribution of the top 8 mutated genes in thyroid cancer. We see that BRAF is the most common. And here we can see the molecular pathways and the TKIs that block these pathways. Regarding DTC, the first TKIs that were used to stop disease progression were sorafenib and lenvatinib with Decision and Select trials. But when we initiate the TKI treatment, we may see disease relapse in disease. We may see that disease response in therapy in one patient, in one tissue, and on the other hand, we can see disease progression in another tissue or organ. And this is due to genetic heterogeneity, because in the same patient and even in the same tumor, there may be different molecular alterations. Recently, cabozantinib has been approved for DTC, previously treated with lenvatinib or sorafenib and showing disease progression. Dabrafenib and trametinib in 2018 was approved for anaplastic thyroid cancer with BRAF V600 mutation, and recently FDA grants accelerated approval to dabrafenib in combination with trametinib for unresectable or metastatic solid tumors with BRAF V600 mutation. Dabrafenib was compared versus dabrafenib and trametinib therapy in BRAF mutated PDTC and ATC, and there was no statistical difference between monotherapy or combination therapy. But if we take account progression-free survival of lenvatinib, it was better than dabrafenib and trametinib. On the other hand, lenvatinib in the SELECT trial had too many serious adverse events that lead to dose interruption in 80% of patients and dose reduction in 70% of patients. Regarding the anaplastic thyroid cancer, the guidelines show that we can use immunotherapy, immune checkpoint inhibitors, especially in tumors that they have higher tumor mutational burden, hot tumors that they better respond to immunotherapy. In the updated ESMO guidelines in 2022, we can see the same, that we proceed to BRAF molecular testing, and then we proceed with abraxane and trametinib if there is a mutation, or if it is wild type, we proceed with immunotherapy. The combination of lenvatinib and pembrolizumab has also studied for anaplastic and PDTC with a progression-free survival of 18 months. And again, this was observed mainly in patients with high tumor mutational burden or increased PD-L1 expression. But very, very recently, in September of this year, the ATLEP trial, who studies the combination of lenvatinib and pembrolizumab, showed no statistical difference regarding PD-L1 expression and response to treatment in the patient. And this is very important if we will still observe it in more studies, because till now, if somebody would like to ask for lenvatinib and pembro off-label, he had to show that there was high PD-L1 expression. Of course, there are many adverse events using TKIs, like hypertension, diarrhea, hand and foot syndrome, that require follow-up of the patient, regular blood tests, cardiology assessment, and imaging. Most of these adverse events can be managed, and sometimes we have to proceed with dose reduction with subsequent increase. This is something that can help us in managing these side effects. When we reduce the dose and then come back with an increased dose as in the beginning, we see that the patient tolerate the treatment well. But apart from selecting the appropriate TKI, studying the molecular profile of thyroid cancer gives us information about prognosis. As we can see here, mutations in the TERT promoter are associated with aggressive PTC and FTC, and here we can see as well that mutations in TERT and BRAF are correlated with worse survival in PDTC, and on the other hand, in ATC, if we have BRAF versus RAS mutation, the survival is worse. Regarding the advanced medullary thyroid cancer, patients with distant metastasis have a 20 to 40% 10-year survival rate. Treatment algorithm is almost the same as refractory DTC. First of all, localized treatments. If we have a disease in the neck, surgery or radiotherapy. If we have disease in the lungs, again the same. In liver, chemoembolization, and in bones, radiotherapy or biphosphonates and rank ligand inhibitors. Regarding the guidelines that are a little bit old, the ATA guidelines for MTC from 2015, we read that vandetanib or cabozantinib can be used as single-agent first-line systemic therapy in patients with advanced progressive MTC. So even in this type of cancer, we have to proceed with molecular profiling. Again, molecular profiling serves as prognostic marker. In this very interesting study from the group of Professor Rosella Elisei in Pisa, over 200 sporadic MTCs were studied with a thyroid-specific NGS panel, and we show that survival of RET positive patient is lower than that of RAS positive, and variant allele frequency is higher in larger tumors and with a worse outcome. Regarding the RET oncogene, it was first characterized in 1985. In 2005, we identified the structure of the RET protein kinase, and then the treatments, vandetanib, cabozantinib, and selective RET inhibitors were investigated. And why it was important to find the structure of the RET kinase domain? It was very important because it explains how TKIs act in our patient. The TKI binds in amino acids in the binding site of the TKI and doesn't allow to the ATP to to activate the receptor. Vandetanib and cabozantinib in the trials showed very good results, especially in patients harboring the M918 mutation, but even here resistance to TKIs may exist. And these are the gatekeeper mutations, mutations that they do not allow the TKI to bind in the binding site of ATP, so the ATP remains bind to the receptor, and the receptor is constitutionally activated. Solvent front mutations are mutations in the solvent front part of the receptor, and again do not allow to the TKI to bind to the binding site, and receptor is activated. Regarding selective inhibitors, the phase 3 trial of selpercatinib in advanced RET mutant medullary thyroid cancer, where almost 200 RET mutant MTCs TKI naive were studied, and it was the selpercatinib group, and almost 100 RET mutant TKI naive, the control group, received vandetanib or cabozantinib, showed statistically significant better results with selpercatinib versus cabozantinib or vandetanib. And regarding the tumor agnostic efficacy, here we can see that selpercatinib in tumors other than thyroid or lung cancer harboring RET mutation had very good results. Pralsetinib is another agent that was tested in metastatic RET-altered thyroid cancer. It is FDA but not EMA approved, with again very good results. And again, this agent showed a tumor agnostic efficacy in patients with RET fusion positive solid tumors, regardless of the tissue that the RET fusion was observed. And here we can see all the agents that are approved according to the tumor agnostic protocols, and you can see that many of them, I have highlighted them with the red boxes, are used in thyroid cancer, like NTRK, ALK inhibitors, RET inhibitors. The approved TKIs for metastatic MTC are vandetanib, cabozantinib, selpercatinib, and pralsetinib. Regarding liquid biopsy, we listened before something about that. It is a very intriguing non-invasive diagnostic approach. We have many things to study about this procedure. The concept is that we detect in the blood cell-free DNA, cell-free RNA, microRNA circulating tumor cells, and thus we can have earlier information about possible disease progression. There are studies, especially in metastatic MTC patients, that showed earlier increase of circulating free DNA before calcitonin or CEA started to increase. And also about CTCs, there was a cutoff over 5 to 7.5 microliters CTCs that was negatively correlated with the overall survival in metastatic MTC patients. And this study showed that detection of the mutations in the cell-free DNA led to detect a resistance in therapy, and so give us the information that we had to change systemic treatment. And as before, I will close with a patient from our series, because it is very informative about how useful is genetic testing in this subgroup of patients. It is a 32-year-old woman. She was diagnosed with MTC in 2018. Surgery was performed, and so calcitonin and CA started to decrease. Then local recurrence was recorded. Again, surgery was performed. Calcitonin and CA started to decrease. Again, increase of biochemical markers. Disease progression in mediastinum and liver was documented. Again, surgery, the third surgery, but there were precarinal lymph nodes that could not be removed. So, Vantetanib, in that time, molecular testing was not available in Greece, or it was very, very, very expensive. So Vantetanib was initiated with intermittent treatment due to severe adverse events, grade 3. And despite the decrease of calcitonin and CA, new lesions were detected in liver. At that time, NGS was performed in the Department of Clinical and Experimental Medicine in the University of Pisa, in the department of Professor Rosella Elisei, where a novel somatic mutation was found. It was a deletion in the ret. And with in silico tools that we can see if this mutation is pathological or not, we saw that it was disease causing, and we started selpercatinib to this patient, and we saw that calcitonin and CA were dramatically decreased till now. This diagram is till 2022, but till now CA and calcitonin are detectable, and in almost 1 year and less, you can see that without surgery, all the infiltrated lymph nodes were disappeared, and all liver lesions were eradicated. So MKIs and selective RTK inhibitors have increased the progression-free survival and overall survival of rare refractory cases. Clinical interpretation of molecular tools have increased our ability to have a more holistic and updated view of disease status. Selective inhibitors provide disease stabilization with low-grade serious adverse events, and again, the optimal timing for the initiation remains challenging because you don't know the exact time that it's better for the patient to start systemic treatment. But the new systemic treatments with the less serious adverse events help us in this decision when we see that disease is progressing. And I will close, the previous talk I closed with Nikola Tesla quotes. Here I will close with Nikos Kazantzakis quote, who is a Greek writer from Crete, from Creta, who said that there are no ideas, only people who have ideas, and they take the shape of the person who has them. Thank you very much.
Thank you very much, George. Very nice presentation. We're moving on with our next speaker, who's Ioannis Koutelidakis, almost there. He's a professor of surgery in the Medical School of Aristotle University of Thessaloniki, and is going to talk about new trends in surgical treatment of advanced thyroid cancer. So please, Dr.
Thank you very much, Pablo. Once again, I thank from my heart the organizing committee. for the very kind invitation, and we are having a great time in Belgrade, and thank you very much for it too. I will talk about the new trends in the surgical treatment of advanced thyroid cancer, and I don't know if we have new trends at the end of my speech about surgical treatment of such cases, or we have a better organized trends in surgical treatments. First, when we are treating cancers in every anatomical position, the problem was definitions. But in the last years, we have definitions, we have identifications. But for advanced thyroid cancers, there were not any common definitions about advanced. Also, it was hard to define an entity that includes all those different histologies and molecular characteristics of a cancer. It was not yet well detailed, so it was difficult to define. So even if we had a common definition, thus change the management in the end, or we stay in the same point. And the guidelines that recently published, they had three main efforts. They carried out three main efforts. Those guidelines were first by the American Head and Neck Society along with the International Thyroid Cancer Oncology Group, the ESCS, and of course the ESMO. All the results were basically made on consensus, both for definitions and both for management. And by itself, this means that it's a certificate that sufficient evidence is usually not there. Are proposals and are based on clinical experience most and low-grade data. But there are some common grounds in these guidelines. The existence of an advanced thyroid cancer must not be an intraoperative finding. Many years ago, we operated patients, and at the end we said, oh, this was very advanced, very difficult. We couldn't extract the tumor at all. And we said it's an advanced thyroid cancer. This is not right. We have to agree that this is must be done after molecular testing, before surgery, before neoadjuvant treatment. Also, we have an informed consent of the patient, collect all the data of the diagnosis, and then decide that this is an advanced thyroid cancer. So, identifications, sometimes from experienced surgeons, some of you are made even before we operate a patient. When we look at their exams, when we take a medical history, and when we have a physical exam of the patients. But this is right? No, it's not right. We have to collect. Data, and the American Head and Neck Society had those definitions made, dealing that we must have bulky disease, distant metastatic, of course anaplastic carcinoma should be an issue for advanced thyroid cancer, but most of the statements, most of the facts in these guidelines are molecular testing. They took a lot, they have a lot of statements for molecular testing, but this is feasible in Europe, in Greece, no. In Serbia, no, I know it, but also in more developed countries is not feasible. So we have to think of a consensus statement that is more close to the physicians, to the surgeons, to the endocrinologists, something that will be more clear. So the European Society of Endocrine Surgeons took under consideration those facts. And we made a consensus among us. We have read all the data, we have collected all the data, and we have made statements for the doctors, for the physicians, for the surgeons, for the endocrinologists, according to our opinion.
So all thyroid primary malignancies classified as PT4 according to the American Joint Cancer Committee, the last edition, have to be considered locally advanced tumor. And we had a consensus, as you see, in most of them. In the thyroid malignancies have to be considered regionally advanced with one or more of the following features present: bulky disease, extranodal extension, lateral neck nodal disease, and also mediastinal nodal disease. Those are facts that they give the definition of advanced thyroid cancer. Of course, all anaplastic, and in the presence of distant metastasis, we have an advanced thyroid cancer. And now we should take they entered in the guidelines, we put in the guidelines that we have to be, all those patients have to be evaluated by a multidisciplinary team. And that team should decide how we go on with that patient. It's very important. So we have surgery, we have systemic therapy, as George said before. Those is something that the one complements the other. It's very important to know that and to proceed with that fact when we deal with those patients. And the ESMO guidelines are based on those guidelines regarding the neoadjuvant therapy and all the drugs that we use. So we surgeons, we must aware of it before we take care of our patients. But we have to evaluate the patients, but it's not always an option, the neoadjuvant. It's not always a panacea, as we say in Greek, but after those guidelines, a lot of papers were published regarding neoadjuvant therapy, and now I will present the three more important I thought they are, and we can discuss about it after. This is a paper from the Latins, Colombia, Argentina, Brazil, all those countries that they have advanced thyroid cancer. And at the end they said that there is a low percentage for surgical intervention arriving in a row 0, row 1 resection. And it's only only 25% of the patients operated for those diseases. Another important paper coming from the States, this is very important paper. This is the one that has the better results, we can say, in the literature, where all 42 patients achieved those row 0 resections without new locoregional recurrences at 2 years of median follow-up. But why this has happened? Because they have a better patient selection. They had a better patient selection, I may ask, or they choose very carefully the patients that should enroll in this trial. And the next is from all well-known surgeons in the field, I think you all recognize, and they went someone in the middle, mixed results. It's important to treat those patients with neoadjuvant therapy, and there are patients that indeed manage to have row 0, row 1 resection. So, is there a surgical strategy? Sometimes less is more, but less is more because we want to resect less from the patient, and the problem is that we have a bigger disease. Why less is more? Less is more because we have to arrive to a row 0 or even row 1 resection, but we have to minimize the morbidity. Because if we fight with the patient, if we fight with the disease, not with the patient, maybe the morbidity will be very high. We have to keep in mind the tumor characteristics because not all the patients are candidates for adjuvant therapies, and the endocrinologists know that very well. We have informed the patient beforehand for the diagnosis, for the diagnostic tool, and the patient's priority might not align with the MDT optimal plan treatment. So the patient plays a role because his life is his, not ours. So we have to take it under consideration. So after all this, who and where should those patients be operated? It is obvious they have operative in advanced centers with high volume surgeons, optimally in tertiary referral centers. And do we have optimal solution for those who have infiltrated serious anatomical structures in the neck? Not always. First, we have infiltration of aerodigestive tract. We know all the Drale classification, which is simpler, and we have the SIN classification, which is more complex. But we have to remember that we cannot always say the infiltration very clearly preoperatively. Even if all exams are performed, we never know what is the infiltrations because there is the tissue, the tumor that infiltrates and not the CT scans or the MRI that can tell you the exact infiltration. And what we should do, save the tumor, make a window for the tumor. If we save the tumor, we will have more recurrences, more operations. But also, if we make a window, maybe we have more strictures, and we have to reoperate more times the patient. And if we make an end-to-end anastomosis, then the morbidity will be high. It's a very, very, very difficult situations. And those are the things that I have already tell you and describe you about what we should do. The most important thing is that the decision for resection and reconstruction at the end should be tailored to the patient and the tumor characteristics for in high volume referral centers based on MDT, and not only general surgeons participate in this operation, other specialities, you know which I mean. Regarding tracheal and laryngeal involver, there is extensive infiltration. If there is extensive infiltration of the trachea and the larynx, which are very rare in the differentiated thyroid cancer, but when they are applicable, we have performed conservative surgical treatment, saving and maybe partial thickness excision. I won't talk about laryngeal nerve. Of course, Nada will take care of it later. And let's talk fast about the two other categories of thyroid cancer, the medullary and the anaplastic. About the medullary, the statements are that when we're dealing with advanced medullary thyroid cancer, try to achieve a raw resection. What does it mean, a raw resection? Even clean all the infiltrated anatomical structures if we are sure that we can achieve a better result for our patients, meaning that calcitonin level will go very, very low. For neoadjuvant therapies in medullary, I think there's no big data, especially also in red negative patients, options are very limited, and radical surgery still remains the first fact that we have to take under consideration. For anaplastic thyroid cancer, we have the SS guidelines and the American Association guidelines for thyroid cancer. Of course, no debulking surgery unless very low volume is anticipated and adjuvant treatments are available with no secure results. No preemptive thyroidectomy, tracheostomy, although some head and neck surgeons are talking about that, but not sure that it is effective for the patient because the morbidity is very high and patients that don't feel very well with that. And for 4A and B tumors, we have to operate only if a good resection is achieved, and very few patients with distant metastasis can be candidates for surgery, and survival is increased only due to the targeted therapies which have place in the anaplastic cancer. Should we have conclusions? Simple conclusions: multidisciplinary approach, collect all the details from the diagnostic approach, visual, clinical, and molecular, inform the patient, first of all, and we have to have a surgery which must be cautious and tailored to the patients. That's very important, and from my point of view, those are the trends for the new trends for the surgical treatment of advanced thyroid cancer. And I don't want to be a hero
when I'm dealing in advanced thyroid cancer. And thank you very much for your attention.
Thank you so much, Johannes. That's a very comprehensive talk about the surgery. Now it's a special pleasure for me to introduce Nada Santrak, our host, and she's talking about the surgical recommendations for the infiltrated recurrent laryngeal nerve management. Nada, please.
Thank you, Kerstin. So I will just follow what Professor Yanis started, and he introduced perfectly actually to my talk, which will be only part of his. I will focus mainly on the, okay, so I will put this. Any arrow, something? Okay. So I don't have conflicts of interest, and as Yanis already said, there's so many nice recommendations in the SS consensus statement that practically gives a thorough overview of the advanced disease, which is not always possible to extract from many other guidelines. So I have focused my talk as well on this. Just to give a little background, recurrent laryngeal nerve is actually the most common infiltration site in the locally advanced disease. It occurs in 70% of patients. So what are the factors that are actually associated with this invasion? Usually the older age, the larger tumor size, the presence of lymph node metastasis, aggressive histologic types, as we heard today by Professor Tatic, and also the BRAF mutation. What is it that we need to do in order to make a justified actually decision whether to preserve the nerve or not? As Yanis already pointed out perfectly this, we should do a thorough, very thorough preoperative evaluation. We should not be in the position to make a decision rapidly in the OR. So in the next few minutes, I will go through all these steps to try to just to deliver you how the process of the conclusion should look like, and we can discuss it afterwards. Regarding the preoperative evaluation, it is really important to do a good imaging. Minimum of the requirements is, of course, the high-resolution ultrasound, and CT with contrast should be done in all patients that have local, regional, and distant disease, just because we need to know the disease stage in order to perform good decision, solid decision on whether to resect the nerve or not. What is it that we can actually conclude based on the imaging methods? We can get a proper assessment of the disease burden, correct anatomical position of the nerve, relation to the tumor, to the lymph nodes and other structures. And we also can observe if there is possible invasion and what is the extent of the invasion, which is really important. If we are doing imaging, it should be done by an expert. So it should be an expert radiologist, or if it's an endocrinologist who is focused and dedicated to thyroid surgery, it is also possible, or even a surgeon who has a lot of skill in that. But I don't think that a radiologist should be excluded in this phase. That's what I actually pointed already. Regarding the preoperative evaluation, it is of utmost importance to evaluate the vocal cord function. Why? We need to know whether the patient has mobility or not in order to perform a proper decision on further management. Fiber optic laryngoscopy is the one that is essential to formulate a strategical plan on surgery and provide appropriate patient counseling prior to surgery, because it is very important to have a talk with the patient regarding all the possible outcomes of the surgery. What we can observe at the preoperative evaluation is that vocal cord mobility is completely preserved, whether maybe it's not preserved but patient is completely asymptomatic, or we have the vocal cord palsy that is followed by symptoms of hoarseness and dysphonia, or maybe patient has a vocal cord paralysis that is not related to the tumor position and the disease itself. Okay. So in this context, a few things need to be emphasized. Any quality issues with phonation, swallowing or breathing, or lack of symptoms should be documented prior to surgery. However, we should keep this in mind. Only 30% of patients have actually the symptoms. Others are mostly asymptomatic. Further, approximately 50% of infiltrated nerves have normal vocal cord function completely. So if it's completely normal, it doesn't mean that the patient will be. You understood what I want to say. It's usually asymptomatic, so sometimes we can just observe it at the preoperative evaluation at the laryngoscopy. So we have to take everything into consideration, the clinical, radiographic signs, and also the pathologic features of the tumor itself, because then we can raise the suspicion based on all these analyses, even in the setting of the normal glottic function, which is important for decision making. Regarding the intraoperative assessment, we should evaluate the nerve integrity and the invasion characteristics and establish whether the nerve function is preserved or not. This is all what we can do also intraoperatively. First, we need to identify the origin of invasion, whether it is from the tumor, from the metastatic lymph nodes, or is it a bulky infiltration combined the tumor and the lymph nodes. Further, in that context, we need to focus on the extensiveness of invasion, whether it is only a recurrent laryngeal nerve that is infiltrated or we have multiple visceral involvement. This makes your decision sometimes easier. Further, we need to evaluate the level of invasion, whether it is at the laryngeal entry point or somewhere lower in the neck, or it is mediastinal invasion. We have to assess the scope of invasion, whether it is simple adherence or it is a complete encasement in 360% or more than 180. We need to know the depth of invasion. This is impossible to know. To be honest, we all face these situations and we don't know whether the endoneurium is infiltrated or only the epineurium. What helps us is, of course, the neuromonitoring, which I will talk about further. Why is this important? My first remark is that sometimes we think that the nerve is actually infiltrated while it's not. It's just a peritumoral fibrosis or adhesions that can mimic the nerve infiltration. So we must not declare it infiltration if it's not. If preoperative and intraoperative findings suggest that the nerve is infiltrated, we should do further evaluation before the decision of the nerve management. We should assess the nerve function with the neuromonitoring, and we should assess the resection margins with intraoperative histopathology if possible. Intraoperative monitoring is used for assessment of EMG signal intraoperatively, and it is actually important to do the stimulation proximally to the infiltration point. So if we have the signal that is available, the nerve should be preserved in most cases, while if we don't have the signal, then we still don't have to cut the nerve. We will see why. What is the rationale for the nerve preservation in this case? If we have asymptomatic patients without vocal cord palsy and we resect the nerve, this will drastically decrease the quality of life of patient. It has been observed in clinical practice. On the other side, resection in patients with vocal cord paralysis leads to worsening of the symptoms regarding breathing, voice changes, difficulties in swallowing, and especially the aspiration. So sometimes, if it's not necessary to remove the nerve to achieve clear margins, then we should not do it. Preservation of infiltrated nerve in differentiated thyroid cancers, as we saw, especially in younger patients than 50, can be really compensated with the radioactive iodine therapy, so it doesn't shorten recurrence-free and the overall survival in these patients. So what is the benefit of the resection of the nerve if we observe that? Also, elderly group of patients should be especially observed, because in their case, the survival is not impacted significantly, but on the other side, this resection of the nerve can lead to life-threatening complications due to aspiration, pneumonia, and death. So this should be taken into consideration while decision making as well. To proceed with this, neuromonitoring has significant implications for deciding on the surgical strategy, especially with respect of the staging of bilateral surgery. So if we can have option 1, we can remove the non-tumor side. If we have stable neuromonitoring signal, we can proceed to the affected side. And if the signal is not stable, we could perform the two-stage surgery. Option 2 is, of course, the opposite one. If we start from the tumor side, we still behave the same way. So if we don't have the stable signal, we should do the two-stage surgery in this case. If intraoperative findings do suggest the recurrent laryngeal nerve infiltration, regardless of the nerve function, we could be very much using intraoperative histopathology. We should try to resect and confirm whether the resection margin is clear. So in that case, the nerve can be preserved. A positive margin, if we get that from the pathologist, this might imply the necessity of the nerve resection. However, the definite decision on the nerve resection should be made after considering disease characteristics, which we've heard about during the first several parts, and especially from our pathologist. So moving forward to the disease characteristics that need to be taken into account, it's the histological type and the differentiation, the metastatic status as well, the probability of recurrence of the disease, the availability of different treatments, especially neoadjuvant therapies, and overall oncological benefit of this, our procedure that we are performing. My first remark is regarding the metastatic stage. There is no benefit of local aggressive treatments if we have metastasis of a disease. Second remark is focused on the histological type. Depending on this, whether the tumor is well differentiated or poorly or medullary or anaplastic, expected recurrence rates are different. So they are the lowest in the differentiated cancers. And aggressive surgery here in this case should not provide any oncological benefit. Also, there is a variable availability as well as efficacy of neoadjuvant and adjuvant treatments in different tumor histologies, and we have to take this into consideration. In the absence of non-surgical treatment efficacy, more aggressive surgical approach should be considered, taking all other factors into consideration, as we heard from Yanis, especially in medullary cancers, where we need to achieve biochemical and complete surgical cure, if possible R0 resection. We should take into consideration whether the invasion is made by the primary tumor or lymph nodes. Lymph nodes tend to not respond to the radioiodine therapy. Also, it is sometimes technically easier to preserve the nerve if there is the lymph node infiltration instead of the primary tumor infiltration, depending on the situation, of course. We also have to take into consideration whether it is the primary tumor infiltration or the recurrence infiltration. If we have the recurrence that is infiltrating, we will probably be more aggressive in that sense and resect the nerve. And the last remark is in case of nerve-sparing surgery, tumor residue should not be gross. So you have to keep it minimal. If it's not possible to achieve that, what is the point of resecting the nerve? Sorry. So what we also need to keep in mind are patients' factors and their preferences. We need to take into consideration the age, the comorbidity, the vocation of the patient. We have to perform informed discussion with the patient upfront to the surgery, and of course to see what are their expectations from the treatment and what are their preferences. So the basic of every conversation is to obtain the informed consent from the patient, because these are really legally sensitive matters. Last but not least, the last point is surgical expertise. We already mentioned this. These kinds of surgeries are really challenging. Sometimes you need to resect more than one organ, And if it is performed, it should be done in highly expert centers. We will talk more about the surgical volume and the complications in the next part, so I won't tackle that, but there are some standards that need to be fulfilled in order for a center to be able to perform this kind of surgery. It's not just a pure lobectomy, it's a very challenging surgical procedure. In the next part, I will just tackle a few recommendations for the management of the nerve based on all this that I have mentioned that is important for the decision making. Generally speaking, there are very little indications where we need to resect the nerve, but if we have vocal cord paralysis in a follicular cell-derived non-anaplastic thyroid cancer, if we don't have the EMG signal using the neurooperative neuromonitoring, and there is extensive infiltration of the nerve, we can't preserve the nerve, we are not able to achieve the local disease control, so the nerve should be taken out, and there is a clear statement in the SS consensus paper that Yanis talked about, but we all have to discuss this with the patient prior to surgery. Moving forward, if macroscopic disease clearance cannot be achieved and preoperative laryngoscopy shows no vocal cord paralysis or there is unilateral paralysis, but we get the positive EMG signal and the neuromonitoring proximal to the infiltration point, of course, we should make the decision based on patient and tumor characteristics. Nerve resection should be done in aggressive histology subtypes where we lack efficacy of the radioiodine therapy. If we have recurrent tumor or lymph nodes, if we have previously had external beam radiotherapy, when adjuvant treatment has or is expected to fail, and when justified by projected survival and disease-free benefits. That's what I already mentioned. This is really important. Talking about advanced medullary cancer, as Yanis said, we need to achieve R0 or at least R1 resection. So in order to achieve biochemical cure and macroscopic cure, we need to take the nerve out. So this is an absolute indication for the nerve resection if we talk about the infiltrated nerve. Regarding the anaplastic thyroid cancer, if it is operable, of course, and if we can achieve the macroscopic clearance of the disease, nerve should be resected. However, we need to keep in mind the Lazarus effect, which is the possibility of vocal cord pulse recovery after neoadjuvant therapies. So this can lead to nerve preservation if we administer neoadjuvant therapies and presuming that we have ones. If we decide and if it is approved that nerve should be preserved based on all that we thought of, there's a few options. We could shave the nerve or lymph node metastasis off without the damage of the nerve integrity, or we can also do the partial layer resection of the nerve with preservation of the axon. However, keep in mind that tumor residue should not be gross, it should be minimal. Partial layer resection has been shown to give good results by Miyauchi and his team from Japan. They had 72% temporal palsy, but then it was followed by full recovery in these patients. 11% of them had no palsy, so only 70% actually had a permanent palsy in their series, which can really encourage us to do these kinds of procedures if possible and if we are skilled. If, however, nerve resection is necessary due to segmental loss, direct anastomosis can be made. So we can use, out of all these methods available, I will just shortly promote the ANZA cervicalis and to recurrent laryngeal nerve anastomosis, which is simple to perform and very efficient. Of course, we don't expect vocal cord mobility, nobody's talking about that, but we have the better phonation. We can have some fatigue while phoning, and tone changes, but still we have very good outcomes after this. This is Kyriakos' original case, but the picture is amazing because we have the laryngeal entry point is completely infiltrated the nerve. So what we can do in this occasion, you need to remove the tumor, and it is sometimes very convenient to when we try to approach the distal stamp, because we need it for the reconstruction, we can divide the inferior pharyngeal constructor muscle and to do this laryngeal approach to find the distal stamp, and then we can practically anastomose it with the ansa cervicalis, for example. What is the physiology of all this? Of course, we don't expect the fibers to connect properly, but there is a misdirected regeneration, and what is the key here is that we preserve the tension during phonation. We actually prevent atrophy of the muscles. The vocal cords are still fixed, but they are not paralyzed completely, so there is a benefit for the phonation of the patient. To conclude, it is a complex process of decision-making, and as I said, it is really important to perform these kinds of surgeries actually in the highly equipped hospitals with the surgeons who have skills for this kind of resections. The point is to preserve the patient's quality of life, but also to achieve the local disease control. And we always have to keep these in balance, and if we can't help the patient, we actually should not harm him. That's why I want to emphasize that this kind of surgery should be done in a specialized center. And what Yanis also said, that less is more. Of course, unless there is the benefit for more radical approach. And I like to cite Marco Raffaelli. When I heard this statement, I liked it. So the nerve resection is one-way trip, but shave may offer possibility of a return trip. So it's better to wait than to do something irrationally and very quick. This is my message. Thank you. I hope I didn't extend. No?
Thank you very much. Another fantastic presentation. We're going to introduce our last speaker of the panel. That's Dr. Marco Buta. Is going to talk about thyroid cancer in children and adolescents. Thank you.
Thank you so much for the. Thank you so much for having me here, and I hope you enjoy our stay in Belgrade. We hope that we are taking good care of you. I'll continue another story. Less is more. In pediatric thyroid carcinoma, maybe that's not true, and I will talk about our experience of 44 years, retrospective study at our institute. This is where we work. This is the old building, 90 years old building, but we do a lot of work. We do around 800 cases per year. Of course, the thyroid surgery was brought to our institute by our professor Radan Đodić, who was trained in France by Professor Jean-Paul. And this is I always take a chance to remember to remember our professor. This picture was taken when I defended my master thesis on the pediatric thyroid carcinoma. We published that in the year 2014. What do we know about thyroid carcinoma in children? It's a rare entity. It accounts for 1% of all thyroid carcinomas. It is when we have a child with a thyroid nodule, in 22% the nodule is malignant, mostly papillary thyroid carcinoma, then follicular, and then medullary. And we know that it's aggressive. It has a high rate of metastasis and pulmonary metastasis. Risk factor after the Chernobyl catastrophe in 1986, we know that ionizing radiation is the risk factor, and in recent publication we know that autoimmune pediatric thyroiditis is also a risk factor. Until 2015, we treated children according to the adult guidelines. Now we have the special pediatric guidelines. What is new in the guidelines? We have the 3 stratification risks after the surgery: low risk, intermediate risk, and high risk. Low risk patients are the ones that have N0 disease, or the patients who have disease confined to the thyroid gland. Also, high risk, intermediate risk are the patients with extensive N1 disease or minimal N1B disease, and high risk patients are the ones who have extensive N1B disease or local invasive tumors. Of course, Europe gave their guidelines in 2022. I'm glad to have one of the panelists of this guidelines here with us. Guidelines are similar to the ATA guidelines. We can discuss the role of prophylactic central neck dissection, but both guidelines are similar in terms of proposing prophylactic central neck dissection in pediatric population. There's some risk stratification we must mention. One of them was published by Tuttle in 2010. Another thing that is very important when talking about the thyroid carcinoma in children is the stimulated postoperative thyroglobulin level. Professor Žaković was talking about the thyroglobulin, but this is the stimulated thyroglobulin. There are 3 papers that discuss this topic. The most important is the Chinese, with 118 patients, that set the cutoff value of the thyroid globulin at 17.8, with a negative predictive value of 96.8. Also beautiful work by Zanella in 2018. He evaluated all the prognostic factors, and he was the only one who included all the 3 mentioned prognostic tools. Our aim was to evaluate postoperative complications, tumor and lymph node histology findings, occurrence of relapse, and overall survival. We know, it's well known, that the extent of initial surgery appears to have the greatest impact on proving long-term survival. What do? We kept our strategy the same almost 40 years. We do always total thyroidectomy with central node dissection. And what do we do with the lateral nodes? How do we assess them? We assess them by sentinel lymph node biopsy in the lateral region, looking for occult and micrometastasis in the lateral region. This is the video of our Professor Jodic injecting methylene blue dye in the thyroid lobe, 0.5, coagulating the capsule. Coagulating the capsule. How do I do it now? And then approaching the lateral region and following the lymphatic path and removing the nodes in the lateral region. In the lateral region, we remove nodes we send to the frozen section analysis, or Schnellschnitt, as you would call it in Germany. And if the nodes are affected, then we proceed to the modified lateral neck dissection of that region. That has a special meaning in children because of the high recurrence rate of central and the lateral region. Our work was published in 2006, and we still use it to look for the micrometastasis in the lateral region. Here are characteristics of the patients. We had 99 patients. We divided them in 2 groups, under 16 and over 16. We performed total thyroidectomy in 97% of patients. We performed central neck dissection in 95% of the patients, sentinel lymph node biopsy in 50% of patients. And here are PTNM results. To summarize, we have a lot of central and lateral metastases. We have 66.7% of central metastases, 64% of the lateral metastases, which is in accordance to the other studies which I will show. Our follow-up was 187 months, and what is important and take-home message is that these carcinomas have excellent prognosis and all patients are alive. Mean tumor size was 22.3, which is really large, considering the volume of the child thyroid. Most of the cancer carcinoma was papillary. We had a lot of multifocality, capsular and vascular, capsular invasion and vascular invasion in follicular carcinomas, and lymph node metastases were observed in 71.7%. When we talk about mean tumor size, all the studies reported mean tumor size from 18 to 25 millimeters. And I want to use this slide to discuss it. Average volume of the child thyroid is 8 milliliters. An adult thyroid has the volume of 20 milliliters. If we do some calculation, that's the thing for discussion. Can we limit PTA to 4 millimeters? Our mean tumor size was 22.3. If we convert that to adult thyroid, that would be 55.7. That's a large tumor, and that might explain this aggressive behavior of the thyroid in children. 3 patients had nerve injury due to infiltration. We had to resect them. Transitory hypocalcemia in 10 patients, permanent in less than 1. I want to show you this meta-analysis from 2004. It's an old paper, but it's really interesting because it shows that back in the times when the pediatric surgeons operated children, the laryngeal nerve injury went up to 40%, and hypoparathyroidism was observed in 32%. Local recurrence in our study was 23%, which is, you think, it might be embarrassing for a high-volume endocrine surgeon, but it's is in accordance to the other studies, which I will show you. Now I will look into some studies that I found in the last 5 years. Most of them are single institution. There are some multi-institution study, but only one prospective study. This is the study from France, 662 patients. Results are really difficult to compare among the studies. French surgeons in almost 95% performed total thyroidectomy, and they did the surgery on lymph nodes in 80%. Study from Portugal, only 21 patients. What is interesting is that NX stadium was, they had 50% of the patients who didn't have a central neck dissection. This is the 12-year follow-up study. We'll see how that goes. Another study from Belarus, they reported the hypoparathyroidism from 12 to 36%, permanent nerve palsy in 6%. And what is interesting study, because it has similar numbers to our study, was the study from Tokyo, you know, when Fukushima nuclear plant accident happened. They performed a lot of screening in the children population, and they operated more children than they used to. They had 153 patients operated in Tokyo Ito Hospital, and they have percent of lymphnodal metastasis of 73% and recurrence rate of 22%. So 22% of the patients they had to operate. UK, this is multicentric study. First UK multicentric study was published in 2019. I expected to gather really good data from this study, but unfortunately they did not present. They only presented 166 patients. 3 patients died, and no data on recurrence and mean tumor size. A beautiful study from China. They had 184 patients, median tumor size was 24, and disease recurrence they observed in 27.2%. So the percentage of recurrence is high in almost all studies that I mentioned. Of course, Belarus study, they have the studies with the highest numbers. Again, study published in year 2000, they have the recurrence relapse rate of 21%, and in the 2.2% they did more than 3 operations. We had also the children who we operated more than 1 time. Last but not least, multi-institutional German and Austrian database study. This was the only prospective study that I found so far. It included 126 patients in 90 institutions. Mean tumor sizes were also large. PTC was 18 millimeters, and follicular thyroid carcinoma had a mean tumor size of 42. Lymphnodal metastases were observed in 45.9%, and permanent recurrent laryngeal nerve injury in 0.7%, which is great. Genetics of adult and pediatric carcinoma is different. In young patients, RET PTC mutations and all the recombination events are the main genetic alterations. In contrast, PTC in adults is predominant result of point mutations. Again, point for discussion. Is it a distinct entity? Are the pediatric and adolescents PTC different? Just to conclude, we had a lot of capsular and vascular invasion. Initial distant metastases were seen in 8 children in our in our study. Lymph node metastasis in 71.7% of the study, and distribution of the lymph nodes in the neck was not statistically significant according to the age groups. Local recurrence again in 22%. And despite all of these, survival is great, and most of the studies show survival of up to 98-99%, depending on the number of patients included. Of course, only the high-volume surgeon should operate pediatric patient, not pediatric surgeon. That's well known, and we now know that beautiful and well-known Pasieka publication about the quality of endocrine surgery, that a well-trained surgeon is always a factor of prognosis. Thank you.
Well, thank you very much for the excellent presentations, excellent talks. Do we want the remainder of the podium join us? Any pressing questions or comments from the floor? Anyone want to discuss or point out anything? Go ahead, please.
You can come closer.
Thank you for all the nice lectures. I just wanted to ask Dr. Butt about his last presentation. What were actually the pathohistological findings of these children carcinomas? What types of papillary cancers were involved? Maybe that would explain as well the aggressiveness of these papillary thyroid cancers in these children. If you have any information about that. What was the pathology of the children cancers that you had? I mean, was it, what sort of thyroid cancers were we talking about there?
We had 98% of the histopathological type was a papillary.
But what subtype of papillary?
We don't have that. We don't know that because we gathered the data from the 44 years back, and then we do not establish the specific subtype of the papillary.
Okay, I just think that this is something that maybe should be taken into consideration, the subtypes in the children.
Probably, but we don't have that data.
Yeah, okay, thank you.
And the other studies do not really make that difference between whether it was a tall type or any other aggressive subtype.
Okay, thank you.
Well, I think you showed the data from the German registry study with one of the largest cohorts, and as they are quite recent, the majority is classical PTC. Anything else is really rare. And I think with regards to the main discussion, because these pediatric thyroid cancers are so advanced locally and lymph node metastases are so frequent, I think it is still okay to be conservative with regards to the extent of surgery, because the prognosis is excellent. I mean, even though you have micrometastases, we strictly refrain from any type of prophylactic neck dissection, because if you have macroscopic and visible infiltrated nodes, we do systematic lymph node dissection, but we would never perform a prophylactic neck dissection.
Okay, thank you so much all for your presentations. I learned a lot again. Due to the sake of time, I would like to ask questions, but you can keep it very short, okay? Because the first for you, George, the role of neoadjuvant treatment in these advanced cases, should we send them first to oncology? If yes, who should we send it to oncology?
And
the role of neoadjuvant treatment in advanced thyroid cases. Is there a role for neoadjuvant treatment?
And you asked if they should be sent to oncologists,
Yeah,
or
before surgery.
For surgery.
Before surgery.
Yes, the role of neoadjuvant treatment is still with very little data about that. And also there is no specific duration of the treatment before surgery. We have to establish, if we say like the redifferentiation protocols, we have some data and say, for example, that we will give TKIs for 6 weeks. Here we don't have strict data how many weeks or how many months before surgery neoadjuvant treatment should be given to the patient, and also how much time we have to wait for the surgery, because all these treatments increase the bleeding. So we have to, I think, for this to wait, or we have to give it to selected patients that are unoperable.
Okay, you have something to add?
Just a brief comment, because no one of us has large series just from experience. I mean, in our hospital, we've learned from neoadjuvant treatment that we try to prolong. As long as we see effect, we prolong. And we've started with a 6 weeks interval, but I think patients and the R0 rate has risen the longer we are able to keep the patients on the therapy. But I think the key issue is the type of tumor. In ATC, I would say they should immediately start treatment, because then then you may be able to operate secondary. I think it's different with DTC and MTC. I think those are where you reach a more individual decision in the end.
And is that kind of therapy available in all the countries that we are coming from?
We know in Serbia we don't have a possibility for neoadjuvant treatments, no.
Professor Žarković, and what can we give to our patients for the therapy?
We can use radiotherapy. Yeah, we can use radiotherapy. Yes, so we can use collimated radiotherapy X-knife, then we have sorafenib, and actually we can give some other drugs using some so-called Article 9. So actually we can, but most of the drugs we use, at least at this moment, is sorafenib. That's almost a standard therapy. It's very simple to give.
In the neoadjuvant?
Yes.
Yeah, okay.
It's not a problem, because okay. And yes, we are using it quite routinely. And another thing is what I wanted to ask you. What do you think of TK inhibitors in inoperable patients with infiltration of trachea, larynx, or mostly trachea or esophagus?
Can you repeat again?
When you have infiltration of trachea.
Yes.
And would you give TK inhibitors in those patients, or?
This is a major problem when we have infiltration of trachea, and this is why we prefer, if we would have the ability to choose, it is better not to give anti-angiogenic drugs like sorafenib, lenvatinib, but to give, for example, dabrafenib, trametinib, that have reduced risk of bleeding. But this depends on what happens in every country. In Greece, fortunately, despite the economical problems, we have the ability to give FDA-approved drugs, even they are not EMA. And for example, even in ATC patients, we can prescribe as neoadjuvant treatment before surgery. And I would like to make a comment about the surgery in ATC. In the guidelines of ATA of 2021, the recommendation is to initiate treatment as soon as possible and don't wait for surgery. But if you look in the results from the studies that they used for the guidelines, the survival of the patients who underwent surgery was better than those that didn't.
Yes, and the radiotherapist advised that first operate and then do the radiotherapy. Not only the TKIs, but the radiotherapy is more. You have to choose surgery before the radiotherapy.
And the radiotherapy should be again given before TKIs, again for the risk of bleeding.
Thank you very much. Thank you for the talks. Regarding the neoadjuvant therapy, I think the most difficult situation is in borderline patients. And my question is, if you decide to start neoadjuvant therapy, when do you reassess the situation in order to identify if the patient is going to respond or not, and not lose the opportunity to perform a resection of the tumor? So when do you think is the time to reassess by cross-sectional imaging or something like that after neoadjuvant treatment?
If you choose to initiate neoadjuvant treatment, this is what Professor Lawrence told before. There is no still data to say that now I will stop the treatment and proceed to surgery. If you see, for example, the case that I presented, the MTC case,
under selpercatinib she was cured absolutely. There was no need for surgery. You have to wait and see what will happen with the tumor.
Yeah, I think when the things going well, it's easier, but if you are not sure if the patient is responding or not, probably it's going to be the...
What do you mean? If you
6 weeks. Cross-sectional imaging.
Can I ask a technical question to Nada? Anastomosis for the nerve, what should we use? How should we do it? Should we, is using the magnified loops okay, or should we invite a microscope in the operating room?
Well, in Serbia we don't have microscope. We use loops. Loops can help. Also, it provides more details. But if you don't even have the loops, you can at least put 2 or 3 or 4 maximum stitches to just approximate the nerve, and that can help as well. We don't use microscope. I am sure that it would be even more precise, but still we would not achieve any better, probably, the outcome because of the regeneration of the nerve. As I said, it's mismatched, so we can't put afferent and efferent fibers in the correct position anyway. But loops are something that makes it more convenient to work with. And very thin threads, 6 to 7 zeros, and that's it.
Thank you.
I think for the sake of time, because we're around an hour late, we might stop here the questions. And I don't know if there is a coffee break now. I don't know if we should probably skip and continue with the next panel. Right. Thank you very much, everyone. Fantastic.
Okay. Okay. My co-moderator is here.
I have to go with you. Like.
Perfect. Okay, let's go on. And the next speaker, I think she doesn't need presentation, but Professor Kerstin Lawrence from Halle is going to talk about medullary thread cancers. Thank you very much.
Surgical hardship to continue without a break. This is like in the OR. Sorry for this. Okay, I'm asked to talk about new strategy for surgical management and follow-up in sporadic medullary thyroid carcinoma, so I strictly stick to the sporadic thyroid carcinoma. So where do we come from? I think one of the essential issues to stratify our surgical management was the identification of calcitonin as this specific tumor marker that's representative of the tumor load and the type of cancer that we're faced with. So this already had an influence on the staging and prognosis of these patients, because you could see that when it started that calcitonin was assessed, already the overall survival improved in these patients. Calcitonin, however, does have some difficulties. There's many pre-analytic factors involved in the level of calcitonin, smoking, certain drugs, type of assay that is used. And we've lost pentagastrin as a stimulation tool, so calcium stimulation cannot be really compared to the old data with pentagastrin stimulation. So we're left with the basal levels of calcitonin, and there's so-called cut-off values to differentiate the T-cell hyperplasia from medullary thyroid carcinoma. This is sex-dependent, so for the female it's about 30 picogram per mil and 60 for the male. However, there's a gray zone of C-cell hyperplasia versus micro-MTC. And if you stick to these cut-off values, you would still miss some of the micro-MTCs and up to 13%. And in some of these cases, if you don't have anything in your ultrasound, you may just control these patients to not over-treat these. So this is where we started out. However, lymph node metastasis is the issue that we want to prevent when we try to individualize and step back from major surgery. And we know that the number of lymph node metastases and the number of infiltrated compartments are prognostic relevant. So if we have more than 10 lymph node metastases that are positive or more than 2 compartments of lymph nodes involved, we will not reach biochemical cure with our surgery. So this, of course, influences our outcome and biochemical cure rates. And you can see that if we have a primary surgery, the number of lymph nodes is correlated with the biochemical cure rate, and this, of course, has effect on the overall prognosis of the patients. And you can see that any remedial surgery does not achieve the same biochemical cure or effect in these patients. And even better in prognosticating the future is the lymph node ratio in these patients. So, having said that, this has influenced all surgical guidelines globally. If you look at the ITA guidelines, BAETS, the German guidelines, and the NCCN, all of them recommend total thyroidectomy in case of expected MTC. Only the German guidelines specifically denote that there's some factors of basal calcitonin levels to recommend on the extent of lymph node dissection that you should perform with the total thyroidectomy. But this has been the case for many years. However, again, looking into the future, the group from Miyauchi has many years back tried to reevaluate their patients because they've identified a cohort of MTC patients that had not only not advanced cancer, but only unilateral MTC. And they saw, after a series of 7 patients where they only did a lobectomy with microscopic lymph node metastases, that after lobectomy, these were biochemically cured. So there must be a cohort of patients with MTC that may be treated differently than the overall total thyroidectomy with bilateral, central, and even lateral compartment dissection. But the precondition that needs to be evident is that this is sporadic, because we know in hereditary, they will harbor the same risk for MTC in both lobes, of course. So they have reconsidered these data, and some years later, they had even 71 patients that they could analyze, and you can see that there's a cohort of patients that had not undergone total thyroidectomy, and overall, they had a 77% of biochemical cure rate in those that did not undergo total thyroidectomy. So this was the first data to initiate a different surgical concept for a subcohort of medullary thyroid carcinoma. And it was the Vienna group with Bruno Niederle who tried to identify this concept after they've identified that desmoplasia in these tumors strictly correlates with the risk of lymph node metastases. And they found that in all their negative, desmoplasia negative medullary thyroid carcinomas, they would never have lymph node metastases, and they were always biochemically cured. So they tried to take this concept into intraoperative frozen section decision-making when undergoing the surgery, and to omit lateral lymph node dissection that they would previously always do per standard procedure. They have then continued this concept, and this is a cohort of 360 patients, and they found that all desmoplasia negative patients had no lymph node metastasis and no distant metastasis during follow-up. All of them were biochemically cured. And the desmoplastic positive had about 3/4 of lymph node metastases and 6% of distant metastases in follow-up. And overall, the desmoplasia negative tumors were smaller, more often T1A stages, and they had lower preoperative CEA and calcitonin levels than the desmoplastic positive patients. So in the end, they considered, or their follow-up was that no lateral lymph node dissection was necessary in desmoplastic negative MTC. A French group also analyzed desmoplasia in MTC, and this is a quite comparable cohort of lymph node negative and positive patients that they compared. And in the univariate analysis, they could not find a strict correlation of desmoplasia with risk factors of medullary thyroid carcinoma and lymph node metastases. However, in the multivariate analysis, they found that the desmoplastic stroma abundance is highly correlated with lymph node metastases. So they had all lymph node negative patients with MTC when the capsule was still intact, and they had no desmoplasia. So we looked at our own cohort and tried to imitate the concept, and this is a highly selected group of only unifocal MTCs, primary surgery in our department, in only sporadic cases where the primary tumor was below 2.5 and more than 10 lymph nodes dissected to analyze the data. And we did ask for frozen section of desmoplasia grading and capsule integrity from our pathologists. And you can see that overall, the increase of grade of desmoplasia and the decrease of intact tumor capsule highly correlated with the lymph node status in surgery. So the number of removed lymph nodes and biochemical cure rates could highly correlate with the desmoplasia grading and the tumor capsule integrity. So this was also done in frozen section conditions, and when we reevaluated these data with the definite histology, it was an overall concordance of 98%. So the concept of intraoperative finding to surgical decision making was bearable in clinical practice. So we looked back at the registry data of the German Society, and this is also true. We found that there was 21 patients with MTC who had only gone under lobectomy, and almost all of them were biochemically cured after lobectomy. So this is another incident to find that this would be a concept for a subcohort of sporadic MTC. Now, you've heard from the first talk this morning from the pathology that in 2022, grading was initiated for MTC that was missing. And this also now show data is highly correlated with prognosis in MTC. So the low grade versus the high grade clearly differentiated with the rate of overall survival, the disease-free survival, the recurrent rate, and the cumulative recurrent rate in MTC. And this is also true if this is added to the concept of lobectomy. If you look at the grading and lobectomy, this is another factor to influence prognosis. So high-grade MTC with no or few desmoplasia has a high 10-year survival versus the low-grade MTC. So they evaluated that the tumor size and the primary surgery is less correlated with the prognosis than the type of desmoplasia and the grading of these tumors. So we could stratify our surgery according to this. However, the grading is not available in frozen section. So this would be an argument to possibly, in some of selected patients, to stage the surgery in MTC. So Henning Drolle then underwent another prospective series in his department and analyzed and only refrained from total thyroidectomy in sporadic MTC without signs of distant metastases. And what he found, again, was concordant with the findings before, that the limited resection in desmoplasia negative showed no multifocal MTCs, had no lymph node metastases, and all of these patients were biochemically cured, and there was no recurrences during follow-up. So they finally arrived at a new algorithm for sporadic MTC to perform the ultrasound and to have intraoperative Fosun section when you have no signs of positive lymph nodes, to refrain from total thyroidectomy whenever desmoplasia is negative, and the diagnostic lymph node dissection would not show micrometastases. In any other, desmoplasia positive or infiltration of the capsule, to then go for total thyroidectomy and at least ipsilateral central lymph node dissection. So this would be a newly defined or individual concept. In desmoplasia negative, just do the lobectomy, unless you have other reasons for the contralateral side, of course, and do a diagnostic central ipsilateral neck dissection. If you have desmoplasia minor advanced thyroid cancer, you do a total thyroidectomy and ipsilateral central and ipsilateral lateral lymph node dissection. And of course, in the advanced disease, you would still do a bilateral central and bilateral lateral lymph node dissection. Now, we've looked at the lymph node metastasis patterns, and if you talk about unifocal tumors, we compared the MTCs with our unifocal PTCs, and what we found is that the lymph node metastases more often went to the ipsilateral lateral side than to the contralateral central and contralateral lateral side, of course. And we would always see that the larger the tumor, the more lymph node compartments would be involved and need to be cleared, of course. Now, if we try to take this concept to our MTCs that were unifocal and sporadic, we found that it is even more clear that the ipsilateral lateral compartment is even more often involved than the ipsilateral central department. Why is that? Well, that is, of course, because it's a C-cell disease, and C-cells are differently distributed than different thyroid cancer cells. So it is still true that we could draw back our surgical strategy, but we need to remind ourselves what type of entity we're confronted with. And again, it's true, the larger the tumor, the more often more lymph nodes are involved. However, this pattern of lymph node metastasis persists in PTC as it does for MTCs, independent from the tumor size. And I think that is a good argument, like we are saying for differentiated thyroid carcinoma. It's not the size that really defines what we should do surgically. It's not the 1 centimeter rule we had in Germany for many years, but it's the type of tumor, the position of the tumor, and secondary factors. So briefly for the follow-up, well, follow-up in MTC still is a lifelong follow-up, and it is individually risk adapted. It requires the immune histology and the TNM classification because the staging determines what frequency and what investigations you need for your follow-up. Basal calcitonin and CEA levels should be done 6 to 8 weeks post-operatively to see whether we have achieved biochemical cure or whether we should look for metastases. And also the tumor testing for germline molecular mutations is important, especially in advanced disease, to decide what type of systemic treatment may be available. So this will all determine frequency and the intensity of our follow-up. There's definitions, of course. We have biochemical cure, that's clear, ideal response of surgical therapy, no calcitonin measurable, CEA normal, R0 achieved in pathology, and these are usually stage 1 or 2 tumors. Then we keep checking these patients all 6 months with basal calcitonin and CEA levels, and do investigation of the neck with ultrasound. And you can see that if these are all stable, it's about a 20-year survival of almost 90% in these patients. Biochemically incomplete response would be any persistent calcitonin, medium or even elevated, mostly 2 or 3 stages with occult residual MTC. So we don't know where the tumor is located. We would follow these patients again all 6 months. And only if we have significant increase, or we do see on ultrasound or other imaging any tumors, we would investigate further with imaging procedures. So 20-year overall survival in this cohort is about 82%. So it's a slow-growing tumor and it allows for some type of surveillance. Structural incomplete response, of course, is the most difficult to treat, usually associated with high calcitonin levels. It is usually locally infiltrative, stage 2, 4A or B tumors with distant metastases. But still, these patients may live for a long time. So we refer to calcitonin and CEA doubling times to decide what type of investigation makes sense and if these investigations would be followed by any intervention. And you can see that even in the N1 or N1B stages, the majority of patients over time may still achieve biochemical cure. So in this cohort, you can see that there's even 44% with C1b stages who after 12 months achieved biochemical cure. However, again, this nodal stage and preoperative calcitonin and CEA levels are highly associated with the calcitonin normalization postoperatively. So the higher the level, the larger the tumor, the longer it takes for calcitonin and CEA to normalize. But you see there's a cohort of patients who will definitely never normalize, and this is prognostically important. But it takes time, so it does not make sense to really rely on your postoperative calcitonin levels before 1 week. Doesn't make sense, but the majority normalizes within 6 to 8 weeks. And patients with more than 10 lymph node metastases or basal calcitonin levels more than 1,000 will definitely normalize later or never. So calcitonin doubling time is highly associated with prognosis. But you still see that even though calcitonin doubling time is higher within or lower with 1 year, this is associated with decreased or recurrence-free survival and overall survival, but the survival rates are still good compared to other tumors. So this is a dynamic and individually risk-adapted strategy for MTC. Calcitonin and CEA doubling times do help. Less than 24 months, you have a 94% of structural recurrence, so you need imaging investigation in these patients. If it's below 12 months, you need to consider treating these patients because they accelerate very fast. And for these patients where you decide to do either surgery or to start treating systemically, you should do imaging procedures to have RECIST criteria for either surgery or to select systemic treatment. So we do need laboratory, molecular testing, and imaging. With regards to imaging, first measure would be ultrasound, but also CT and MRI for distant metastases, bone scintigraphy, and molecular functional imaging. I think the first choice would be Doppler PET CT. Very dedifferentiated MTCs, you can go for FDG PET CT. And we now have a recent series in our own department where we tried FAPI PET CT, which is much more sensitive compared to the Doppler and DOTA. So if you have patients with small tumor load and you're worried about, I think FAPI PET CT is probably superior. And we'll try to show this with the larger series in the future. So when we move to systemic treatment, I'm not going into details, but there's, of course, depending on the molecular features of the tumor, it's either the MKI, TKI, or the RET kinase inhibitors that are best functioning, and I think the best advantage of the RET kinase inhibitors definitely is that they have less side effects for the patients and are really well tolerated. And this also has led to a neoadjuvant concept, so patients that cannot be initially resected do profit from neoadjuvant RET kinase inhibitor therapy and can secondarily be operated on. And we've already seen that in some of these patients, even vocal cord function may return in case of local infiltration with tumor. So to conclude, surgery in MTC still remains the exclusive curative treatment. It needs to be performed timely and adequate. So the total thyroidectomy still has its important role, but there is a subcohort that may individually be treated and biochemically cured with a lobectomy. It's only sporadic tumors that can be treated this way. And in these, we can omit systematic lymph node dissection. For much advanced tumors, I think neoadjuvant therapy enables a second surgery and definitely gives advantages to overall survival and give a new perspective for these patients. So the concept of intraoperative frozen section for desmoplasia and capsular integrity, I think, is a very good and clinically applicable concept. If we do not have frozen section, I think there's still a cohort that may be staged with surgery. You do a lobectomy, and after you have your final histology, you can still go back and do the contralateral side in your lymph node dissection if the patient is not biochemically cured. Thank you.
Thank you very much for this beautiful lecture. Now I want to call Kyriakos for next lecture.
Hey. Dear colleagues, dear friends, I would like once again to thank Professor Ivan Markovic and Ada Sandrak for inviting us here in your beautiful city. I will speak about the management of hereditary medullary thyroid cancer. I will keep it short. I will highlight only the important points, and I will accelerate in the basic knowledge. The medullary thyroid cancer appears in 75% in sporadic form and in 25% of the patients in hereditary form. There are a RET germline mutation in the RET proto-oncogene. It is an autosomal hereditary syndrome where we discrete the MEN2A, MEN2B, and the familial medullary thyroid cancer. The familial medullary thyroid cancer, it is a category of MEN2A nowadays. The classical, the MEN2A is appears in 95% of the patients with MEN2. It is the classical MEN2A. The MEN2A with lichen amyloidus is the MEN2A with Hirschsprung disease and the FMTC, while the MEN2B is a rare condition and appears only in 5% of the patients. The FMTC is characterized by the absence of FEO and primary hyperparathyroidism, while MEN2B is characterized by the absence of primary hyperparathyroidism. We can see here in this table all the differences. The MEN2B has the typical marfanoid characteristics in the vast majority of patients. They are thin and tall with long upper and lower extremities, and they have a joint flexibility. They have tumors of nerves in the lips, mouth, eyes, and digestive tract. The MEN2A is less aggressive regarding MTC compared to the MEN2B. Important issues in hereditary MTC young patients is the early diagnosis and finding the proper time for surgery. This is the most important points of the surgical management. The early diagnosis. the best means is the genetic testing, where there is a family history. The problem in men to be patients is that there are de novo germline RET mutations combined with a negative family history of men. We have the onset of the disease on the first month of life, and so the early diagnosis with genetic testing, taking into consideration that more than 90% had de novo mutations, is practically impossible. In this publication of Brauch and Kerstin-Lorenz, we see that 41 out of 44 men to be patients had de novo mutations with no family history, and so genetic testing with more than 93% de novo mutation cannot help. So we rely on premonitory symptoms. There are some symptoms in the infancy as the inability to cry tears, because there is a decreased activity of the thickened corneal nerves, which affect the sensitivity of the ICA phase. So this patient, they cannot cry tears. There is the constipation. It is because of the intestinal neuromas. They can affect the intestinal motility and cause frequently constipation, and a severe constipation can be the first clinical sign during the infancy in men to be patients. The third and last premonitory symptom is the feeding problems because of mucosal neuromas, which create raised bumps on the lips and tongue, and so the infant cannot suck the nipple and will have problems by feeding. These three premonitory symptoms, inability to cry, constipation, and feeding problems, are our only signs, and they can help us to diagnose at an early stage the men to be. So we have to raise the awareness of pediatricians. They are the doctors that they can make an early diagnosis. The important point of finding the proper time of surgery to find the window of opportunity, which is the time in which either the MTC is not yet developed, or if it is developed, is isolated in the thyroid gland. We have to use the following information: the underlying mutation, the calcitonin levels, and the preoperative imaging for the detection of infiltrated lymph nodes. The initial risk level of American Thyroid Association of A, B, C, D was modified 2015 with revised American Thyroid Association guidelines into highest, high, and moderate group. And after the publication in 2017 by Matthias and al. Regarding the codon 883, in which these patients with this mutation were classified as high-risk patients for developing medullary thyroid cancer, we have these risk level stratification. The highest level, the 918 codon in men to be patients, the high, the 634 and 883, and the moderate that include all the remaining mutations. In the men to be group, of course, the prophylactic thyroidectomy must be done during infancy, if it is possible during the first year of life, or even better in the first 6 months. After 4 years, there is no practical possibility to cure the patients with men to be. The high-risk mutation category, 634 and 883, we have to perform the surgery during the first 5 years of life. They need an annual examination to start at the age of the 3 years, unless we see increased calcium levels or clinical evidence of disease earlier. The moderate mutation, that is all the remaining codons, we have to operate the patient after the 5 years of life, and it is individualized. We use as you use the calciton levels and of course the imaging. What about the extent of the surgery? What about neck dissection, prophylactic or therapeutic? In the high-risk category, the saddle neck dissection, it is performed if calcium levels are more than 40 picogram an ml, or if there is, of course, imaging evidence of lymph node metastasis. In the moderate risk, we take into consideration the calcium levels and the imaging evidence of lymph node metastasis. Another question is, what about parathyroid transplantation in cases that parathyroid glands are accidentally removed or not viable during thyroidectomy in men to patients because of the possibility of developing later primary hyperparathyroidism? We have to take into consideration that men to be patients and FMTC patients, there is no need for heterotopic transplantation. We can't do it orthotypically because the possibility of primary hyperparathyroidism is 0 by men to be and FMTC patients, and it is very, very low in the patients with all other codon mutations. Heterotopic will be done in patients with a codon 634 mutation because the possibility of primary hyperparathyroidism in this patients is about 30%. What's the importance of the proper time of surgery? We need the curative potential of the operation, and we want to minimize the possible complications. And there is no surgery without complications. The complications are increasing as the age decreases. So we need to perform the surgery just before the MTC develops, not much earlier, because then we will have more complication. In this study, we can see this is a cross-sectional analysis of 1,200 patients younger than 70 years, and which underwent thyroidectomy, and this is the complications rate. You see that in the ages between 0 and 6 were 22%, in the ages 7 to 12, 15%, and 13 to the 17 years, 11%. You can see the complications rate is decreasing as the age increases. So, in patients with hereditary medullary thyroid cancer, we looking the window of opportunity to operate the patients with the minimum complications and the increased possibility of cure. Thanks.
Thank you for such a good lecture. Does anyone from the audience have any question?
Pablo. Thank you, Joaquin. Hello? Yeah. Thank you very much for these wonderful presentations. I have one question regarding this medullary thyroid cancer without desmoplastic reaction. If they do not have lymph node metastasis and hemithyroidectomy is sufficient for treatment, when are we going to stop following them? If, I mean, they behave like a kind of a benign tumor. I said this in front of a pathologist in a previous meeting and almost jumped on me because he said there were no benign C-cell tumors, right? But this really behaves like a benign tumor. Once it's out, it looks like. So will we be ready to stop following up after a certain time? Do we still follow these patients for life? What would be your recommendation regarding follow-up of these patients that seem to have very low risk, if any, for developing a recurrence in the future?
I think that is an excellent question because, of course, the calcitonin post-operative will still be there naturally because there's one lobe left. And I think we still can't really say that we can rename a type. Maybe, I don't think there will ever be anything like a nomenclature like a benign MTC. I think that doesn't make sense, but it's a contained tumor. It's a low-risk MTC, I'd call it, and I think we should still continue because the proof of concept does not have a long follow-up yet, except for the Japanese group. But in our hands, we follow them like any other MTC. We follow them every 6 months with basal calcitonin, CEA, neck ultrasound, and clinical investigation. And so far, we have to do this, I would say, at least lifelong.
Okay, Nada?
I may suggest something. Lifelong of the surgeon. I was I could not believe that the patient is cured properly with hematoidectomy, even if the patient is okay. I think you hear my...
Yes, but unless we have proof or any other risk factors, I don't think that in these selected cases there is necessity to do more. I mean, it's like with active surveillance or less than thyroidectomy in DTC. I don't think there's a principal difference if the patient agrees to undergo controls and surveillance. And I think the data wasn't shown today, but the cohort of the largest group of the Japanese, they have 30 years of follow-up for their surveillance data. And the patients who would undergo completion thyroidectomy, half of them underwent completion because they did not want to go to controls any longer. It was a psychological burden, and they didn't want to be controlled. So I think that is a good argument, but there's, I think, enough patients who really want to have thyroid left behind. And I think in these selected patients, that is a concept.
I just thought it would be important to underline the possibility of fine needle aspiration biopsy and interaction with the false positive finding on the desmoplasia.
Well, it is, in our guidelines, it's strictly against FNA in these patients because you cannot really rely on your desmoplasia after FNA, or it's much more difficult.
Yeah.
And you don't really need to because the calcitonin levels and ultrasound findings are, I think, good enough to date for these patients to not perform FNA.
Exactly, which underlines also Pablo's talk at the beginning. So it is important to evaluate thyroid status, calcitonin in every nodule that we suspect.
Kerstin, we have moved from calcitonin was the most important factor to decide the extent of the surgery, and now you didn't mention in your new algorithm to decide the extension of the surgery. It doesn't matter at all, the levels of preparative calcitonin?
Well, I did mention it, but nevertheless, no, it is levels where we expect from experience that we would achieve tumor-associated biochemical cure. But like I said, if you leave behind one thyroid lobe, you will have a residual calcitonin level, depending on the size and the gender of the patient, that you would try to interpret. What we're missing today now is that we cannot stimulate like we did in the old pentagastrin days. We still do calcium stimulation tests, and I think in our hands it's a good tool, but it takes very defined settings to be analyzing this. And I think it is something more to be relying on the calcium stimulation test to prognosticate if the lobectomy will be sufficient for tumor follow-up. But this could not be, we did a 2-center study with a Viennese group, and our data are quite comparable, but I would refrain from saying that calcium stimulation test will help you to make this decision, because there's data out that are not as good as our 2 centers.
Yeah, well, yes, there is some data that calcium stimulation test is not quite as it should be, but there is quite a lot of data about calcitonin in fine needle aspiration, measuring calcitonin actually when you flush the needle, and it seems that sensitivity and specificity is quite good, although it cannot differentiate between C-cell hypoplasia and micromedullary or medullary cancer. So what do you think about measurement of calcitonin in FNA aspirate?
Well, like I said, I would not want to perform FNA because then I cannot rely on the intraoperative frozen section evaluation, or make it even harder for the pathologist who's already stressed to give us a grading of desmoplasia. Plus, I think our basal calcitonin levels drawn from the blood are good enough to rely on that we have to consider that this may be MTC. But to answer your questions, I think we more and more see that large tumors with high basal calcitonin levels that are capsulated and without desmoplasia will still reach biochemical cure with lobectomy. So I think calcitonin, yes, does have a role. Like I said, if you have a preoperative level of 1,000, you can be quite sure that this is an advanced thyroid, MTC. Anything between 500 and 1,000, I say, well, you could still achieve biochemical cure with a lobectomy. So it's only one factor. If I have sky-high CEA levels, I would rather be worried that I had distant metastases, and you can still discuss, does it make sense to perform total thyroidectomy and bilateral central and lateral neck dissection in someone who has distant metastases? So I think it is a good thinking to reconsider the surgical concept for the individual patient.
And our experience is very low compared with yours, but also calcitonin levels are correlated with the desmoplasia. So desmoplasia negative patients have lower calcitonin levels also.
Yes.
And when would you prefer calcium test? I mean, what's a basal calcitonin level when you're not 100% sure whether it's medullary cancer? I know that Pugazzola showed some 23 or 24 as the best cutoff level for non-stimulated test. Which are the patients where you would prefer calcium test to diagnose or to confirm medullary cancer?
I would definitely want to do it in anyone where I do not have a convincing finding in the thyroid, because I think the key advantage of stimulation tests is to exclude extrathyroidal sources, so whatever, pancreatic net or lung nets. I think that is the best advantage to do stimulation tests. I have patients where the stimulation test with a finding in the thyroid was not as high as I had expected. And those patients I would be worried about to offer the concept of lobectomy to only eliminate one incidental finding on ultrasound. I think I would have second thoughts to have a staged procedure. So I think those two are the most important patient groups to do a stimulation test.
I have a I have a question for Kirsten regarding patients with C-cell hyperplasia. Would you consider these patients are candidates for surgery or not? And what would, I mean, from our experience, we have been performing calcitonin tests because we're a tertiary referral center to every patient who comes to us with a thyroid nodule. So we have been doing calcitonin tests for the last maybe 20 or very long time, at least 20 years. And this was not the case everywhere in the world because of the cost it incurs, but whereas here this health system is a bit different. Generally, we don't think about the costs while we are working as doctors. So we are not, let's say, don't have that burden to consider that. So in our opinion, in our experience, we have more than 20 years of patients we're doing routinely calcitonin. And since we are a centralized center for endocrine disease, a lot of these patients, these calcitonin tests were a way of screening that we were doing actually. And in our experience, by doing this, we found a lot of patients who had lower levels of calcitonin than 30 or 60 for males, and we would perform a stimulated calcitonin test, and we actually did a study where we found that a rise of over 300 was indicative that the patient should be operated or on the stimulated test. So generally, in my personal experiences, when I have a patient with a rise in calcitonin, I always consider myself, if I was that patient, I would go for thyroidectomy. Because I feel that the benefit of leaving a patient with the C-cell hyperplasia who has a response on the stimulated test, which is maybe not over 300, but is 250, I would again maybe suggest to go for a total thyroidectomy. So now because we don't have the knowledge of the desmoplasia, what is the situation with the patient? We only have the levels of calcitonin or CA, let's say, but we're just talking about the calcitonin. So in your opinion, do you think we are over-treating patients with hyperplasia? Well, in a way, we are again preventing patients to develop maybe medullary cancer and having better survival rates for patients with, let's say, we don't see as much of advanced medullary thyroid cancer lately. Let's say, just in our experience, we don't have, like we used to have before, so many of these very advanced patients because we are maybe over-treating them because we do routinely performing calcitonin. So what is your opinion about this? Do you think that's a good thing or not a good thing?
Well, let me answer. But with our concept of, it's in our guidelines for many years now that any patient who undergoes thyroid surgery should have calcitonin assessed preoperatively. And by this, we have gained the best biochemical cure rate and the least extent of surgery and still arrive at cured patients. So I think that is hard to give up. So we were, I think, really slow to take over a concept of less than total thyroidectomy for these patients because our results are so good. It's not only our center, but within Germany. I think the results are really convincing. Now, if we give up this concept, what are we buying in for it? I think we need to consider this. And considering is our highest problem in thyroid cancer surgery is still hypoparathyroidism, and that is the argument to refrain. Plus, there's more and more patients who are reluctant to give up the thyroid and said, well, I'd rather not take pills, and 70% will probably do fine without medication. So I think there are arguments. Now, I cannot exclude C-cell hyperplasia, but this would be a finding you'll have postoperatively because rarely you see C-cell hyperplasia in only one lobe. So if your histology shows you have diffuse or maybe slightly nodular C-cell hyperplasia in your one lobe, I think it's a good argument to say, well, you're fine with that. It doesn't matter. But I think it is much more difficult to exclude other reasons for a rise in calcitonin as you follow a patient, because this is peritumoral C-cell hyperplasia in differentiated thyroid carcinoma. Hard to interpret, I think. Plus, renal insufficiency medication. All these things need to be excluded to be able to interpret your findings. So I guess, yes, C-cell hyperplasia is probably over-treatment with total thyroidectomy. It's not a disease. You don't need to cure a patient of it, although we know it may be a precursor. Cannot be excluded, but I mean, it's like life. It's not everything in life is safe.
It's the patient's choice in then, but you have, yes. Maybe you should present, we present it to them and say this has a possibility to go this way or that way, and what is we can always follow up, or you want to have a surgery. A lot of the patients want to have the surgery actually, because they don't want to think all of their life, will something develop there when they have that case. So I just wanted to share the experience with that.
Yes. Kerstin, I would like to clear something because I was a little bit confused. I heard before that calcitonin levels depend on the desmoplasia presence in the tumor. But I think that calcitonin levels are independent of the desmoplasia. We have high calcitonin, desmoplasia negative, as Durale showed in the paper, with no lymph nodes, nothing, after a major operation. So desmoplasia is independent of the calcitonin. And another problem that we have in Greece is that we cannot perform desmoplasia because our pathologists are not aware of that pathology. And I don't know in how many countries desmoplasia is present as a pathological finding through frozen section, not afterwards, because afterwards doesn't matter. The problem is frozen section, how reliable can be. In Greece, it's not. I'm telling you that.
Well, I think to answer your first question first is that, like we've shown in the data, I mean, that's not large series, of course, but there's the Miyauchi data, Niederles data, and our data, and they are all in line that desmoplasia and tumor size and grade of desmoplasia are associated. But desmoplasia is not, or correlated, but it's not 100% prognostic of the base level. The larger the tumor, the more calcitonin we'll have, but it's not necessarily representing desmoplasia. So that is why it makes sense to investigate this by frozen section, because we cannot prognosticate preoperatively. And with regards to, I've discussed this in the Scandinavian countries as well, because the pathologists were reluctant to do it. And I think if we have our ultrasound, surgically performed ultrasound, we have the basal calcitonin and CEA levels, and I do not have any other finding in the contralateral lobe. I think it's a good procedure, like in DTC, to offer a patient who has no family history for a hereditary disease to say, well, let's go for a lobectomy, do a diagnostic central lymph node dissection if you want to have more criteria. And if that is negative, you could still go back to the contralateral side in a staged procedure. But this, of course, is a second anesthesia, it's a second surgery. But if you have a patient who wants to keep his thyroid, who does not want to take medication, I think it is an option to offer. So it does not necessarily, in my belief, rely on intraoperative frozen section, although it's much more comfortable for the surgeon, of course.
Last question. Kyriakos, do you think we have to continue being strict with the recommendation of early surgery in patients less than 1 year old? Or now with a good ultrasound and negative levels of calcitonin, we can't wait and...
With the exception of men to be patients, I think that something is changing. We could wait along more measuring calcium levels and making a very good imaging on the thyroid. Yes, we should perform the operations a little bit later. But at this stage, it's not the sure procedure. I think we can do it, but with the knowledge that we have until now, in high-level, high-risk patients with the mutation in codon 634, we should perform the operation until the age of 5. For all the other moderate-risk codons, we should reevaluate the age of the operation.
Perfect. Thank you very much.
I just wanted to say after this part that we can have coffee again, a little break, if you agree.
So, Coffee or let's move? Coffee? Okay, coffee.
Good idea.
Okay, so let's proceed with the last part of our master class. We were quite efficient. It is a pleasure to moderate with Ozer Makey, professor from Izmir, Turkey, and also visiting professor of our Belgrade Medical School, which we are proud to announce here. Recently he gave an admission talk at our medical school, and it was great. We were all there. Today he will talk about neuromonitoring during thyroid cancer surgery and both standard and alternative techniques. So Ozer, it's a pleasure to have you here.
Thank you, Nada. Thank you for having me here, Professor Markovic. Thank you. I'm so honored. We have a friendship dating more than 8 years, I think. And I'm very happy that this friendship had brought me here. I'm really very honored. Thank you so much. I also thank the team of Professor Zivalcevic. I was very honored to be an invited lecturer 2 weeks ago. It was, again, about the same topic, but I have unforgettable memories there as well. So I'm so happy to be back in Belgrade again. I have nothing to declare. It's not easy to talk about nerve monitoring and the alternative techniques, the standards and alternatives in only 20 minutes. I will try to do my best. I can share you the slides. At the end of this talk, you will see my email address. So if you want to have the video or the presentation, feel free to contact me by email. When it was about alternative techniques, I was very excited to have Serbian young surgeons. I think it was an amazing time altogether, scientifically and socially, and we did enjoy ourselves very much. Beyond that, we started to work together, 5 centers. It was about an alternative technique for nerve monitoring. We used a needle electrode, and we reached the best presentation award in Rome, ESAS Rome 2024, which increased our motivation more regarding the use of the needle electrode during thyroid surgery. I was asked to first start with the standards, and I was wondering why, because I could show the empathy that not everybody in the country is using nerve monitoring during thyroid surgery. Possibly it's because of the lack of having no device in the operating room, or the service, or the gadgets. So this is also true for Turkey, but what has changed is those surgeons, possibly it's going to happen here as well. So I'm quite sure that it will be available more than it is today in the upcoming, I don't know, the year or years, because a paper came out on the Turkish platform in our scientific journal of our society, and it was about the nerve palsy issue. And all cases who went to court because of bilateral vocal cord paralysis were accepted as malpractice, not complication. And when you go through that report of the judge, there we see that there is a seek for nerve monitoring use during surgery. So it's of course not 100% protective, and it's not going to steal the role of seeing the nerve, but it's a gadget which I believe should be in the standard care of the thyroid patient who will receive surgery. What do we do? It's actually the EMG of the thyroarytenoid muscle. I try to keep it simple, but why are we so concentrated on nerve monitoring, and why are we insisting on nerve monitoring use? Very honestly, if the device is not working, I seek for another one. If both devices are not working, I'm not doing the surgery. So I keep it that serious, because the more you use, the more you believe in that technology. Is actually not a very complex technology. It's just the wires you use, and you have the box there, which I will show you in a few minutes. So vocal cord paralysis due to RLN injury is still an important complication. Nerve monitoring really helps in the neural mapping, not only for the recurrent nerve, but also for the external branch of the superior laryngeal nerve. We evaluate the nerve functions, we have feedback about the integrity of the nerve. It helps in preventing nerve injury, and it's predictive. The accuracy changes actually, but it's predictive for postoperative vocal cord functions and, of course, voice results. If you go through the internet, I mean, not the PubMed, whatever, if you seek for the systematic reviews about the use of nerve monitoring in thyroid surgery, you really get confused. It's very important to criticize these papers as well. We should not accept them as like verses from the Bible, Quran, or other books. But this is a very nice one. It pools 60 studies, and at the end, it favors the use of intraoperative nerve monitoring. I took, of course, this out because it's just supporting my talk today. But honestly, it's important to criticize as well, even its systematic meta-analysis. So I think we need more, but we have already convinced ourselves with our thousands of cases. So what are actually the cornerstones? This is a new device in the operating room. You do not want to have, as a surgeon, something that annoys your concentration, but for being the master, the chief of the orchestra in the operating room, I think it's very important you to know what you're dealing with. You have to know what an amplitude is, what latency is, what the current is, how you manage the current during surgery, and what's threshold. If you leave it to the technician or to a resident that you appoint for the system, troubleshooting when you have the loss of signal will be really annoying for you because you are the surgeon, you have a loss of signal, you want to figure out whether it's a true loss of signal or a false loss of signal. So as long as you, as the chief of the orchestra there, keep the response, have the responsibility and learn the cornerstones, then it's easier to manage and manipulate. I'm just jumping this one. The setup is easy actually. You have a recording side and a stimulation side. These graphs can be a little bit confusing, but it's really very simple. Anesthesia and you have to be a perfect team. It's a kind of marriage, a strange marriage. You never can divorce your anesthetist because you need him, her. But it's very important, especially if they are shifting in the operating room. They have to know that you do not want that much muscle blocking agent. So this is the dose. But what do I mean with the circulation? What happens, for example, in my operating room, every 5 minutes I see someone else because they are called to somewhere. And when we say the patient is awakened, she or he should definitely know that we do not need another dose of the blocking agent. The proper intubation is very important, so that's what the anesthetist does because we need that contact if we are using the tube electrodes. And with the positioning, with what we are doing during surgery, the manipulations, again, the contact with the vocal cords can be disturbed. That's why the anesthesist should be experienced in correcting maneuvers as well. What is in the standards, what is actually 100% missing everywhere, I'm quite sure. I'm not sure about Germany or Greece, but in Turkey, we did a survey and just 30 to 35% of surgeons did obey these standards. And in general, the V1 and the V2, which is lacking. Don't do nerve monitoring then. That's what we say on our national platform, because if this report is coming to me from the court, and I will report that, no, this is not a proper report because V1 and V2 is missing. And then again, it's a disadvantage for the surgeon who has been accused for recurrent nerve palsy, causing for recurrent nerve palsy. So what we need is preoperative laryngeal examination, pre-resection vagus, recurrent nerve, EBSLN, and the post-resection amplitudes and the latencies. We need to see them, hear them, and also record them and compare them. L2, which is a post-operative laryngeal assessment, if everything is going well, there are clinics who just omit this one, but it's, of course, this can be discussed. So thinking about the non-recurrent nerve as well, you have to know where you have to get the signal from. But in general, when we have the talks, the educations on our national platform, people are afraid from the V1 because they are afraid to open the fascia in between the jugular vein and the common carotid artery. And we said just, increase the current a little bit more. And especially if you use a monopolar one, it's easy to get a signal from the vagus, so you don't have to concern about it. And this is an area where you do your surgery. If you think that you're experienced thyroid surgery, there should not be emitter. So the recurrent nerve, the vagus, and the ABSLN, this external branch of the laryngeal nerve, where it's up to you whether you do an intermittent or continuous. There are very large series about both. But the continuous nerve monitoring needs another electrode. For us in Turkey, it's expensive, so most of us prefer to use the intermittent intraoperative nerve monitoring. What is a presence of a satisfactory EMG? That means the accuracy, that's very important. We desire for a V1 amplitude, which is higher than the 500 microvolt. There are studies which have shown that good negative predictive value is obtained with a final amplitude of 250, higher than 250. No or low response is, what is low? It's below the 100, and with stimulation at 1 or 2 milliampere. But we have to be very, again, in that troubleshooting, be careful. So we start, when we have that loss of signal or that low signal, we start the troubleshooting process. For example, the area should be dry. We should get in contact with the anesthetist if it's a tube electrode. And then think about your maneuvers, what you have done when you had that loss of signal. All these steps have to be taken into account. An absence of laryngeal twitch, that's what you do, and or glottis twitch on ipsilateral vagal stimulation means loss of signal. Troubleshooting is not that complex. I can make it more complexer, but it's just very important. Check the stimulation side, check the recording side, think about your maneuvers, contact with your anesthetist. With the tube electrode, with the tube electrode, the most common false positive signal is because of the tube depositioning. So you need a repositioning. For the needle electrode, for example, that we use, the most common error is generally related to the grounding cable, which goes out from the arm of the patient. So I already told the most common cause of false positive error for tube electrode is endotracheal tube placement. We plot or fascia can obscure the stimulation. Check improper use of the blockage agent. Indicate stimulating power. So check the current as well. In the very beginning, we were very afraid to move from 1 milliampere to 2. But today, we have switched this to 3 and 5. So it's not always 5. It's just for, the mapping, if we need. But 3 is, I think, it's safe because this is what has changed in the last 2-3 years for us. The most significant impact of nerve monitoring is that it is inviting you to stay on one side surgery if you have a real positive loss of signal. So this matters. I told you the legal reason on one side, but on the other side, even it's a cancer surgery, which can also be discussed again, staying at one side when you have that nerve palsy, you may postpone your second completion surgery with checking the nerve function regularly. Most of them are temporarily. Even it's permanent, you can get the support of an ENT surgeon so that you can protect the patient from an acute tracheotomy. The tube electrode is advantages, but there are some disadvantages regarding the replacement, malrotation, ciliary pooling, and it's not easy to reposition always. It requires time, and it may be expensive as well compared to some other alternatives. What are actually the alternatives that are in clinical use are the transcartilage, the percutaneous and the transcutaneous one. We were very impressed by the work of Professor Chiang and his team from Taiwan, and I was very irritated about the price, and I was not allowed to use it anymore in my operating room because my director, he said that it's expensive and you're not allowed to use it. And I said, but this has an impact, a very significant impact on the patient. So there was a negotiation. Since being expensive, I was told that it was expensive, then you start to search for an alternative. And very inspired by Professor Chiang's paper at work and support as well, we started to use the needle electrode as an alternative to tube electrode. We do not increase the length of the incision, just to put the tube electrode perichondrially. So you do not put it in a muscle. It's just in a vascular area. It's perichondrially, just very parallel to the thyroid cartilage. We have learned from our professors first to dissect the pyramidal lobe, so we really go high as the hyoid bone and just clean that area. And here you see how we put the needles. They are not that long, and I advise not to use shorter than 13 millimeters. So these are, I think, they are 70 millimeters, something like that, because they can be detached. This paper increased really our, we were very inspired, but looking to the literature, we found out that there were a lot of experimental studies, so we were very motivated to use it. And after a few years, our paper came out where we compared the tube electrode versus needle electrode, and we were very happy actually from the very beginning, where we had the same latency but with higher amplitudes, which were very satisfactorily. And this is also true for the EBSLN. This is a very recent paper that came out from Izmir as well. But there are possible complications. There are some minor vascular structures. That's why there is a possibility of bleeding, but that's not a problem. So until today, there was no patient suffering from bleeding or needing re-exploration. Intracartilage hematoma, there are reports, but we have never seen them. Puncturing of the tube cuff can happen, and of course, a needle can be broken. And also detaching, being crushed under the retractor, and needle stick are other issues, and especially in an aged patient, the calcified cartilage can really be annoying when you're trying to put the needle there. I already mentioned you that it's compared to the tube electrode, it's cheaper. For me, as long as I have the device, I do buy them even. So it's really, on the Turkish platform, it's really very cheaper, and it's just 2 simple EMG wires that the neurologists use in their own laboratory. This counts also for the electrode and also for the hand probe. I'm not giving you any numbers because the companies are not happy with me with telling you about the prices, but you have the internet, it's on your phone actually. So it's very easy to reach if you want to. And this is also true for devices, but the quality of devices differ. That's why it's very important to criticize them as well. Is it in the guidelines? Yes, I see it in the guideline one, which is the Chinese one. I was very happy to read this because the demand for an alternative technique for intraoperative nerve monitoring also is increasing. The research is going on, and this is something else where we try to improve the quality of the reporting. And this is again a paper from Professor Chiang and his team. And today have been approved by the Eurocrine Council, pooling 17 Eurocrine clinics. We soon will start a study about the feasibility using these transcartilaginous electrodes. I want to learn more, if you say something like that. These are the recommended readings. Please concentrate also on the guidelines, which are available on the internet for free. And to take home, I believe it's improving the quality of the care, as I mentioned. But the gold standard is not replacing the gold standard, so we have to see. It's not an adjunct that's replacing this standard. There are alternatives. It's important to know that. It was helpful for me. Hope it will be helpful for you. The needle electrodes, I believe it's efficient and safe. We have proven it. It's cheap and easy to apply. And please concentrate on the troubleshooting. I welcome you to the to a club. This is the Balkan Black Sea group for thyroid cancer. This started with the collaboration of Turkey and Bulgaria. It's been expanded, and now we have a forum in the World Congress of Thyroid Cancer. It will be our 3rd time next year in Boston, and we all together work in a harmony and with our studies concentrating on geographical differences. If you feel that you will be happy on this platform, we welcome you very much and hope to meet in Boston, but before in Izmir. So what's happening in Izmir next year? It's the EACS conference, where we concentrate on, again, nerve monitoring, ablation, autofluorescence, and robotic use. 4 consensus paper will coming out. So please come and vote as well for these consensus so that you have an impact on the European reporting of innovation. So thank you so much for listening. And here's my mail address if you want to have the presentation. Thank you.
Thank you, Azar, very much for this amazing talk. Would you introduce Yanis?
Yes, with pleasure. And our next presentation is about modern technologies for preservation of parathyroid glands during our thyroid surgery. Professor Yanis Koutelidakis, you're welcome. The floor is yours.
Thank you very much. Late hours, it's a very heavy program, but I think we have done a good work until now. Let me wear my glasses since I'm a bit old. Well, after neuromonitoring, we can see what we have in order to preserve parathyroid, in order to prevent hypoparathyroidism. This is the main point. This is the landmark paper in 2014 in BGS showing, I think they are true, at that time the percentages of transient hypocalcemia, permanent hypocalcemia, and referring that, acknowledging better that rates are more higher, even higher in thyroid cancer and with central neck dissection. It's that position that started the conversation about finding something that can show that can preserve parathyroid glands in the surgical field, at least, or even give us the opportunity to find them in the specimen after the operation. So we have in a way to solve the problem of postoperative hypopara. This is a paper that should be put in the end, but also I put it in the beginning of my presentation because it's not something with very heavy, with high evidence, because it's a narrative review, but it's a review that shows that the technologies that exist in the literature is the autofluorescence and the use of indocyanin green with the help of autofluorescence to identify the parathyroid glands. But the paper that started the conversation was in 2016 after a PhD of PhD doctors about mechanical students of studying mechanic found that there are tissues, live tissues, that they can absorb near infrared light. And this was very important because in 2016 they used they used near infrared machines to give light to surgical field. This was done first by Solorzano and his team in Nashville, Texas, where in 137 patients showed that almost all of the parathyroid glands were successfully identified because they have because they could absorb those infrared near infrared light in order to glow in a dark environment. And how this was achieved? What was the equipment used for it? First, they used an excitation laser, an intense light source of the required wavelength to excite the targeted fluorophore, and they showed that this wavelength was about 800 to 850 nanometers, and they have excitation filter for specific wavelengths in order to absorb the light. Emission filters allows only specific wavelengths for excitation, those wavelengths I just mentioned, and after a detector for emission and collection. What are those? Cameras, spectrographs, photodiodes, and also the software to transmute all the data to a display, to an image, and to have quantification of the image that we get. At first, they used it bulky systems, different machines, the light, the LED, the camera, but now we have commercially available systems. Which are the commercially available systems? That they are FDA approved. There are probe-based devices and the image devices. Some of them you know them, some of them you don't know them yet, or none of us knows them yet. Let's start with those that we don't have experience yet. Those are the devices that they're probe-based. The only device that is FDA approved is PTI. It's a newly devised. It exists, Medtronic presented about 2 or 3 years ago, but now is on the market, and in some countries it is available, but its price is really high. I won't tell the price now because it is too high. But what we have, we have a console with a near infrared light source the one that you see in the picture, and the detector, this probe, this small probe. We have a sterile detachable fiber probe. This is a sterile, the probe that we use in the operation and then we throw it away. And we have a put pedal for starting the near-infrared activation, and then we have the display as you see in the picture. We have an auditory feedback and not a visual feedback, and we have quantitative parameters as you see in this picture, and you see a video afterwards. Of course, we need to create a baseline measurement. We might need to recalibrate the baseline if we see that we don't have the numbers that we expect to have, and it's not affected by the ambient lines. We don't have to close the operating room's light. This video was taken in Rome, in Italy. It was with Marco Raffaelli. You see how he creates in 5 spots of the surgical field before he starts the operation, how he takes the baseline, and now how he detects. You can see. I hope you can see where he puts. You see here. I don't know. You can see. No, you cannot see. But at the probe, at the end of the probe, is the parathyroid that has the elevated signal. And now let's go on with the devices that they are image-based, which are mostly used in daily practice. And I use them too in my department. First of all, we have FDA approval, the FluoBeam, which is a camera of near-infrared light, and in Europe there is another German system, the Maxer, who is also used for this purpose. We have a handheld camera system within a near-infrared light source. We have a console to adjust the near-infrared illumination. We can do it, and it's very helpful. And we have a display panel, as you see in A. In picture A, in picture B, you see the camera, which is a little bit bulky. It cannot reach. We cannot put them in the surgical field. It can arrive until the skin, and you can see how the sutures are shown. We have only grayscale images of the surgical field. We have a hint of how is the surgical field around it, and we have a lower glowing of the thyroid in order to compare with the glowing parathyroid gland, and we see in picture A. The camera is, I told you how near it can be. The picture B is not the most correct one, but we can approach it more in the surgical field, and we can have a better view. Provides a map of the surgical field with parathyroids appearing brighter, but it's not the mapping that we want regarding the mapping that we do in the neuromonitoring, because it does not, if we have a layer underneath the parathyroid, it cannot absorb the light in order to glow, but we can save images and videos for later. But we have other devices that they are not specifically made for autofluorescence. Those machines that you see, those cameras that you see in the slide are those that they are shown in the literature with not very significant results. But there is a camera that I started to use in the beginning, which is not made for autofluorescence. It's the Rubina from the Karl Storz company, which has a very, very accurate wavelength, I have to admit, but the only problem is the handling. The handling, because you have to use the laparoscopic optical, and you need, in order to achieve a better result, better image, you have two hands to hold it, one at the bottom end and one at the upper part of the optical, in order to reach a good image. But the good thing is that this you can arrive at about 2 or 3 millimeters of, or 5 millimeters from the parathyroid gland. this is our setup. You see how it's done. And you can see that we can see in the camera, this is the color image, this is the green, and this is the light, the glowing white in the image of the parathyroid gland. And if we want to compare those two machines, the only difference is that in one we have to close the light, in the other no, but the main difference that is not written in this paper of Solorzano is that with autofluorescence, with image-based machines, sometimes we will get mixed with metastatic lymph nodes. But maybe with the PTI, we might not have this problem because we should, according to our experience of identifying the metastatic lymph nodes, we can take a new baseline in order to be more sure of what we see in the field. And now let's talk about ICG angiography. Indocyanine green is an inert water-soluble organic dye. It's an heterophore, not an autofluorophore. It's an heterophore. Binds mainly to plasma albumin and confines to the vascular compartment. Cleared exclusively through the HPB system. Has a short half-life of 4 minutes most. And we have also a maximum absorption and spectrum of 800 nanometers to 840 nanometers when excited in the near-infrared spectrum. And this is how is the setup. We inject the indocyanine green. We expect 1, 2, or 3 minutes, and then we look to the camera, and then we can have this image. You can see down in the lower image on your right. You can see the parathyroid gland and the vessel that is vascularizes the parathyroid gland. But the main, what is really revolutionary is that paper of Pablo Moreno from Barcelona, who showed us that we can change our strategy. What did he show us, and this is very interesting, is that if we see that parathyroid gland, as you see on your left in the lower image, this parathyroid gland seems viable. And if we start to dissect over this parathyroid gland, the upper part, and we don't know where the vessel is, then we will devascularize the parathyroid gland for sure. But we have a parathyroid gland in the field, but it's not viable. If we do this, you can see, if we inject ICG, you see that we can see the vessel. So we can move up our operation in order to save the vessel of the parathyroid gland. This is our image of parathyroid gland, and you see the vessel here that we can imagine that if we go upper this part, we can save the parathyroid gland. It's really a very good point from this paper. But we have problems. We have advantages, but we have disadvantages. The main advantages is that patients, also Tripones said that a lot of times, patients with one or more well-perfused parathyroid gland with ICG did not develop hypopara. Also, ICG uptake correlated with post-operative parathormone, but grading is usually given visually. It's not it's an objective criteria. First injection gives the clearest image, because if we inject continuously ICG, then all the place will be green at the end. But the problem is that we have few quantitative studies about it. There are teams in Europe that they are trying to do that. But to end, I want to show you something that I found in the literature. There is a review analysis from a Greek, a known Greek team about the carbon nanoparticles. There are papers in the Asia part, China, Korea, And how that works. Thyroid gland is injected with stained nanoparticles. The particles pass in the lymphatic vessels, but not in the blood capillaries. So thyroid lymphatic drainage is stained, and then parathyroids remain unaffected, and you may identify them and save them. In the beginning, they used it in order to identify lymph nodes, not parathyroid. But on the opposite, going that way, they also found, and they said that it helped also to find parathyroid and harvest more lymph nodes. There's some pictures from the papers. You see the stained particles, but here in this endoscopic thyroidectomy, you can see how the color of the parathyroid, which is the normal color according to all the stained, if I believe in it. I'm not sure. I don't know. I never used it. I don't know if it's available. It's only in the Asian countries. I found it in the literature. I wanted to present it just for something else. This is the paper also I put in the beginning that I put in the end. And those conclusions of the paper are the conclusions that I will give you now. Autofluorescence is the leading technology for at least identifying the parathyroid glands. For the use of ICG and autofluoro must be conducted more quantitative studies, but the only stable thing is that we must be aware of anatomy and experience of seeking the parathyroid glands. And with that, I want to thank you for the attention.
Thank you, Yanis, for this amazing talk. Next speaker is the person without whom this masterclass wouldn't be possible, without his support. He will talk about management of complications in thyroid cancer surgery, Professor Ivan Markovic from Institute for Oncology and Radiology of Serbia.
Thank you, Nada. I know you want and you did deserve to say thank you for organize this and call all these dear people and experts for at the end, I'm afraid to probably spoil those two very stimulating lectures for the new ideas how to prevent. This is what I'm going to talk about, and this are the complications in thyroid cancer surgery. I think most of today's session was talking about the complications and how probably at the first place to prevent them and not to have them. And as a matter of fact, at the half of the 19th century in Philadelphia, I think George showed this slide, this photo at the beginning, and he obviously said that the honest and sensible surgeon would ever engage in thyroid surgery. At the same time, at the other side of the Atlantic, the French Medical Academy prohibited the thyroid surgery because they believed to be one of the most dangerous operations. Still, just a few hundred kilometers in the near in Switzerland, Emil Theodor Kocher did his work about thyroid glands, and you can see even at that time there is a hospital register that said that with precise Kocher technique and using the Lister's wound bandaging methods, the mortality was significantly diminished, and from almost 75% by the end of 1912, Kocher achieved that complication and mortality of thyroid surgery was less than 1%. Of course, as we all know, at 1909 he was awarded with the Nobel Prize for his work. On the other side of the Atlantic again, William Stewart Halstead said that extirpation of thyroid gland typifies perhaps better than any operation the supreme triumph of surgeon's art. At the old age of both of them, they met, and Halstead was watching Theodor Kocher doing the operation in 70 years of old with the gloves he brought to him. So, what are the objectives of surgery? For the first time in thyroid cancer is to eradicate primary disease, to adequate stage the lymph node status, either performing routine or prophylactic neck dissections, to reduce the incidence of local regional relapse, enable accurate thyroglobulin monitoring, as well as calcitonin in medullary thyroid cancer, to optimize the decision of using adjuvant radioiodine treatment, and of course to cure maximum number of patients with minimum morbidity. And what about the post-operative complications? They are rather infrequent in the experienced hands, and we are talking about this master class as the volume of a surgeon itself. So there are different pitfalls which can get to probably to complications in the thyroid surgery and thyroid cancer, especially. It is of course the extent of the disease or extent of the surgery, reoperative surgery, especially extrathyroid extension. Then we talked about central neck and lateral neck dissections. Then what about the upper mediastinal lymph nodes, especially spared in and affected in advanced medullary thyroid cancer? Then reoperation for hematoma, and of course, again and again, less experienced surgeon. This is, I should say, the table of major and minor thyroid surgery complications. Of course, we cannot agree about what is major and minor, but I used the Ashok Shah presentation to start with this. So our team with late Professor Jodic gives some complications and some contribution to this evidence-based endocrine surgery book. So for the first, we want to prevent bleeding. So the close capsular preparation of upper thyroid blood vessels is mandatory. Why? Because you can do it separately, artery or vein. So for the first, the upper one, the posterior branch of upper thyroid artery we are leaving for the end, because obviously and most frequently it is the vascularization for the upper parathyroid is coming from there. So of course the same procedure should be done at the lower pole, separate ligation, and the most important to do it very, very close to capsule. And of course the lymph, the vessels, blood vessels in the varus ligament parallelly to recurrent laryngeal nerve should be ligated. These are the main points of potential bleeding in thyroid surgery, especially in varus ligament, when the unexperienced surgeons start to try to stop bleeding, usually ligate the nerve itself. So when we are talking about the superior thyroid vessels, we came to the prevention of superior laryngeal nerve injury. The colleagues showed how to do, and of course, when we have neuromonitoring And this is just this sternothyrolaryngeal triangle of jewels. And the important thing to repeat that we should ligate those vessels close to the upper pole. Some points where we have to find the laryngeal nerve is, of course, the inferior thyroid artery and the nerve crossing. Of course, it could be done if we cannot find it here, closer to the lower pole or closer to the larynx. So it's extremely important when we do have monitoring or do not to visualize the nerve, because we have to be very careful and make a preparation of nerve, taking into account that the nerves are very often they have two or more branches. They have other branches for esophagus, so it is extremely important to be seen. At the same time, by doing technique like this, you are going to find and to ligate the branches for parathyroids. So when you are talking about coloring of the lobe, you probably know that we do and publish some papers about sentinel lymph nodes. So this is one of the situations. So the lobe is blue, and we also have published that we have blue the lymph nodes in the central and lateral compartment, but parathyroid glands were never colored with this technique. So one of the very rare potential complication because of the rare anatomy is the anatomical variation of non-recurrent laryngeal nerve, mostly on the right side, and it has been reported up to 1% of the population on the right side. It is extremely important when you cannot find the nerve and then at its regular place, you must think about non-recurrent laryngeal nerve and take a special attention in this situation. But thyroid cancer surgery can be only the tip of an iceberg, and the good preoperative diagnostics and clinical examination is of crucial importance to know or to decide whether or how we can go into the surgery. So it is when there is a bulk of metastasis in the lateral and central compartment, especially when we are talking about potential infiltration on jugular vein, on the carotid artery, even vagus. We must prevent bleeding in a proper manner. So on the lower photos, you can see here the case of medullary thyroid cancer. I just in the post discussed about that. This is the second operation with sternotomy and doing the upper mediastinum and the right and pretracheal side. And 1 month before that, we did it on the left, but we have the complication about Hillow's leakage, and fortunately it stopped and we could do the operation in the second act. So when we are talking about medullary thyroid cancer, I couldn't agree more with my colleagues that the surgery is probably the only way of complete healing. So this is one of the situations when we have the vagus infiltration, and we didn't get the signal on vagus. So that could be the situations that we stop the surgery and leave it for the one side, as was discussed before. So after recovery or after control to the ENT, we could do the second act of the operation. This is one of 3 cases of mine doing this ARA reconstruction with ansatz cervicalis because of the nerve resection due to complete infiltration. Nada explained already and answer to Ozar that we have only lenses, the loops, and it was at the beginning try to see if it works. Fortunately, this young woman it works, and after 2 months she completely recovered, even phonation time, and this is also an example of I should say suspecting infiltration of the laryngeal nerve, but if we, when we did a good exposure, we saw that it is not 360% infiltrated. So we tried the partial layer resection, and at the end, of course, there is no immediately recovery, but this obviously in this case the nerve was not infiltrated in its functional branches. And I will finish soon. This is the way how to preparate and ligate sometimes separately artery and vein, draining and vascularization. I'm tired a little bit. Vascularization of parathyroids. So what are the main pitfalls that we could damage its capsule, its vascularization? We can remove it by accident, and especially we could have to think when we are doing a completion of thyroidectomy, because we don't know what some other colleague or me did on the opposite side. So this is also a technique of our late Professor Jodic, who was insisted to separate ligation of artery and vein and he published that due to venous infarct of parathyroid glands. Generally, we should look for every parathyroid gland and do it as it is the only one. And this is my attempt to stop the Hill's leakage. Of course, if you discover during the operation proper technique, there is not a lot of experience, but you should try to repair this hole on the to thoracic blunt, so cover with the surrounding tissue if it is possible, or if we recognize later probably conservative techniques, and I think that usually it stopped at some time. And I'm finishing with this. These are very interesting slides with a few papers which are oriented on how to quantify the surgeon's experience. We are coming to a beginning, and it is the mathematics is quite clear. So you can see that about 3% of potential complication are expected in surgeons doing 21 to 25 cases yearly. So it's someone made the approximation that more than 25 is something that we could say that it is enough safe for the patient. The similar paper, which is taking into account that 50 or more thyroidectomies per year per surgeon means that he is an experienced surgeon with very, very low percentage of complications. And to finish this master class, this is a very valuable paper and statement of the European Society of Endocrine Surgeons, the position of the organization. I am not threatening. Don't want to make the fear in young surgeons, but in the institutions of high volume, with the good mentors, with enough number of assistants and operations, you will become experienced surgeons. So thank you for the attention.
Okay, thank you so much. And we are approaching the finish line, finally. Are there any questions from the floor? Yes, everybody, I think it's very tired. Okay, I can hand over the microphone to you if you have any questions. Any questions or comments? Yes.
For the panelists, okay.
Well, maybe from your experience or early experience, just the two of you, what is your indication for neuromonitoring? Do you use it on standard basis in every case, or do you do it selectively? And if you have the less expensive version, would you do intermittent or continuous in selective or standard cases? You mentioned standard procedures.
Yeah, that's so. Let's go again. If it's not there, I'm not doing the operation. So, since even being experienced with using it more and more, you really get affected to it because you see a lot of things. It's not only the complicated case. That's why you really do want to have it also for the regular thyroidectomy. So that's why it's there for every case. Intermittent or continuous, I was very a supporter of continuous nerve monitoring in the very beginning, but the continuous probe is expensive and I could not get it anymore. That's why if I have it, I reserve it for the complicated cases. But in general, in my in a routine, it's the intermittent use of the nerve monitoring.
So it's an excellent teaching tool as well.
Yes.
If I get you.
I was going to say that I use it also in all my cases. And I try to use more the continuous, and also it's a matter of cost. But from time to time, I think we will solve also this in the future. But the main thing is teaching. It's teaching. It's how easily you can teach a young resident how to find the nerve. Because there is a very good, a perfect way to do that mapping. And if you know the anatomy, since the mentor, the teacher knows the anatomy, he can guide or she can guide the resident where to search the nerve. And it's amazing how they are surprised when they, by themselves, find the nerve at the end, and they see that it's not so difficult finally, but it's something that they have to know the anatomy and use these instruments and find the nerve. If they preserve it, if we preserve it, is another question, is another problem.
I think it can also help refine our technique, because if you use intermittent, you observe how much any move you make in the neck actually affects the nerve function. But when you use the continuous one, as Kerstin told me, she usually uses continuous all the time. So you can imagine how many little discrepancies on the monitor you observe while mobilizing the larynx, while pulling too hard the lobe. So this kind of can provide another, as you said, educational moment to soften the technique, to more lessen it, to be more refined. Yeah.
But we are not in the position to. We can only imagine. We have the problem about the financing. We are completely socially public health insurance. So there is always a fight for some maybe more important things but we are doing it. We go through the neuromonitoring course with Professor Triponet. They send us, and we are using, but in situations which are somehow advanced, or big goiters or something, or for the reoperations. I think that there is about, I should say, 70 tubes and complets that we could use for a year. So this, could we hear the price of these alternative electrodes or something? Because we are trying a way to find the way to do it more frequently.
It is available at AliExpress. Huh?
Okay, I'm not going to tell.
I think yes.
I think yes.
He's Uzama Kai, as a scientist and clinician, he's not the merchant today. Yannis, same for the fluorescence or ICG. What's your estimation? Do you recommend to use it on a regular basis? Is it just something you would use for teaching, or what do you estimate this technology will develop to?
I followed in a lesson from Peter Angelos. I think you know who is Peter Angelos, who is not a well-known endocrine surgeon in the States, but it's also a well-known professor of ethics in the States. And I heard one of his lectures in an American college college meeting, saying that if someone uses an instrument for a purpose, it has to use it in all his patients. How to choose who patient is available for this, to use this instrument, and the other patient who has the same pathological condition not to use it? It's a question he made, and I think nobody can answer it from an ethical way. So if we want to use an instrument in a patient and we can afford it, we have to put that in the discussion. I think we have to use it in all of our patients. So when I started to use the autofluorescence, at first I started to use the Rubina cam. Why? Because in my department we have the tower of Karl Storz with the Rubina. So when the laparoscopists didn't use it, I could use it, or I programmed my operations when they didn't have laparoscopic operations in order to use this tower, which is totally free. If the institute has bought it, it's totally free to use it in my patients. But when I started to use Fluobeam, which is not really so expensive in Greece, I used it because, and I'm using it now in all my cases, because it's a machine made only for this purpose. So I think it's more accurate with the wavelength and the coloring choose that you have and the intention of the light that you give with this camera. So it's more accurate regarding the other cameras. The other cameras have the advantage that you can see in a very clear way if they are 4K, and you can see the environment that you operate, and you can zoom in the environment maybe. But regarding the parathyroid glands, Fluobeam is more accurate in finding them, but I use it also from now on in all my cases.
Thank you. The reason why we have endocrinologists in the panel is because when surgeons mess up and make a complication, we need you, right? What about the hypoparathyroidism, transient and permanent? What are the protocols that you apply in the practice?
We're lucky that we're very good surgeons, so there are a very small number, but still there are. So what we did, we use vitamin D analogs, either 1 or 125 hydroxy vitamin D plus calcium. Generally, the hypoparathyroidism is a bit difficult to treat, but still it's manageable. We have several pregnancies in hypoparathyroid females, and outcome of all these pregnancies was very good. So yes, we have them, and I think they vary. Sometimes they go to even hypercalcemic, and you need to follow them really well. But actually, it's manageable.
And what is the amount of calcium that you give? Because some endocrinologists start with really high doses.
No, you don't need a very high dose. If you do proper doses of vitamin E analog, then you don't need to go more than 3 grams, 2 grams. It would be more than enough, in my opinion. Sometimes, but it's rarely that you need to give more than 3 grams calcium.
Mm-hmm.
And then you need to talk with the patient, because most popular calcium is calcium carbonate, but it is a bit unpleasant for the patient. But you can change it. Just try other. Then you can, don't take calcium with food. Otherwise, you will make more situation calcium oxalate that you're not going to absorb, and some other things. So with some instructions, it's going nice. But sometimes it's really rarely, we cannot always get the calcium levels that we really want. They're always slightly hypocalcemic, most of our patients. But if we give them 125, that's much better. Mm-hmm. 125 vitamin D is much better than any other, and then we have much better compliance and calcium levels.
Just a short question for surgeons. Do you routinely administer, regardless of the PTH and calcium levels postoperatively, do you routinely administer substitution, like support after the surgery of calcium, tablets or intravenously, or not?
No, not routinely. Only if there is problems with the calcium. If there is problem with the parathormone at first, if there is problem with the parathormone, even with normal calcium, I give substitution.
When are you doing parathormone?
Yes, what's the measurement?
6 hours after the operation. 6 after the operation, and the last one the day after.
Mm-hmm.
But if yes, I decide according to the calcium of 1 day after, what to do with the patient, to keep it 1 more day, 2 more days. We don't know then how many days we will keep the patient. but it depends on the calcium. But if I have low parathormone the first 6 hours, I start calcium even if the calcium is normal. And the problem is that, calcium never falls the first 6 hours. Calcium starts falling after not even 12, maybe after 18 or 24 hours. That is the problem with that condition.
Number one, we do PTH at skin closure, and whenever PTH at skin closure is below normal levels, we'll start immediately with calcium and vitamin D, and we'll keep them on for a week and then have follow-up.
Otherwise not. And you, Azar?
I checked the next morning, PTH and calcium, no symptoms, calcium higher than 8.5 milligram deciliter, PTH higher than 10. So no parenteral infusion, whatever, but they receive calcium and vitamin D as oral supplementation for a week. But if there are symptoms or PTH is below the 10, calcium is low, then the patient receives parenteral treatment. Kyriakos.
Yes, clearly yes. If I have to give vitamin D and parathormone and calcium, I give also magnesium. Yes.
We always do in symptomatic patients. Patients that are not symptomatic, we don't.
We are starting now a randomized prospective study with placebo double-blind patients after the surgery. We will receive 3 days before and 1 week after the surgery. Magnesium.
Kyriakos, closer.
Call closer the mic.
It doesn't work.
We give 3 days. We give 3 days before the surgery magnesium in all patients, and 7 days after, 10 days, 3 days before, 7 days after. We have a post-operative hypocalcemia in about 30% of the patients. And we will see in these 30% of the patients if the group that receives magnesium has milder symptoms of hypocalcemia compared to the group which didn't receive magnesium. It will be a prospective, randomized, double-blinded study, and I believe that in 1 year we will have 1.5. We will have results. There is the hypothesis that the lack of magnesium creates a functional hypoparathyroidism, and this is that we want to check.
Great.
And it was very difficult to take the permission from the Pharmaceutical Organization of Greece. It is created now a European Medical Association. We have to apply there and then go back to the national organization to take the final permission, because it is supposed to be a study of we give something to the patients. Interventional study. Thank you very much. Interventional study. Although we give just magnesium, everyone takes it. It is free from the pharmacy. And we had to pay a lot of money to
yes,
take the, and
it is, I'm sorry, yes. It is logical to give, because hypomagnesemia causes resistance to PTH and actually causes hypocalcemia. Now, the other thing is, do the patient have hypomagnesemia, or whether high level of magnesium will improve? That's something that you're going to, your study is going to answer, I believe.
You are definitely right, but there is no clinical study that proves it until now.
Kyriakos, could you please close the master class?
What I could say, thank you very much that, for all of you that you are still here after this marathon. We are very lucky to be here in this very beautiful city, and we will have the opportunity tomorrow to see this city better.
The rest of it.
The rest. Thank you very much.